raised concern for a reverse J-shaped relationship between exercise dose and cardiovascular death health. So, with diminishing cardiovascular benefit, potential harm in life-enduring athletes. So, moderate activity, as we always tell to our patients or people in general, that is a very good strategy. And this is the most recent study which was published in a journal and was on Medscape actually on 19th of July, and it shows that gut and oral flora is linked to subclinical coronary artery disease and inflammation. So inflammation by different areas, by different risk factors, by infections, by other things, it is playing an important role in the cardiovascular disease. Thank you very much.
Thank you, Dr. Akhtar Bandisha from the PIMS. And we will be proceed to our next session. Our experts are sitting here around with us. No question? And,
Assalamu alaikum. My question to the panel is that since हमने देखा there is so much of rise in cardiovascular diseases, chronic kidney diseases, so I don't think so कि funding as such आपको इतनी available होती होगी. तो as health professionals मतलब इतनी ज़्यादा on the rise के लिए what have you decided? Have you decided anything कि आप public के लिए what will you be able to help? How will you going to able to help them?
I think बड़ा अच्छा सवाल किया आपने. असल में हमारा नशिस्तन गुफ्तन बर्खास्तन हमारा कल्चर रहा है. तो इस दफ़ा हमें पूरी उम्मीद है डॉक्टर रशीद प्रोफेसर मंसूर ने ही हैज़ गैदर्ड ऑल कंसर्न पीपल कि एट द एंड ऑफ द कॉन्फ्रेंस ये प्रैक्टिकल स्टेप्स बताएंगे पब्लिक को कि किस तरह इन चीज़ों की. अब इसमें बहुत सारे प्रॉब्लम है. एक तो हेल्थ एजुकेशन है, वो स्कूलों से शुरू होनी चाहिए. अभी अमेरिकन हार्ट एसोसिएशन ने स्कूलों में एडोलेसेंट हेल्थ पे प्रोग्राम शुरू किया हुआ है. वो कोविड की वजह से वो रुक गया था, लेकिन उनकी फिर भी ये फाइंडिंग थी, ट्रेंड था कि जो हेल्थी बच्चे रहते हैं उनमें हार्ट डिजीज़ कम होती है. तो एक तो स्कूल में, दूसरा एक्सरसाइज की यहाँ सहूलतें कैसी हैं. लोगों को चाहिए, अभी उन्होंने ये कह दिया 10 मिनट्स भी वॉक कर लेना, एनी एक्टिविटी इज़ बेटर. तो लोगों को एक्टिव होना चाहिए. मैंने देखा फर्स्ट फ्लोर चढ़ने के भी लोग लिफ्ट यूज़ करते हैं. यंग लोग, स्टूडेंट्स हमारे, मैं हमेशा उनको कहता हूँ कम से कम सीढ़ियाँ तो यूज़ करें. और जो फीमेल स्टूडेंट्स हैं उनको मैं बोलूँ आपको और भी एडवांटेजेस हैं अगर आप एक्सरसाइज करें तो ये एक तो हमें पब्लिक अवेयरनेस बढ़ानी है. दूसरा जो हमारे यहाँ सबसे बड़ी चीज़ है जो डॉक्टर अख्तर मंगेश ने हेल्थ इनिक्विटी. गरीब आदमी के लिए सहूलतें कम हैं, बट वी आर वेरी लकी इन कराची. NICVD ने एक ग्रेट एग्जाम्पल सेट की है. न सिर्फ उन्होंने फ्री ट्रीटमेंट हाई क्वालिटी का प्रोवाइड किया है, बल्कि रूरल एरियाज़ में भी, ये मैं दूसरी सोसाइटीज़ को भी बोलता हूँ कि वो भी इसी तरह अपने सेंटर बताएं. जिस तरह NICVD किया ना, ये हमारा मसला हल हो जाएगा. क्योंकि कंसल्टेंट रूरल एरिया में परमानेंटली तो नहीं रह सकते. जो इन्होंने मॉडल दिया है ये एक्सलेंट मॉडल है. जावेद सयाल साहब तो बैठे हैं, नदीम कमर साहब, मेरी तरफ से मुबारकबाद है उनको. तो एक तो हमारे यहाँ सहूलतें, दूसरा सिर्फ 80% जो हेल्थ है ना वो नॉन डॉक्टर की वजह से है. साफ़ पानी, सीवरेज का बेहतर इंतज़ाम, न्यूट्रिशन अच्छी, हाउसिंग, इसकी तरफ तो हम गए ही नहीं. तो ये सारे फैक्टर्स हैं. लेकिन मैं उम्मीद ये करता हूँ कि हमारी जो मेडिकल एसोसिएशन है ना वो प्रिवेंशन की तरफ जाएगी. अभी तक सिर्फ उन्होंने ट्रीटमेंट फैसिलिटीज़ बढ़ाने को किया हुआ है. दे हैव डन गुड जॉब एजुकेशन में. लेकिन अब मुझे उम्मीद है कि सारी सोसाइटियाँ मिलके प्रिवेंशन पे जोर देंगे, सोशल मीडिया का यूज़ बढ़ाएंगे, क्योंकि इलेक्ट्रॉनिक मीडिया और अखबार हमारे कब्जे में नहीं है. वो तो इश्तिहार पर उनका मुनसर है, वो हमारी एक्टिविटीज़ को नहीं प्रोमिनेंट करेंगे, बट सोशल मीडिया फ्री है, उसमें आप ज़रूर यूज़ ज़्यादा करें। और उसमें हमें कोई टेक्निकल बंदा चाहिए हमारी सोसाइटीज़ को जो सही इन्फॉर्मेशन दे। मिस इन्फॉर्मेशन आजकल सबसे बड़ा प्रॉब्लम मिस इन्फॉर्मेशन है, उसको भी चेक करना है। थैंक यू।
हमारे पास फिरोज़ मेमन साहब हैं, एस्पेरेंट फाउंडेशन के प्रेसिडेंट और हाइपरटेंशन लीग के। आप इस पे कुछ कमेंट करेंगे प्लीज़? और इसके बाद हमारे पास प्रेसिडेंट कार्डियक सोसाइटी भी हैं, तो वो भी इससे भी कमेंट लेंगे। द क्विक।
थैंक यू सर। सर बेसिकली मेरी टॉक इस पे थी कि वी मस्ट क्रिएट अ मास अवेयरनेस प्रोग्राम in the society, involving schools, colleges, students, parents, teachers, and should be mass level, as we should use social media as well. We should involve our general practitioners. There should be we have got a very wide gap between the consultants and general practitioners. General practitioners refer the patient, consult, treat the patient. We do not have time to concentrate on preventive measures to tell people what to do. And if we create this awareness among our students in the school age, as what Vara Sahab is suggesting, I think we are going to get a lot of benefit on it. Instead of talking, just abhi maine talk mein kaha tha, if we look at preventive measures, we are using only 9% people are using aspirin and 2% people are using statins, which is a major preventive drugs in the society. So we are not putting in enough efforts on prevention. We are just going on treatment. I think we should go back on prevention, have such meetings more and more to involve institutions, involve students, and in our curriculum, we should have preventive chapters separately introduced.
Thank you, Memon Saab. And the short comments from Professor Ishtiaq Rasool and also Dr. Javed Akbar Sahab.
Instead of giving my comments, I will ask two short questions, if you will allow me. One from the Professor Kazmi. You had a very good presentation, and I liked it very much. Your data, that is association of CKD and the LVH, and the role of LVH we all know in the cardiovascular disease. So you gave the data about the creatinine level and about the creatinine clearance, but what is the hemoglobin level which we should start treating with hemopoietin?
जी मैंने नेशनल किडनी फाउंडेशन की डेफिनेशन आपको दी कि वो डिफाइन करते हैं कि CKD पेशेंट्स को जो है आइडियली दे शुड हैव अ हीमोग्लोबिन बिटवीन 11 and 12। अच्छा, हम लोग सिंपल टेस्ट लाइक CBC हम लोग इतनी ध्यान नहीं देते, हालांकि मैं यही पॉइंट हाईलाइट करना चाह रहा था कि एनेमिक पेशेंट्स होते हैं 7, 8, 9 ग्राम, और हम उनको नोटिस नहीं करते, चलने देते हैं विदाउट रियलाइजिंग द फैक्ट कि दीज हीमोग्लोबिन लेवल्स, सब ऑप्टिमल हीमोग्लोबिन लेवल्स आर अल्टीमेटली गोइंग टू रिजल्ट इन समथिंग वेरी सीरियस लाइक लेफ्ट वेंट्रिकल हाइपरट्रोफी। तो आइडियली यही है कि वी शुड ट्राई एंड कीप आवर हीमोग्लोबिन लेवल्स बिटवीन 11 and 12 ग्राम इन CKD पेशेंट टू प्रिवेंट कार्डियोवास्कुलर कॉम्प्लिकेशन।
Thank you.
हीमोग्लोबिन की वजह अगर हेमाटोक्रिट के हवाले से हो जाए,
हमारे यहाँ लोग हीमोग्लोबिन को ज़्यादा
And no,
एक्सक्यूज मी सर, अगर
short comment from Dr.
सर अगर
Javed Akbar
हेमोग्लोबिन
Sahab.
कम होता है तो
We
फिर
are
क्या
ready.
करना चाहिए?
We are short of time,
हेमोग्लोबिन
please.
कम होता है, हेमोग्लोबिन कम हो जाता है तो फिर इसके क्या मतलब रीज़न क्या होते हैं और क्या करना चाहिए ट्रीटमेंट इसका? फिर
कम होता है। देखिए ना, हीमोग्लोबिन अगर मैंने बताया था कि CKD पेशेंट्स में हीमोग्लोबिन कम होने के क्या कॉजेज हैं। मेनली जो है एरिथ्रोपोइटिन डेफिशिएंसी है, आयरन डेफिशिएंसी है। पहले तो हमें लेवल्स पता होने चाहिए कि क्या होने चाहिए नेशनल किडनी। तो अगर इसीलिए यही मैं कहना चाह रहा हूँ, तो हमें एरिथ्रोपोइटिन यूज़ करना चाहिए। CKD मतलब हमारे जहन में यह है कि शायद एरिथ्रोपोइटिन यूज़ करना चाहिए सिर्फ डायलिसिस पेशेंट में। यही मेरी टॉक
Dr. Waqar, we are short of time, please. If you
तो बहुत सवाल आया था तो मुझे मैं जवाब दे रहा हूँ, अदरवाइज थैंक यू वेरी मच।
Thank you. Thank you very much.
कर लीजिएगा मुझसे।
Dr. Javed Akbar sir for a few
I am ready to talk because repeatedly intubation, Probably next is the inauguration session, and we are going to speak on prevention a lot more in that session. So I think this is time to conclude this session. And
Before conclusion, yes, it's the time for the sheet distribution. May I request to Professor Wara Saab to present the sheet to presenter in short time. Sheet.
हम दे देते हैं ऐसे बताओ
Yes. जावेद साहब
2-4 मिनट आप मुझे दे देंगे कंक्लूड करने के लिए? हाँ, तो मैं भी थैंक यू कर दूँ, थोड़ा सब कुछ बोल दूँ। अच्छा, एक शुक्रिया तो we on behalf of the panel of Chief Presidential, we want to express thanks to the organizers for giving us the honor and talk about a very important topic. और जो स्पीकर थे उनका शुक्रिया अदा करना चाहती हूँ।
Thank you. Please. अच्छा, नहीं अभी इजाज़ वारा साहब, please for the sheet distribution. We just start. मौजूद है सेशन में, आ जाओ। The sheet. And the first receiver speaker is Professor Memon Saab. To please receive sheet. Feroz Memon Saab.
हम भी आ जाते हैं।
Next is the next is Dr. Waris Khidwai. Please come and challenge. And the next is Dr. Kalimullah Sheikh to receive this. नाम को बाद में कर लेंगे, उसको बोल दे दे रहे हैं।
किसी की भी दे तो बाद में चेंज कर।
सर आपको सपोर्ट वो नहीं है, आप इसको जल्दी
तो वो आ जाए ना, सपोर्ट नहीं है ना। अब वो नाम देख रहे हैं, नाम ना दे के बोलो बस दे दो।
नाम बाद में देंगे। अच्छा उधर एक ही शील्ड दे दो, अरे एक शील्ड दे दे, बस ये यही रहेगी, सबकी तस्वीरें इसी से निकलेंगी। नाम बोल
ठीक है, नाम की क्या जरूरत है,
नाम बोलते हैं।
And the next is to receive a sheet is Professor Waqar Kazmi sir. And the next is Professor Javed Akbar Sial to receive the sheet. Javed Akbar Sial. And the next to receive is Professor Ishtiaq Rasool to receive a sheet. And that's okay. And this session is concluding, and we will invite to Colonel Bakar to please come as a moderator for the next inauguration session. Colonel Bakar.
कुर्सियाँ इधर रखवा दो भाई, नहीं आप आ जाए।
आप अपना वो करें।
शारिक क्या कर रहे हो, कुर्सियाँ इधर रखवा लो सेंटर में। आप खुद कर लो पहले से इधर एक उधर रखनी पड़ेगी तुम्हें। जी सर, स्टेज पे किसी को बुलाना है? स्टेज पे अभी तो नहीं बुलाना ना किसी को, बस सब स्पीचेस ही करवानी है जी। बस अभी बिठाना तो नहीं है ना किसी को, स्टेज
बिठाना है ना, उठा बुला के सबको
सबसे
पहले आप
उसके बाद फिर स्पीच
इनसे कई दिन जो है ऊपर आ ही जाएंगे। प्लीज एवरीवन सिट डाउन। I would request Professor Mansoor Ahmed, Professor Javed Sayal to please come on the stage, Professor Hussain Mehdi, Professor Bilal Mohyuddin, Professor Ijaz Vohra, Professor Abdul Rashid Khan and Professor Masood Hamid Khan to kindly come on the stage. जी
डॉक्टर भी नाम दिया है।
बंद करवा दें।
डॉक्टर का नाम दिया है।
Shahamat, please close the multimedia. एक बार सर मैं चेयर के पास I'll request everyone to please sit down, take their seats. नहीं नथिंग, मैं जब तो मीडिया वाले आ गए ना। ऊपर वाली जो है इसके ऊपर वो बेहतर है।
Asama. Claro, pele que deja ver. Poni की वजह वो पहुंच रहे हैं सर बंदा ये 500 का सेट टैक्सी भी है सही है ये तो नहीं लग गया था हमारे नहीं मैं नहीं कहता हूँ कुछ टेंशन कर रहे थे
I would request all to please kindly be seated. We will continue our program now. Ji. Can you please go at the back?
Dr. Mansoor.
Please be seated. Assalamu alaikum. I am Colonel Bakar Nawab, Head of Administration at Medicare Cardiac and General Hospital. It is indeed a pleasure for Medicare Cardiac and General Hospital to organize and host the National Congress of Preventive Cardiology at its premises. We, being a tertiary care teaching hospital, always encourage to have seminars, conferences and workshops at our premises. And keeping in line with prevention, last month, Medicare Cardiac and General Hospital was declared tobacco smoke-free zone by the Deputy Commissioner's Office East in collaboration with Sindh Healthcare Commission. We will begin our proceedings. I'll request Professor Mansoor Ahmed, Head of Cardiology at Medicare Cardiac and General Hospital, to please kindly come on stage and give the welcome address. Professor Mansoor Ahmed.
Thank you very much. I'm very grateful to all of you. Many of our colleagues have already left after delivering their talks because everybody is busy in medical profession. A very brief about this Congress, which we call National Congress of Preventive Cardiology. Iski brief history is that myself and Professor Rashid have been together for many years, and we started it many years ago. And for some reason, it came to a halt some 16 years ago. So now we are team again, and we decided to restart this. Prevention is the most important thing as far as we are concerned in cardiovascular disease. We have already heard many talks on it, and we know that preventive measures are effective. All we need to do is create awareness and help people understand how to implement those measures that will prevent heart disease. Developed world have proved that heart diseases, the increment has stopped, they have plateaued, or they have started to go down using these preventive measures. And we need to learn and adopt those preventive measures. And I'm very grateful to Medicare Cardiac and General Hospital and Sohail University to have allowed us to develop a heart center over here, which is already in an advanced stage with all the invasive facilities that needs, and there are certain gadgetries that we need to have which are being delayed because of, as you know, the import problems and the currency issues these days, and we hope that those will be available very soon. But we are performing all the non-invasive and invasive techniques in this hospital already. And I welcome all the faculty, participants, and I can see Professor Masood Hamid Saab here, former Vice Chancellor of Dow University. Professor Feroz Mehman is Vice Chancellor of Indus University. And of course, there are so many others, my colleagues from all the institutions of Karachi. And I'm very grateful to Secretary Cardiac Society, who has flown from Lahore to attend this meeting only. He has no other, if you want to talk to him, you can talk to him now, otherwise he'll fly out. And he talks very well. And I'm very grateful to Professor Ijaz Vora, our very senior colleagues who have agreed to be the chief guest here, because we have always had our own professional colleagues senior to us who have served the community so well over the years. And I'm so grateful. Professor Ijaz Vora have mentored hundreds of students, undergraduates as well as postgraduates. And we have Professor Hassan Mehdi Saab, Vice Chancellor of Suhail University, and of course President of Cardiac Society, Javed Akbar Saab. So I'm so grateful. All of you are here, and I'm yet to find somebody who declined to come. There are many who had some already some engagements who have not been able to come, but most of the people have already been here, and they will be coming later on in the afternoon. So I welcome you all to this meeting, and we hope that this meeting will continue annually as we did in the past. And of course, we will continue to have support from all our colleagues and faculties across the country. Thank you very much.
I would now request Professor Javed Sayal, President Pakistan Cardiac Society, to kindly come on the dais and say a few words.
Thank you very much, organizers and Medicare, especially Professor Mansoor Ahmed and Professor Abdul Rashid Khan. And I'm very happy to see that a lot of involvement, enthusiasm, and participation in this preventive conference, because majority the faces I'm looking cardiologists, they are always busy in interventional cardiology or electrophysiology, but they have keen interest. And Professor Mansoor Ahmed is my teacher, and he is very busy and excellent interventional cardiologist, and I am happy that he has taken this initiative. But he has resumed this initiative because, as he said in speech, that this conference he was doing for many years. And being a president of Pakistan Cardiac Society, we have a Prevention Council in Pakistan Cardiac Society who is being chaired by renowned cardiologist Professor Khawar Kazmi. And he is supposed to come here as well, and he is also working on that. We all agreed on this, that prevention is better than cure. It's a historic saying, or old saying. And in press talk, while we were talking to different media anchor person and different journalists, we all emphasizing, and they are asking questions regarding prevention. Nobody want to put a stent in artery if these arteries are clean. So we have to work on prevention. As a continuation of that, Pakistan Cardiac Society has taken a step, and last month we have an inter-society dialogue where we initially involved 6-7 major societies which are associated with the cardiometabolic issues, like Pakistan Society of Internal Medicine, Endocrinology, Stroke Society, Neurology. So we are working on that, and we are planning that kind of big conference on prevention maybe next year, and definitely Professor Mansoor will be part of that, because this is a responsibility, basic responsibility of society to educate healthcare professionals and to educate general population that how we can prevent this issue. And as our worthy chairperson already told us that this prevention is not medical only. This started from our houses and a lot of other things. Before patient comes to seek a medical attention, they have to go through a lot of other things which are related to prevention. And again, I'm thankful to Professor Mansoor for inviting me, and thank you all.
Now I would request Professor Bilal Mohyuddin, Secretary General, Pakistan Cardiac Society, to please come and say a few words.
Assalamu alaikum. Professor Mansoor Saab, Professor Rashid Saab, very kind of you for setting up this thing. Invitation के लिए बहुत शुक्रिया है, but to get this thing all once again going. काश मुझे पता होता कि मैंने इस तरह की बात करनी है तो जैसे कि कुछ तकरीर लिख लेते, लेकिन 3-4 बातें आप लोगों के साथ मेरे हाल में करनी बनती हैं। जिस वक्त शुरू के दिनों में व्हेन आई जस्ट ग्रेजुएटेड एंड गॉन इनटू गवर्नमेंट सर्विस, तो मुझे इनवाइट किया गया, हुक्म मिला कि जी कि ये फैमिली प्लानिंग का सेशन है, वहाँ पे आ जाए। हम लोग पहुँच गए वहाँ पे। तो वहाँ पे एक डॉक्टर साहब ने बड़े आराम से कहा कि सर हमें क्या ज़रूरत है फैमिली प्लानिंग को इनकरेज करें, जितने पैदा होंगे उतने मरीज़ होंगे, उतनी आमदन होगी। जिस वक्त आपकी सोच ऐसे होती है तो आप कभी भी राय हक पे नहीं आते। आपको अपनी सोच और अपना पैराडाइम को चेंज करना होता है। हम लोग किसी सोसाइटी की तरक्की, उसका अच्छा होने को असेस करते हैं इस बेसिस के ऊपर कि उसकी जीडीपी क्या है। कभी किसी ने इस बात पे असेस किया कि वहाँ पे खुशी कितनी है? एक मुल्क है भूटान जो मेरे हाल में वो करता है इस बात पे, उनका असेसमेंट मेथडोलॉजी फ़र्क है। हम लोग बात करते हैं ना चंद एक मुल्कों की, जैसे कोरिया है, जापान है। आपको पता है वन ऑफ द हाईएस्ट teenage suicides exist over there because of the undue pressures and competition that has been introduced. हम लोग अपने हर हिसाब की सोच से हट गए हैं। As a child, I had the fortune of playing in fields. I had bruises every day. मेरी माँ से मुझे रोज़ ही डांट पड़ती थी कि आज फिर पतलून फाड़ दिए, आज फिर कपड़े गंदे हो गए। आज everyone goes to schools and probably just sits over there, may make a small, बड़ा अच्छा गेम खेली थी कैरम बोर्ड की और शायद टेनिस on the computer, but that's about it. You may look thin and lean, but are you lean and smart? क्या आपके जिस्म में कल की मुसीबतें, लड़ाइयाँ करने की ताकत है? कोविड ने आज हमें एक ये चीज़ सिखाई कि हमें अपने लिबास को तब्दील करना है। So as a result, I see a lot of you young students today over here in their surgical or in their hospital kits over here. एक ज़माना था कि लोग इस किस्म के कपड़े पहन के बाहर निकलते थे तो कहते थे ओए कपड़े नहीं तेरे को। फिर रिसर्च आई जिसने बताया कि जो आप ओवरऑल पहनते हो उसका ये जो हिस्सा होता है स्कफ का, यहाँ पे मैक्सिमम प्रॉब्लम आती है। जो टाई है उसकी ये पार्ट अगर आपने टाई पे नहीं लगाई हुई तो इट विल हिट अ पेशेंट एंड यू विल क्रॉस द इन्फेक्शंस। दिस ऑल हैपेंड बिकॉज समवन समवेयर सेड लेट अस ओपन। हम जो चीज़ें सोच रहे हैं उनमें तब्दीली लानी लाजमी है। आज हमें अपने मुल्क का और अपने कौम का इर्द गिर्द के हालात नज़र आते हैं। आप सेहत की बात करते हो, आप लोग इस बात की कहते हो कि आप लोग 220 करोड़ हो या 22 करोड़ हो, जितने भी आप ढेरों में हो। और यार ये बताओ कि ओलंपिक्स में मेडल्स कितने आपके आते हैं? कंपेटिटिव स्पोर्ट्स में आपकी औकात क्या है? वो एक लड़के ने गलती से जाके स्क्वाश में जीत लिया, आप उसकी धूमें मचा रहे हैं। हकीकत ये है कि आप में से जो जिनको मौके मिलने चाहिए थे, वो स्ट्रीट फुटबॉल के बारे में आई, कराची बिकेम अ वर्ल्ड सिचुएशन, नाम आ गया, बहुत ख़त्म हो गई। बट लेट अस होप एंड प्रे टुडे इज़ कि आज अगर हम ये एक प्रिवेंटिव कार्डियोलॉजी की बात कर रहे हैं तो ये सिर्फ कराची में और सिर्फ एक मेडिकेयर अस्पताल के अंदर लिमिटेड नहीं होगी। मंसूर साहब इंशाल्लाह अगर मौका लगा तो पाकिस्तान कार्डियक सोसाइटी के साथ मिलकर हम हर जगह पे जहाँ जहाँ हमसे मौका होगा हम लोग जाएंगे और इस पैगाम को लेके निकलेंगे। लेकिन जब तक आप खुद इस बात को नहीं मानोगे कि हमारी सोच में तब्दीली की ज़रूरत है। बहुत सारे कार्डियोलॉजिस्ट बैठे हैं और आज कार्डियोलॉजिस्ट का मतलब ये लिया जाता है कि वो शख्स जिसको तार आती हो पकड़नी और एंजियोप्लास्टी कर सके। अगर आज मैं किसी और से राइट हार्ट के बारे में बात करूं या कोई और चीज़ की बात करूं तो कहेंगे ये तुम आउट ऑफ कोर्स सिलेबस पूछ रहे हो, और इस दफ़ा पंगा हुआ भी, आपको मालूम है इम्तिहान के अंदर क्या हुआ था। सो बट इन लॉन्ग एंड शॉर्ट लेट अस होप एंड प्रे द ओनली वे वी विल एवर एक्सेल इज़ बिल्कुल उसी तरह से जैसे कि एक मरीज़ आपके पास आता है चल के और वो ये मानता है कि मैं बीमार हूँ, मैं तकलीफ़ में हूँ और उसको सेहत की ज़रूरत है। आज हम लोग ये कह रहे हैं कि हमारा माशरा, हमारा शोबा, बीमार हो चुका है। हमें इस माशरे और शोबे को ठीक करना है। ये ज़ाहिर है उस तरह का मरीज़ तो नहीं है और इस काम के अंदर कोई करोड़ों रुपए की इनकम नहीं है, लेकिन इसके अंदर ही आपकी आखिरत और उसमें बेहतरी है। अल्लाह ताला हम सबको हदायत में रखे और कामयाब करे और अपने मुल्क को आगे लेके चले। पाकिस्तान जिंदाबाद।
Thank you. I will now request Professor Syed Hussain Mehdi, Vice Chancellor of the Sohail University, to come on the dais and say a few words. Dr. Hussain Mehdi.
Thank you, Colonel Bakar. Respected guests, Chief Guest Ijaz Vora Saab, Dr. Mansoor, organizer of this event. As a Vice Chancellor, I would like to introduce and give a brief information regarding this institute. We have started this journey of imparting health to the community in somewhere in 70s with the name of Medicare Hospital. And after that, this is now 25 years is completed that the medical college is established, and we have the 25th batch now pass on. So we have a very strong relationship with the community because we are involved in teaching and we are involved in giving health support to the community. And this things goes on, and in 2018, the Sir government recognized that we have the ability to be converted into the university. So by the act of 2018 by Sindh government, we are allowed to start Sohail University. Right now we are running two parallel things. The one is the medical college that is still under JSMU, but as a Sohail University, we are having the different departments running under it. We have two hospitals. Number one is the Medicare Hospital. This Medicare Hospital, as I said, started in the 70s, stopped working in somewhere in 90s, and this hospital was closed. Afterwards, as the requirement of the students is enhanced, we again established this hospital and revamped this hospital. And we focus to give a state-of-the-art facilities to the students and for the patient as well. For this reason, we have focused primarily on the cardiac and transplant things. So we have the now two good angioplasty system available, and we have state-of-the-art facilities for the cardiac patient. This and the other hospital we have is present in the Korangi, that is about 300 bedded hospital. Again, we have uplifted that hospital and we are trying to make this Korangi hospital as well as a cardiac center. Because Korangi is far away from the rest of the city, we don't have much facilities available over there. So the main focus of our teaching is to create a good doctor and to provide a good facilities to the community. And this event Dr. Mansoor is established and execute is we welcome on behalf of the Sohail University because we are always interested to do the academic activities. And I'm very surprised and impressed that most of the seniors that is sitting here is my teacher, is my mentor, especially Sir Vice Chancellor Dow University and Waqar Kazmi Saab. I think you don't know me because I'm much changed. You have interviewed me somewhere when there is a establishment of Abbasi Shaheed Trauma Center. So you have selected me as the in charge of the trauma center. Yeah. Us waqt young tha, sir. You are still young. Yeah. Thank you very much. So we are basically working together. We just don't want to create a doctors. We create a human with a good ability to treat the humans. So we are always interested to encourage the academic activities, and I'm again thankful to Dr. Mansoor and Dr. Rashid Saab for organizing this successful event. Thank you very much.
Thank you, Professor Hussain Mehdi. I would now request Professor Masood Hamid Khan, former Vice Chancellor, Dow University of Health Sciences, to please kindly come on the dais and say a few words. Sir.
Auzubillahiminash-shaytanir-rajim. Bismillahir-rahmanir-rahim. Professor Mansoor, honorable dignitary sitting on the dais and present in the hall, Assalamu alaikum. I am so happy to be here today because of so many reasons. And that I will start from my early childhood. When I was a young boy, 8 years, 10, 11 years, we used to play behind this Medicare hospital in the Shaheen ground. So this was known to be at the Shaheen ground. There was a cricket pitch, and when the secretary was mentioning about the playing, and then I started my initial career from Medicare hospital. That was in 1985 when I came from Chandka Medical College, Ladkana. Then I started practicing at Usman Memorial Hospital and at Medicare Hospital, which I left in 1995. So I have very fond memories with this hospital and now University Medical College. So I'm so happy to be here like that. The second is about the main purpose of this conference, which is prevention. Now we are talking about cardiac prevention, but as a whole, I think, and we all know prevention is better than cure. I'll just give you one example from your specialty, and that is putting in a stent, which I asked from one of my colleagues today. That single stent is costing 280,000 rupees, if I'm not wrong. Now with 280,000 rupees, if you count the cost of 50 stents, we can create a very robust program of preventive medicine all over Pakistan. And I was the editor of the Journal of College Physician Surgeon Pakistan, and there at that time I published an editorial that prevention in cardiac diseases. So the prevention, without prevention, nobody can progress. Without health, we cannot progress. Because you know what the definition of health by WHO is: absence of disease. No, it is presence of health, and so many issues are involved. I will not take much of the time, but will mention that the prevention starts, as my friends have mentioned, it starts from home. And what we have to do, we have to start teaching our mothers, to-be mothers, youngsters, and how we can do that. I think at the end, Mansoor Saab, I will request you and all the honorable members, please frame a policy. I don't think that much money is involved in it. It is only the commitment that we can create a primary prevention program for Pakistan, and that is not only for non-communicable diseases but also for communicable diseases also. Because we have to do our own job. We will not be, and we should not be, discouraged that this is the situation of water supply, this is the situation of food, this is the situation of education, but at least God has given us something, and we are placed among the top 10 percentile population of this country. Do you agree with? So we have our responsibility, and I think, once again, and anything I can do in my personal capacity, I'll be more than happy to join the group. Form a group. I will give you some ideas. No money is required, but we can. Alone I cannot do, but together we can do, and you have so many societies coming up together. The last message which I would like to give you to all the medical students, my colleagues, that here Mansoor Saab ne jab he was talking to the press, he said कि हम तोंद के बारे में बात कर रहे हैं. तो हमारे यहाँ तो अब the concept is कि जितना बंदा healthy होगा उतना ही ज़्यादा is, यानी जितना वज़न ज़्यादा होगा, तगड़ा होगा, वो आप फिल्मों में भी देखते रहे कि जनाब क्या है क्या नहीं, you know, we know. तो ये अपनी तोंद वोंद के मामले में मैं सिर्फ I will just like to mention 3 things, take away message from my side, not from the conference. Measure your height, measure your waist, and your waist circumference at the navel should be less than half of your height. If you are able to achieve this, and number 2, the ideal body weight. Just Google what is your height, gender, and ideal body weight. Now, if you have achieved 3 things, the conference job will be over. Now, if you identify yourself, you go home and find that no, the waist circumference is more than half of your height, you are not of the ideal body weight, then do it. Do it. And this is what we want to achieve. With this, I am so grateful to the organizers for inviting me. Thank you so much.
Thank you, Professor Masood. I would now request the chief guest for today's conference, a legend and a very respected name in the field of medicine, Professor Ijaz Vohra. Sir, please come.
अस्सलामु अलैकुम। मैं तुम्हें ऑर्गेनाइज़र का बड़ा शुक्रगुजार हूँ इस नाचीज़ को ये ऑनर दिया है। प्रोफेसर मंसूर और प्रोफेसर रशीद ये मेरे बड़े अच्छे कुलीग भी हैं। मैं तो हमेशा जब NH से आया 73 में जब अब्बासी शहीद ज्वाइन किया तो मेरी तो एक ही कंसर्न थी, प्रिवेंशन। मेरी फील्ड नहीं थी, मैंने पेशेंट वेलफेयर ऑर्गेनाइजेशन बनाई। उस ज़माने में इम्यूनाइजेशन प्रोग्राम नहीं था EPI का, मैंने शुरू किया वहाँ डोनर से। वेल बेबी प्रोग्राम शुरू किया, अंडर 5 पीडियाट्रिशियन इंटरेस्टेड नहीं थे, लेकिन मैं प्रिवेंशन का ज़बरदस्त, मेरा मजहबी प्रिवेंशन है। तो ये, और मुझे बड़ी खुशी है कि हम शुरू में जो अब्बासी शहीद में कंसल्टेंट लोग कलीग थे, दे वेरी वेल मोटिवेटेड। फ़कार काज़मी हमारा पहला रेजिडेंट था मेडिसिन में, आई एम वेरी प्राउड ऑफ हिम। इनकी अचीवमेंट से मुझे बड़ी खुशी होती है। अब इन्होंने एक डायलिसिस और फ्री सेंटर भी बनाया हुआ है, प्रिवेंशन का, हाइपरटेंशन का, हेपेटाइटिस का। तो मुझे बड़ी खुशी है कि वो जो हम सब मिलजुल कर करते थे, इन्होंने वो गुड जॉब जारी किया हुआ है। देखिए, मैं अपने तौर पे ये समझता हूँ कि अल्लाह ताला का ये बड़ी मेहरबानी है कि हम डॉक्टर बने। उससे कि जब आप किसी की कुछ बीमारी दूर करते हैं, किसी को सेहतमंद रखते हैं, ये बहुत बड़ा सिला है। तो आप देखें, डॉक्टर्स की डिसेंट लिविंग है, ये स्टूडेंट्स को मैं कह रहा हूँ। लेकिन अगर आप पैसे के लिए आए हैं तो ये जॉब सही नहीं है आपके लिए, फिर आप कुछ और करें। बट डॉक्टर्स में आप इसमें देखिए, शोहरत भी है, इज़्ज़त भी है, खिदमत भी है। किसी और प्रोफेशन में ये नहीं है तीनों चीज़ें। सो यू आर वेरी लकी कि अल्लाह ने आपको ये चॉइस दी है। अब हमारे मुल्क में तख्ती सिंड्रोम है। अब जहाँ तख्ती का वो सियासतदान लगा सकता है, वो चीज़ें, बड़ी बिल्डिंग बन जाएगी अस्पतालों की, एजुकेशन की, अंदर बेशक कुछ ना हो, लेकिन साफ़ पानी, सीवरेज का निज़ाम, गुड न्यूट्रिशन, गुड हाउसिंग, इन चीज़ों पे तख्ती नहीं लगती, इसलिए हमारी तवज्जो उधर नहीं है। और दूसरे, हमारे यहाँ एज ए इनफरादी तौर पे डॉक्टर वेरी बिजी, लेकिन हम इवन जब हम पेशेंट आते हैं, आपको कोशिश होनी चाहिए, अगर डायबिटिक है तो उसकी फैमिली की भी स्क्रीनिंग करें। दूसरा, सुबह साल्ट का जिक्र आ रहा था, कम्युनिटी अप्रोचेस बड़ी इंपॉर्टेंट है प्रिवेंशन में। अब पीरू में एक स्टडी हुई और जगह भी हुई है, उन्होंने 75% सोडियम और 25% पोटेशियम साल्ट निकाला है। उसकी पैलेटेबिलिटी अच्छी है और कम्युनिटी में ब्लड प्रेशर का लेवल बड़ा कम हो गया। यहाँ मैंने नेशनल फूड वाले मजीद साहब मेरे वाकिफ़ थे, अच्छे कुल, उनसे मैंने रिक्वेस्ट की, तो बहरहाल उनका अनफॉर्चुनेटली इंतकाल हो गया। दूसरा, एक दफ़ा मुझे रेडियो प्रोग्राम पे इनवाइट किया था उन्होंने, तो मैंने बस सिर्फ एक कहा था अपने ख़वातीन से, अपनी बहनों से, माओं से, कमाल तो ये है कि कम नमक के बग़ैर भी, नमक कम करके भी लजीज़ खाना तैयार कर लें तो ये आपकी कमाल है। सिर्फ नमक डाल के खाना अच्छा बनाते हो तो कमाल नहीं है। तो ये नमक जो है ना, ये हमारे यहाँ 12 ग्राम पर वो है इंडिविजुअल, जो होना चाहिए 5 ग्राम। हमारे यहाँ तो लोग फ्रूट पे भी नमक छिड़कते हैं। तो ये सब चीज़ें ऐसी हैं जिसमें अब हम डॉक्टरों को प्रिवेंशन की, हमारी सोसाइटी सब मिलजुल के, मेरी अभी ख्वाहिश यही है कि प्रोफेसर रशीद, मंसूर और बाकी तो हर सोसाइटी जो इन्वॉल्व है, डायबिटिक, मेडिकल, ये मिल के एक प्रिवेंशन का प्रोग्राम बनाएं। और जैसे इन्होंने कहा बहुत सारी चीज़ों में तो पैसा नहीं लगता, वेट मेंटेन करना, वेस्ट शेप रेशो, इन सब में तो पैसा भी नहीं लगता। और दूसरा फैसिलिटीज़ भी प्रिवेंशन के लिए करें। ब्लड प्रेशर देखिए 38 मिलियन ब्लड प्रेशर के मरीज़ हैं, 2 मिलियन का कंट्रोल है। और डायबिटीज़ कितनी बढ़ रही है, हमारे यहाँ कोई कंट्रोल नहीं है, कितना वो इश्तिहारबाजी करते हैं उसमें आपको है नहीं। तो हमें अब सोशल मीडिया को, हमें अब कोई एक्सपर्ट अपना सारी सोसाइटियाँ बनाएं ताकि हम सोशल मीडिया इंडिपेंडेंट है, वो इश्तिहारों पे मुनसर नहीं है, ना अखबार वाले आपको ना अखबार ख़बर देगा, ये टीवी वाला देगा। तो ये अभी एक मशहूर शख्स का नाम भी नहीं लेते टीवी वाले, जब इश्तिहार बहुत देते हैं। तो जब इतना इन्फ्लुएंस हो तो बड़ा मुश्किल होता है। तो मुझे बड़ी खुशी है आज, तो आज की प्रेजेंटेशन बड़ी अच्छी थी, उसमें कई प्रैक्टिकल सजेशंस थी। तो मैं ये चाहूँगा कि ये प्रोफेसर मंसूर, डॉक्टर रशीद ये जारी रखें, लेकिन नशिस्तन गुफ्तन बर्खास्तन की जगह कुछ अमली जामा भी पहनाया जाए, कुछ ना कुछ एफर्ट करें। हमारे यहाँ बड़ी सहूलतें हैं, एक तो मास्क को हम यूज़ कर सकते हैं। देखिए वेस्ट में मास्क कम्युनिटी सेंटर है, यहाँ मैंने प्रोफेसर खुर्शीद को खत लिखा था कि यहाँ भी मस्जिद इसी तरह कर दें जैसे वेस्ट है। अब जो इस्लाम आएगा ये मगरब से आएगा, वो सही मानों में अगर आप वहाँ कभी जाएँ हर किस्म के लोग आपको मिलेंगे, लोग फैमिली के साथ आते हैं, ज़ात पात नस्ल ज़बान कोई चीज़ नहीं होती, मुसलमान बन के रहते हैं। हमारे यहाँ तो फ़िरका बंदी इतनी है कि एक दूसरे के ऊपर। तो ये हमें मस्जिद के बाहर ब्लड प्रेशर और शुगर का तो बड़ा अच्छी तरीके से हम कर सकते हैं। तो ये एक तो मास्क प्रोग्राम बनाएं, और अगर ख़तीब और इमाम साहबान को भी एजुकेट कर दें, हो सकता है अपने खुतबात में भी वो जिक्र करें। देखिए एडम स्मिथ ने लिखी थी वेल्थ ऑफ द नेशन, वर्ल्ड इकनॉमिक फोरम ने एक प्रोग्राम बनाया था जिसमें हेल्थ मेन टॉपिक था। तो उसमें उन्होंने ये लिखा कि आज अगर एडम स्मिथ ज़िंदा होता तो वो लिखता हेल्थ ऑफ नेशन इज़ वेल्थ ऑफ नेशन। हेल्दी नेशन के बगैर आप वेल्थ नहीं बना सकते। आपकी प्रोडक्टिविटी 8 गुना कम है। इवन इंडिया का जो सिख जो है ना, वो स्मोकिंग नहीं करते, और पंजाबी किसान हुक्का चलता है, तो उनकी प्रोडक्शन हमारा 8वां हिस्सा है हमारा यील्ड जो खेतों से, क्योंकि हम हर 15 मिनट बाद हुक्के का कश लेंगे। तो ये बहुत सारी चीज़ें ऐसी हैं जिसमें हमें अपना ये, और दूसरा कल्चर भी प्रिवेंशन का करना है, तख्ती सिंड्रोम से निजात हासिल करनी है। तो उम्मीद है कि ये आज की कॉन्फ्रेंस प्रैक्टिकल बनेगी, ये सारी सोसाइटीज़ को इन्वॉल्व करेंगे, एक कॉमन पॉलिसी बनाएं, और बहुत ज़रूरी है। देखिए हमारे यहाँ तो एक आदमी कमाता है 10 खाने वाले होते हैं। अब देखते हैं कि कितना डिज़ास्टर है जब 30 और 35 साल के लड़के को हार्ट अटैक हो जाए। हमारे यहाँ देखिए बड़ी यंग जनरेशन में अब हार्ट अटैक हो रहा है, स्मोकिंग कितनी है। तो ये हमें ये हमारी जिम्मेदारी है एज ए डॉक्टर। हिप्पोक्रेटिस ने कहा था कि प्रिवेंशन ऑफ हेल्थ एंड मेंटेनेंस ऑफ हेल्थ इज़ मोर इम्पॉर्टेंट दैन रेस्टोरेशन ऑफ हेल्थ। तो हमें भी डिजीज़ मर्चेंट नहीं बनना चाहिए, हमें हेल्थ प्रमोटर बनना चाहिए। मैं अगेन आपका शुक्रिया अदा करना चाहता हूँ कि ये मुझे मौका दिया और इज़्ज़त अफजाई की, जिसका बहरहाल पता नहीं हकदार हूँ कि नहीं हूँ। बहरहाल जो आपका मकसद है उस पर मेरा आपके साथ हूँ। कितनी भी मेरी एज हो जाए, जब भी आप ज़रूरत महसूस करें मैं हाज़िर हूँगा। और मुझे बड़ी खुशी है कि आपने इस प्रोग्राम को शुरू किया है और इसको जारी रखेंगे ताकि इस इम्पॉर्टेंट मसले पर हमारी तवज्जो बरकरार रहे। शुक्रिया।
सर बहुत शुक्रिया। For vote of thanks, I will request Professor Abdul Rashid Khan to please kindly come. Sir.
बिस्मिल्लाहिर्रहमानिर्रहीम। अस्सलाम वालेकुम। उस्तादों के साथ प्रोफेसर आजादुल्ला साहब, हुसैन मेहदी साहब वीसी सोहेल यूनिवर्सिटी, प्रोफेसर जावेद अकबर सयाल प्रेसिडेंट पाकिस्तान काट सोसाइटी, प्रोफेसर बिलाल मोहिउद्दीन जनरल सेक्रेटरी पाकिस्तान काट सोसाइटी, प्रोफेसर मंसूर अहमद चेयरमैन नेशनल कांग्रेस ऑफ प्रिवेंटिव कार्डियोलॉजी, मेरे सीनियर और जूनियर कलीग, अस्सलाम वालेकुम। जैसे सुबह से आप सुन ही रहे हैं कि प्रिवेंशन जो है वो सबसे ज़्यादा बेहतर है, और क्यों हम बहुत देर तक आगे गुजर चुके हैं, 1 घंटे से ज़्यादा हो चुका है, तो मैं अपने इसको मुख्तसर से मुख्तसर करना चाहूँगा। मैं आप सब लोगों का तहे दिल से शुक्रगुज़ार हूँ, जिन जिन लोगों ने मेरे साथ ताउन किया। ये कॉन्फ्रेंस कम से कम 3 से 4 मरतबा किसी न किसी वजह से कैंसिल हुई, और कुछ मेरे दोस्त मुझसे मजाक में कहने लगे यार होगी भी या नहीं होगी। मैंने कहा अब डेट दे दी है, अब होगी। ये और बात है ये और बात है कि यही है जो उन्होंने कहा था, और यही वजह है कि एक कॉन्फ्रेंस 1 हफ्ते के बाद भी हो रही है। तो वहाँ से भी मुझे प्रेशर था कि आप कॉन्फ्रेंस कर रहे हैं। मैंने कहा भाई हमने डेट दे दी है, अब हम इसको चेंज नहीं कर सकते। हमारा इरादा ये है कि ये जो कॉन्फ्रेंस में स्टार्ट की गई है इसको हर साल मुनक्कद किया जाए, क्योंकि सबसे बड़ी प्रॉब्लम जो है वो प्रिवेंशन की है। स्टैंड लगा लेना, बाईपास कर लेना, वेल चेंज कर लेना तो बहुत आसान है, लेकिन प्रिवेंशन सबसे ज़्यादा डिफ़िकल्ट है। तो मेरे इस सफ़र में सबसे ज़्यादा जो ताउन है वो मेरे एक शख्स है जिसने दिन और रात मेरी मंत्री साहब की बातें भी सुनी, और वो अभी भी सुन रहा है। उसका नाम है शारिक ज़मान। वो बेचारा कल रात भी यहाँ 2 बजे तक रहा, आज सुबह मेरे आने से पहले ये मौजूद था, और आई एम रियली थैंकफुल फॉर हिम कि उसने तमाम चीज़ों को बहुत अच्छी तरह से करने की कोशिश की। आई एम थैंकफुल टू द एडमिनिस्ट्रेशन, जिसमें बाकर रज़ा साहब का और पूरी एडमिनिस्ट्रेशन का रोल है कि उन्होंने हमें ये मौका दिया कि हम इस कॉन्फ्रेंस को यहाँ मुनक़्क़िद करें। मैं शुक्रगुज़ार हूँ तमाम उन लोगों का जिसमें मीडिया पर्सन भी शामिल है, हमारी आईटी डिपार्टमेंट भी शामिल है, हमारी कैथ लैब भी शामिल है, हमारा क्या इको डिपार्टमेंट, तमाम डिपार्टमेंट जो हैं जिन्होंने हर लिहाज से कहीं ना कहीं पे हमको से ताउन किया। ये कॉन्फ्रेंस बग़ैर फार्मा कंपनी की सपोर्ट के बगैर नहीं हो सकती। माई स्पेशल थैंक्स टू ऑल द फार्मास्यूटिकल स्टूडेंट्स हु हैव कंट्रीब्यूटेड इन दिस कॉज, और मैं उम्मीद है कि आइंदा भी हम ये कॉन्फ्रेंस करेंगे जो इंशाअल्लाह ताला हर साल मार्च में होगी, तो इसी तरह से ताउन रहेगा। लेकिन अब से सबसे आखिर में आप तमाम बच्चों का जो मुझसे सीनियर हैं, और हो सकता है कोई एक आध जूनियर भी बच्चा बैठा हो, सीनियर भी बैठा हो, कि वो लोग आए और उन्होंने इस कॉन्फ्रेंस को कामयाब किया। तो आप देखेंगे इसका इतना शोर था कि मोर देन 500 रजिस्ट्रेशन आर देयर इन दिस कॉन्फ्रेंस, जो कि एक रिमार्केबल वो है कि जो एक्चुअल जो हमारी रजिस्ट्रेशन है मोर देन 500 है, और हमने इसी लिहाज से तमाम चीज़ें मदद की थी। मैं इससे आप सब लोगों का शुक्रिया करता हूँ। अस्सलाम वालेकुम रहमतुल्लाहि व बरकातहू।
We will take a short break for tea and till we meet for our afternoon session. Thank you.
हम नेक्स्ट सेशन 10 मिनट में शुरू कर रहे हैं, तो चाय आप लेके वापस यहाँ आ सकते हैं ताकि हम ये सेशन जारी रखें। थैंक यू।
मुझे बन जा रहा आवड़ नहीं वो समटाइम होता है लेकिन व्हाट्सएप फोन होता है अच्छा और क्या क्या वो कर बैठे ना तो दोबारा एक होती कॉलिंग, एक होती रिंगिंग। कॉलिंग कॉलिंग होगी जब रिंगिंग लिखा है तो मतलब वो बाकी में कनेक्टेड है, फिर मिस कॉल दी या तो उनको मिस कॉल दे क्या बोला तो उनको मार्क नहीं ये तो बैठेगा वही बैठेगा ये जो भी हाँ वही तो सिस्टम सभी में कुछ बात है। I like उनको बताया बगैर भी जा सकता ना। ना कितने हो गए वो अनाउंस करना है। हाँ तो थोड़ा रास्ता दे रास्ता भी दे देता है लेकिन फिर करते हैं रास्ता तो कौन सा है इसमें तीसरा पास तो बस बैठ के बात मैंने मार्केट में लेकिन तो वो करने में तो देखें तो ऑनलाइन होता है कि नहीं। एक नंबर अमूमन सारी 1 से 2 बजे तक तो हाँ होता है फिलहाल तो मैं एक्टिव पिक्चर बताएंगे विजुअल करने पढ़ा तुम जाके फिर इधर आया हूँ तो सब क्या हाल है ठीक ठाक है कौन से कराची अच्छा अच्छा पहले के मैं पढ़ो नमाज पढ़ो नमाज तो फिर कितने बजे तक लेक्चर है एक्सपेक्टेड पता कुछ मैं नमाज पढ़ लूँ या पहले लेक्चर दे दूँ ठीक है थैंक यू ठीक है ठीक है थैंक यू जी सर इंशाल्लाह सब ठीक ठाक इशराज भाई कर सलाम दे रहे हैं आपको इशराज भाई सलाम दे रहे हैं आपको ये में अच्छा आप उम्र पे जा रहा दुआ करनी है हमारी खास तौर पर उम्र पे जाएंगे ना दुआ कीजिएगा हाँ बेटी के लिए दुआ करें अच्छा दूसरा सर है कि आपके पास पढ़ी है कोई पोर्टेबल तो पढ़ी आपके पास से नहीं आपके पास कैसी जगह अच्छा मैं ना सेंटर में करना चाहता हूँ एक प्रोग्राम रीडिंग प्रोग्राम तो वो दे देंगे मुझे आपने वापस कब आना कब वापस आना आपने नहीं उम्रे पे जा रहे हैं ना आप वापस कब आएंगे नहीं वापस कब आएंगे सर अच्छा चलो फिर 20 के बाद मिलेंगे संडे के बाद आप पहले आप चेक कर लीजिएगा आप मुझे फिर वापस आप इस तरह वापस आ गए मैं जैसे स्कूल खुलते हैं अब चलो मुझे बता दीजिए जैसे भी हो है ठीक है बात करने की ताकि माल को आती है ऐसे माल को क्या पड़ेगा ये पढ़ के अपनी ये कहते थे इधर 1 बजे तो नहीं कहता मैं दिन लगाऊँ आपको ऑनलाइन ये मोबाइल क्या है ना वो नहीं है ना वो नहीं है परफेक्ट वो क्या क्या कब वापस आना है और तो नहीं ठीक है रामसुल भाई थक गए चल बैठ रामसुल भाई थकते नहीं गए ਅਸੀਂ ਵੀ ਆਪਣੀ ਚਾਹ ਪੀ ਲੈਂਦੇ ਹੁੰਦੇ ਹਾਂ ਬਣਾ ਤੁਸੀਂ ਆਪਣੀ ਚਾਹ ਪੀ ਲਈ ਹੁੰਦੇ ਚਾਹ ਪੀਂਦੇ ਨੇ ਉੱਤੇ ਬਣਾ ਲਓ ਫਿਰ ਚਾਹ ਪਾਣੀ ਲੱਗ ਕੇ ਕਾਫੀ ਬੱਚਾ तो ना कोई अंदर आ जाएगा पता नहीं तो बड़े चार का चला गया था चार ये चारों एक मुंबई तक 550 मुंबई के बाद
ऐसे चलेगा. Give donations.
शायद बोल भी कोई नहीं रहा, अभी वैसे बोल भी कोई नहीं रहा है ना, बोल भी कोई नहीं रहा, इंग्लिश में टूटा सारा आपका भाई क्यों नहीं कर, लेकिन एक आवाज ऐसे भी आवाज होती है शायद की आवाज होती है, बैकग्राउंड नॉइज होती है, कह सकते हैं ना, तक तक कुछ सांस नहीं मेरा तो नोट किया मैंने, इससे चलते हैं मुझे भी उन्होंने लेक्चर हॉल भी ये पहले डिवाइस से आ रहा है.
Bismillahirrahmanirrahim. Shall we start the next session? आप भी लोगों ने बैठना है, भाग लो तो भाग लिए. अब्दुल समद साहब, समद राशा राशा दिलता राशा. चलो
स्पीकर ही बंद हो गया, बारी आई फिर बंद हो गया.
Bismillahirrahmanirrahim. We are going to start our other session, and it is about the cardiometabolic disorder. In this session, the chairpersons are number one, Professor Yusuf Kamal. May I request you to Professor Yusuf Kamal, the Professor of Internal Medicine, AKU, to come on the chair as a chairperson. And the second chairperson is Mr. Amir Hamid. He is the professor of cardiology and head of the electrophysiology section at the Ziauddin University Hospital. The next is Professor Kaisar Jamal, who is the professor of internal medicine. Please come as a chairperson. Now I will be start the session, and the first speaker is Professor Kaisar Jamal. He is a professor of internal medicine at the Karachi Medical and Dental College. His topic is prevention of diabetes mellitus. Professor Kaisar Jamal.
Bismillahirrahmanirrahim. With the kind permission of the chair, the topic of the discussion today is something regarding prevention, and it is the prevention of the diabetes, the most commonly affected disease which is spreading very rapidly in the community. And this is the start which we have to learn, the saying of the Prophet, which is basically the cornerstone of every prevention. So there is no conflict of interest, nothing else. So learning objective here are to understand the definition of diabetes, diabesity, and understanding the burden of the disease in the Pakistan and some strategies to prevent it. So this is basically a new terminology introduced in the literature, diabesity, which is a combination of diabetes and obesity. That is basically behind the genetic predisposition is a major risk factor behind the onset of the type 2 disease. And these are some parameters given by the world authorities and for Asian and for the general, European and others, to measure the waist-hip ratios and body mass index as a part of the obesity. This is very alarming. Look at the slide. The World Health Organization figures shows 58.1% of Pakistani population to some extent either are overweight or obese. This is very alarming, 50% of the population. However, according to the Asian cutoffs, when we apply the Asian cutoff, which is much lower than the other cutoff used in the world, this proportion raises up to 72%. So 72% of our population from the childhood till the adult are to some extent either overweight or obese. And this is a definition of diabetes used worldwide as state of hyperglycemia actually, with result from the either insulin secretion deficit or resistance of that. Now what is the situation of the diabetes? We are talking of prevention of diabetes. Look at the scenario. In 2017, approximately 462 million worldwide were affected. 44% of those were in the group of 15 to 49 years. Most productive year of the age is affected by the diabetes. And as you all know, that when diabetes started and it progresses in the 5-year down the track, people start having complication. So the burden of the disease is rising day by day. Now look at the Pakistan. In 2021, 33 million of the adult population was living with diabetes. And you see a remarkable increase after the COVID from the 2019 onward, 70% rise in the population of the diabetes in the Pakistan. And this is the world map. 46.3% remains undiagnosed. Alarming situation behind those who are having diagnosed diabetes. This is IDF map, and the IDF placed us in the MENA region, and that is progression of the disease. You can see. And these are the components of different part of the world where the diabetes increasing. The arrow shows percentage of the increasing, and you are surprised to know in the middle that from 12.8 to 15.7% increase in our region, which is called the MENA region. Recently published data that Pakistan unfortunately get the top in the growth of the diabetes, although this is having third number in the world in the number of diabetes, but the growth rate is top of the list. These are the few studies held different times to show the percentage, and the people used to do their work
from different in 90s, 80s till the last year. But what we do need to do actually, the prevention is better than cure. And can we prevent diabetes? Yes or no? And if patient develop diabetes for any reason, then can we prevent the progression and its complication? Now this is a new concept, remission of the diabetes. अब तक आपने सुना होगा diabetes खत्म नहीं होती, but this is a new concept in the literature that remission is possible of the diabetes. What is the definition of the remission? HbA1c less than 6.5, measured at least 3 months after stopping of the diabetes drug, or at least 6 months after starting of the lifestyle intervention. And it can persist for years and years. Metabolic surgery remission 60 to 80%, lifestyle intervention 36 to 86%. You know, you see the results of the lifestyle intervention, a good healthy lifestyle, good result. If a proper maintenance weight loss is there, then up to 86% is the result. So these are the few common risk factors behind the genetic predisposition for the development of the type 2 diabetes. Unfortunately, some are non-modifiable risk factors. We can't do much to them. But what we can do, as we were talking in the morning session, that prevention starts from the home. बच्चे ने ज़रा सा तंग किया माँ को, ये मोबाइल ले लो भाई, टैबलेट ले लो, अपना काम करते रहें. वो बच्चे मोबाइल में लग के what they are doing, they are having zero physical activity. As a result, we got overweight and obesity. घर में खाना पसंद नहीं आया, अब everything is available on a phone call. आपने ऑर्डर किया, खाना घर पे आ गया. मॉर्निंग में आप फेसबुक उठाएं, दोपहर में उठाएं, रात में उठाएं, आपको मेन्यूज पोस्ट हुए नज़र आएंगे. आज हमने ये खाया, आज हमने वो खाया, आज हमने कितनी एक्सरसाइज की, आज हमने कितनी कैलोरीज बर्न की, ये वाली अभी हम वेट कर रहे हैं. इन पोस्ट का शायद स्टार्ट होने वाला है इस कॉन्फ्रेंस के बाद. तो व्हाट वी नीड टू डू, वी नीड टू स्टार्ट प्रिवेंशन फ्रॉम आवर ओन, then to the family, and then to the community. And this is obesity, a hallmark which behind the development of the disease, and Professor Rehan, my colleague, will talk more on it. So I am going to skip few slides. Now, what is the recommendation? To whom we should screen? The IDF and the All Diabetic Association categorically describe the high-risk categories where we should focus and we should start screening if we really want to prevent the diabetes. So there is a chart available, there is a screening protocol available on the every site, and you can search this all with the help of that. People with pre-diabetes, HbA1c of 5.7 to 6.4 need to be concentrated at most, and people with overweight and obesity and a family history need to be concentrated most, and a female with history of gestational intolerance needs to be focused more. A few more common group which need to be addressed beside the whole community screening. Screening should be in the early age, and so we start preventing the diabetes, start preventing the onset of the disease, and start preventing the complication, and later on end up with in the age of 30 and 40. We usually saw these patients nowadays, the patient coming with the young myocardial infarction in the age of 30 and 40. So much stress in the community, so much everything is there, but we can do our job, we can maintain our health. There is nobody to going to obstruct you from that. So this is a criteria. Everybody knows the diabetes, when it develops, every fasting blood sugar should be less than 100. That's it. Remember one thing, blood sugar less than 100 is the target, is the goal. So again, you can use this. Some of the strategies used to prevent the onset of the diabetes. or if diabetes is started, then obviously we can work for remission or at least progression to the complication. And different parameters have been designed and designated for these patients who can work for that, and some of the samples are available on the net. You can work out your caloric requirement, you can work out your daily requirement, and up to 1200 to 1600 kilocalories in a general population who is not exerting much can be useful. And these are the some menus you can describe to your patients, and this is the DASH diet, focusing the vegetables at the most and the fat, and in between the pattern is described everywhere. Intermittent fasting concept is also there to progress the halt and development of the obesity, and it really help in prevention and remission of the diabetes. You will be surprised to know these facts about these common things used in our kitchen. I don't think much of the people will realize that what cinnamon does to our fasting. Cinnamon, the most common used component in the kitchen, decreases the fasting glucose, decreases the cholesterol, decreases the cellular inflammation, decreases the decreases the oxidative stress, and thereby increasing the insulin sensitivity. This cinnamon is so important. Likewise, you can see a few of the spices used in our daily routine, but we don't know actually what we are doing, what we are focusing at. So, a low carbohydrate diet with balanced nutrition is supposed to deal with progression of the obesity and onset of the diabetes. Assessment before going into the exercise program is mandatory. Every individual is a different patient, and every patient need to be different and individually sorted out what type of exercise need to be advised. But as the morning session described, nothing is fixed, but we can advise something to everyone. A minimum 5-minute walk or a 10-minute walk is better than nothing. But what is the recommendation? 40 minutes brisk walk 5 days a week is for the good healthy life. And these are the benefits, that it is not only the obesity, but the anxiety will be relieved, the sleep will be improved, and the blood pressure goal will be achieved much easier than if we will go to the exercise program. And these are the benefits of the physical activity that we are going to achieve with a 40-minute brisk walk if we go through this. Now, this is the mechanism of the remission of the diabetes. What happens actually, type 2 diabetes, increased fatty liver, visceral deposition of the fat, liver fat export, pancreatic fat, that by we end with the beta cell dysfunction. If we do otherwise, if we focus on the health, if we focus on the good healthy nutrition, if we focus on the physical activity, what we'll achieve? It will reversal will be started, and the beta cell start again functioning. So we will get the remission of the diabetes in early 6-month to 5 years program. It is all proven. Management for the prevention or remission of diabetes. This is the algorithm used step by step, that you go for the lifestyle intervention, combining with the physical activity and a healthy nutrition, avoiding the sedentary lifestyle, avoiding the stress factors, and focusing on the. So these are the targets. We'll quickly go through the last few slides, as Samad Saab is saying the time is short. So, management plan for prevention and remission. The strategy going through that we discussed, the diet, physical activity, and thereby improvement in all parameters that lead to the reversal of the beta cell function. This is the another segment which is the surgical oriented and the gastric bypass surgery for very morbidly obese patient whose BMI is more than 40. We can recommend this remarkable results in the remission of the diabetes and hypertension and other metabolic syndrome. So what are the key changes? Reinforcement of the role of healthy behavior and new information on the role of certain dietary patterns in reducing the risk of diabetes. You can see the cumulative incidence of diabetes, and you can see the result benefits of diet and exercise or metformin on diabetes prevention at risk and patient with IFG, IGT and without diabetes. So lifestyle changes 58% reduction, metformin 31% reduction, and placebo unfortunately didn't find any benefit. So even still the lifestyle is much better intervention than the pharmacotherapy. आपके पास पेशेंट आएंगे, डॉक्टर साहब दवा जो चाहें लिख दें, जितनी महंगी हो लिख दें, चल मैं नहीं सकता, इसका टाइम नहीं है मेरे पास, मुझे खाने से ना रोकें, थोड़ी सी ज़िंदगी है खा के ही जाऊँगा. पेशेंट आया मेरे पास, ब्लड शुगर उसकी 400-500 रहती थी, उसको अप्लाई की, उसके ऊपर ये सारी चीज़ें जो आपसे डिस्कस कर रहा हूँ. आफ्टर 6 weeks he came, blood sugar was 102. He was so happy कि मेरी लाइफ में कभी 100 टच नहीं की शुगर, और उसके 1 घंटे बाद दोबारा आया हूँ. डॉक्टर साहब मैं इस खुशी में 6 रसगुल्ले खा के आया हूँ, आपको बताने के लिए आया हूँ कि मेरी शुगर ठीक हो गई है. दिस इज़ आवर एटीट्यूड. जो अभी डॉक्टर बिलाल मोहिउद्दीन या बात कर रहे थे कि हमें अपने एटीट्यूड को फोकस करना चाहिए, हमें अपनी सोच को बदलना होगा. Program related to reduction and progression of the diabetes, metformin again used, but recommended is that. So recommendation 1 for pre-diabetes and high-risk individuals, summary is that moderate weight loss by healthy food and regular physical activity. Recommendation 2, if it not works, then add the metformin. And this is a new thing which is available and a remarkable weight loss, but with some concerns and cost is available. So a safe and preventive strategy can prevent the disease. And I will end my talk with the saying of the Prophet Muhammad, peace be upon him, sallallahu alaihi wasallam, again. On seeing a fat man, the Holy Prophet Muhammad, peace be upon him, said, if you did not have a punch of belly, it would be better for you. He also said, overeating doesn't go good with the health. Us saying 1450 years ago is still we are discussing prevention. Our teaching is this, but we unfortunately forget. Another hadith, this is the last slide. No human ever filled a vessel worse than the stomach. अपने पेट से ज़्यादा भरने वाली कोई चीज़ अच्छी नहीं है. Sufficient for any son of Adam are some morsels. कुछ निवाले अपनी ज़िंदगी को गुजारने के लिए, सेहत के लिए ज़रूरी हैं. But if it must be, then 1/3 should be food, 1/3 should be water, and 1/3 should be air. This is the Ahmad al-Tahami. This is the saying of the Muhammad, peace be upon him. I hope that we should start working at our home, at our families, our community for the prevention and for the prevention of disease. Thank you.
Thank you, Dr. Kaisar Jamal. Now I request to Professor Rehan Umar to please come and address. And his topic is metabolicity and how to treat it. And we requested to the speakers, please, the time is short and keep it as
Assalamu alaikum. First of all, I am privileged to be here. And shuru karte hain sir pehle. Being an interventional cardiologist, going to meetings जिसके अंदर prevention की बात हो रही होती है, उसमें बड़ी खुशी होती है. और ख़ास तौर पे आज जिस तरह प्रोफेसर बिलाल मुहिउद्दीन ने आके जो बातें की हैं, लिटरली सैल्यूट टू हिम, बिकॉज इट डजंट हैपन दैट ऑफन। मैं जाता हूँ प्रिवेंशन की मीटिंग्स में, वहाँ पर सारा कुछ जो है वो हाई फाई चीज़ें हो रही होती हैं कि पेशेंट आपके पास आएगा, आप कैल्शियम स्कोरिंग कराएं, CT एंजियो करा के देख लें, जेनेटिक टेस्टिंग कर लें। लिविंग इन ए सोसाइटी विच इज़ सो मच हैविंग पॉवर्टी, उसके अंदर ये सारी चीज़ें एप्लीकेबल नहीं हैं। सो हम अपने जूनियर्स को, अपने कॉलीग्स को, आई कैन सी लॉट्स ऑफ पीपल हु आर नॉट इवन डॉक्टर्स हेयर, उनको वो पैगाम दे के जाएँ जो प्रैक्टिकल हो और जिस पे अमल किया जा सके। तो आई थिंक दैट शुड बी गुड डिस्कशन। अभी हमने डॉक्टर कैसर जमाल ने बात की डायबिसिटी के बारे में, मेटाबिसिटी के बारे में, तो मैं उसी को थोड़ा सा आगे बढ़ाऊंगा। अभी WHO ने रिसेंटली एक क्राइटेरिया पास किया कि 2030 तक जो इंसिडेंस है कार्डियोवास्कुलर डिजीज़ का वो कम से कम 30% कम हो जाए जो एग्जिस्टिंग है। क्या आपको पता है कि कोविड के जो 3 साल हम पे गुजरे हैं क़यामत की तरह, और जिसमें कोविड की वजह से लोगों ने मास्क पहनने शुरू कर दिए और अपने अजीज़ व अकारिब की अमवात में भी जाना छोड़ दिया, इतनी खुदगर्जी और इतनी सो कॉल्ड प्राइमरी और सेकेंडरी प्रिवेंशन पे हमने अमल करना शुरू किया, उसमें कितनी अमवात हुई हैं पिछले 3 सालों में? 2019 से 2022 तक कितनी अमवात हुई होंगी कोविड के अंदर? एनी आइडिया, रफ आइडिया जी? The total deaths that occurred during the COVID area were not exceeded by 3 million. 3 मिलियन के करीब अमवात हुई हैं कोविड के 3 सालों में। अगर हम बात करें कार्डियोवास्कुलर डिजीज़ की तो एक साल के अंदर 19.1 मिलियन डेथ्स। तो दिस इज़ द एल्गोरिथम दैट वी डील विद। हम जो कहते हैं ना हम कार्डियोलॉजिस्ट हैं, वी आर प्राउड टू बी कार्डियोलॉजिस्ट बिकॉज वी ट्राई टू आवर बेस्ट टू प्रोटेक्ट लाइव्स। अगर हम इस वक्त बात करें जहाँ मैं खड़ा हुआ पोडियम के ऊपर, इस वक्त पूरी दुनिया में 515 मिलियन पेशेंट्स ऐसे हैं जिनको कार्डियोवास्कुलर डिजीज़ है। जस्ट इमेजिन 515 मिलियन। अगर हम बात करते हैं जो रिस्क फैक्टर्स जो कार्डियोवास्कुलर डिजीज़ रिजल्ट करते हैं, जैसे जो हमारे नेफ्रोलॉजिस्ट आए थे उन्होंने पूरा बयान किया, एनीमिया एंड क्रॉनिक किडनी डिजीज़। इस वक्त कितने पेशेंट्स हैं जिनको रीनल फेलियर है दुनिया में? देयर आर मोर देन 800 मिलियन पीपल right now on the surface of this planet who are suffering from chronic kidney disease. ठीक है, so we are dealing with a cynical world. 1 बिलियन से ज़्यादा हाइपरटेंसिव्स हैं। इंटर हार्ट स्टडी ने साबित कर दिया कि जितने रिस्क फैक्टर्स हैं कार्डियोवास्कुलर डिजीज़ के, अगर उन सबको इकट्ठा किया जाए सो हाइपरटेंशन इज़ नंबर 1। और हम कितने बदनसीब हैं कि इस दौर में जब हमारे पास कितनी सारी दवाइयाँ हैं ब्लड प्रेशर की, तब भी हमें हाइपरटेंशन ट्रीट करनी नहीं आती। ठीक है, एक जूता हर एक के पैर में फिट नहीं कर सकते, एक एस्थमा के पेशेंट को बीटा ब्लॉकर नहीं दे सकते, एक प्रेग्नेंट लेडी को, एक ऐसी खातून जो कि अपने रिप्रोडक्टिव ईयर्स में हो, उसको बगैर काउंसलिंग के एस इनहिबिटर ARB नहीं दे सकते। एंड आई कैन अश्योर यू टाइम एंड टाइम अगेन वी आर सीइंग सच पेशेंट्स इन आवर क्लिनिक्स। फीमेल पेशेंट है, प्रेग्नेंट है, क्या दवाई ले रही हो? एस इनहिबिटर। सो दिस इज द स्टेट ऑफ द अफेयर। सो टॉकिंग अबाउट प्रिवेंशन इन दिस सोसाइटी इज़ ऑफ पैरामाउंट इंपॉर्टेंस। अगर हम बात करते हैं कार्डियोमेटाबॉलिक सिंड्रोम की, कि कार्डियोवास्कुलर डिजीज़ के साथ अगर सिर्फ पेशेंट को अगर डायबिटीज़ है, कोई कार्डियोवास्कुलर डिजीज़ नहीं है, तो क्लिनिकली स्पीकिंग, मेडिकली स्पीकिंग उसकी ज़िंदगी के 6 साल कम हो जाते हैं। अगर डायबिटीज़ के साथ उसको कार्डियोवास्कुलर डिजीज़ है तो उसके 12 साल ज़िंदगी की कीमती कम हो जाते हैं, और साथ में उसको अगर क्रॉनिक किडनी डिजीज़ है तो उसके 16 साल कम हो जाते हैं। सो प्रिवेंशन हैज़ टू प्ले इट्स रोल एंड इट हैज़ टू बी। अब बड़ी सिंपल सी बात है, बड़ी सिंपल इक्वेशन है कि ओवर ए कोर्स ऑफ लाइफ स्पैन हम लोग जो खाना खाते हैं, हम 18,000 पाउंड पूरी ज़िंदगी में, जो एक एवरेज लाइफ है 65 साल की, 70 साल की, 18,000 पाउंड लेते हैं, लेकिन हमारा वज़न नहीं बढ़ता। जब हम प्रिवेंशन इख्तियार करते हैं, व्हेन वी ट्राई टू कट डाउन ऑन आवर वेट, तो फिर देखें क्या होता है। फिर हमारी जो बॉडी है, ये बॉडी का एक फ़लसफ़ा है कि बॉडी फाइट्स बैक। एक चीज़ की, जब बुरी चीज़ की इंसान को आदत हो जाती है तो उसको अचानक आप रोकते हैं तो इट वांट्स मोर। वो एक वो था ना पेप्सी का ऐड, ये दिल मांगे मोर। सो बॉडी स्टार्ट्स फाइटिंग बैक, उसको और चाहिए, क्योंकि उसके काउंटर रेगुलेटरी हार्मोन्स प्रोड्यूस होते हैं, बहुत सारे बॉडी के अंदर केमिकल्स प्रोड्यूस होते हैं जो कहते हैं और खाओ और खाओ। सो इन दैट सर्कमस्टांसेस, इन दो सर्कमस्टांसेस फाइट बैक करना बहुत ज़्यादा इंपॉर्टेंट है, क्योंकि अगर हम नहीं करेंगे तो ये हाल होगा इस वक्त जो हमारे साथ हो रहा है कि हमने अपना जो सेल्फ कंट्रोल है उसका बटन दबाना छोड़ दिया, सेल्फ डिस्ट्रक्शन का बटन दबाना शुरू कर दिया, और उसकी सबसे बड़ी वजह द प्रोसेस ऑफ अर्बनाइजेशन, जिसके अंदर जगह जगह फास्ट फूड रेस्टोरेंट्स खुल चुके हैं। और सबसे बड़ी बात ये, अगर ये अमेरिका में स्टडी आई थी कि जो 60s में रेस्टोरेंट्स थे उसमें स्नैक्स का साइज़ छोटा होता था, पेप्सी की बोतल का साइज़ छोटा होता था, और अब अगर आप अमेरिका जाके देखें, एवरी सेकेंड अमेरिकन इज ओबीज, every second American is obese. Why? Because of this fact. सोडा का साइज़ बढ़ गया, बर्गर का साइज़ बढ़ गया, एक वक्त में बैठ के ऑल यू कैन ईट एंड ड्रिंक एंड $50, तो जनाब वो ज़िंदगी का आखिरी खाना समझ के जाते हैं और ठूस के वापस आते हैं। तो दिस इज़ व्हाट इज़ हैपनिंग। सो अब इस तरह के वेइंग मशीन आने लगी है मार्केट में, वो 10 किलोग्राम 20 किलोग्राम ख़त्म हो गया, अब बकरा है, गाय है, मज है, भैंस है, इस तरीके से हम इसको एडजस्ट करते हैं। सो दिस इज़ व्हाट वी एंड अप विथ, full blown metabolic syndrome. So what I'm about to discuss over the course of next 5 or 6 minutes is that there are certain factors, जिस तरह डॉक्टर बिलाल ने ही कहा था गालिबन कि जापान में और कोरिया में, जहाँ की हम बात करते हैं कि बड़े तरक्की याफ्ता मुल्क हैं, 60 की दहाई पे तो सड़क पे थे, आजकल दे आर द मोस्ट डेवलप्ड कंट्रीज इन द वर्ल्ड, वहाँ पर सबसे ज़्यादा सुसाइड का रिस्क फैक्टर, बहुत ज़्यादा सुसाइड्स हो रही हैं। वाई? बिकॉज दे हैव गॉट स्ट्रेस, दे नीड टू वर्क हार्ड। एंड आई वेंट टू कोरिया, वी वेंट टू कोरिया टुगेदर। हमने वहाँ पर जाके देखा कोरिया में इंसान नहीं रहते, कोरिया में कोई इंसान नहीं है, कोरिया में सारे रोबोट्स हैं। सुबह 5 बजे घर से निकलते हैं मास्क फेस के साथ, 6 बजे तक वो कुत्तों की तरह काम करते हैं और उसके बाद वो सीधा घर चले जाते हैं। दे डोंट लाफ, दे डोंट स्माइल, दे डोंट पार्टिसिपेट इन एनी सोशल एक्टिविटीज़। सो बिकॉज ऑफ दिस शेयर स्ट्रेस दे हैव मोर चांसेस ऑफ डेवलपिंग मेंटल डिसऑर्डर, जिसके ज़रिए वो स्ट्रेस में मुब्तला होते हैं। फिर सेडेंटरी लाइफस्टाइल है, फिर एक्सेसिव कैलोरी इंटेक है, ये सारा कुछ जो है बॉडी के अंदर एंडोथेलियल डिसफंक्शन कॉज करता है एंड दैट रिजल्ट्स इन कार्डियोमेटाबॉलिक सिंड्रोम। सो ओबेसिटी, जिस तरह भी मुझसे पहले स्पीकर ने बताया कि फॉर इट हैज़ ग्रोन आउट टू प्रोपोर्शनल, इस पैंडेमिक की सूरत इख्तियार कर चुकी है। हर दूसरा अमेरिकन ओबीज़ है, पाकिस्तान में 50% से ज़्यादा ओबेसिटी है, पाकिस्तान में 70% से ज़्यादा ओवरवेट हैं, तो वी नीड टू डू समथिंग अबाउट इट। सो द कॉन्कॉमिनेंट अकरेंस ऑफ डायबिटीज़ विद ओबेसिटी इज़ नोन एज डायबिसिटी, लेकिन इसके साथ जो मेटाबॉलिक डिरेंजमेंट्स होती हैं उनको हम मेटाबिसिटी कहते हैं। तो अब मेटाबिसिटी क्या फैक्ट है, मिथ है, क्या है? सो यस, इट डज एग्जिस्ट। आपके सामने है ओबेसिटी, आपके सामने है डायबिटीज़। सो ऑल दीज factors, they ultimately culminate into metabesity or metabolic syndrome. Metabolic syndrome एक ज़माने में जब हम मेडिकल कॉलेज में पढ़ते थे तो एक बड़ा फैंसी सा नेम था, और अपनी डॉक्टरी को जताने के लिए मरीज़ से आपको तो मेटाबॉलिक सिंड्रोम है, अब वो मरीज़ परेशान किसको है क्या? So we need to tell our patients, we need to educate our patients कि what metabolic syndrome is. Obesity, diabetes, hypertension, hyperlipidemia, all these risk factors, they all tend to accumulate and they cause metabolic syndrome, and these are the drivers of metabesity. Patients who got insulin resistance, high blood pressures, high glucose levels, visceral obesity, etc., etc. So अब इसकी पैथोफिजियोलॉजी क्या है? पैथोफिजियोलॉजी ये कि ऑफ कोर्स अंडरलाइंग एंडोथेलियल डिसफंक्शन है, एथेरोस्क्लेरोसिस है, ऑल दीज फैक्टर्स कल्मिनेट एंड रिजल्ट्स इन आइदर टाइप 2 डायबिटीज, ओबेसिटी, कार्डियोमेटाबॉलिक सिंड्रोम। तो जब किसी को ओबेसिटी हो जाती है तो उसको देयर आर मोर चांसेस ऑफ और फॉर द पेशेंट टू हैव कैंसर्स, हार्ट अटैक्स एंड ऑल डिफरेंट complications of this disorder. Early aging हो जाती है because of different mediators that are released. So what are the benefits of weight loss? Weight loss achieve करने से आपको सारे जो आपके parameters हैं ये reverse होना शुरू हो जाते हैं. It's never too late. It's never too late. So we can achieve those risk markers. अब यहाँ पर एक बड़ी important चीज़ है, जिस तरह बहुत ज़्यादा मोटापा ख़तरनाक है उसी तरह बहुत ज़्यादा दुबलापन भी ख़तरनाक है। वो लोग जो बुलिमिया नर्वोजा का शिकार है, जिनको एनोरेक्सिया नर्वोजा होता है, दे ऑल्सो कैरी इंक्रीज कार्डियोवैस्कुलर रिस्क। सो वी शुड अटेन एन एवरेज लाइफ स्टाइल जिसके ज़रिए हम बेहतर कर सकें। आपके पास ये 3 तस्वीरें शो कर रहा हूँ, इन तीनों में से आप कौन सा होना चाहेंगे? इन तीनों में से हम कुछ भी नहीं होना चाहेंगे। एक तरफ तो एक बॉडी बिल्डर रॉटवाइलर खड़ा हुआ, एक तरफ ऐसी माशाल्लाह हेल्दी अंडियाँ खड़ी हुई हैं, और एक तरफ एक स्किनी खातून खड़ी हुई है। सो ऑल दीज 3 have got more risk. अभी आपने I'm sure सुना होगा इतने बॉडी बिल्डर्स हर साल मिस्टर ओलंपिया लड़ते हैं, जाके बॉडी बिल्डिंग करके वापस आते हैं और मर जाते हैं। सो ऑल दीज आर एक्सट्रीम्स ऑफ लाइफ विच वी डोंट हैव टू फॉलो। बड़े नाइस गाइडलाइंस बड़ी क्लियरली आ चुकी हैं, और डॉक्टर बिलाल मोहिउद्दीन ने बड़ा अच्छा बताया कि इस वक्त जो आप अपना वेट चेक कर लें और अपनी आप वेस्ट सर्कमफ्रेंस चेक कर लें, तो आपका जो वेट है वो आपका वेस्ट सर्कमफ्रेंस का आधा, अगर इसका रेशो 0.5 आ रहा है या उससे कम है तो आप हेल्दी हैं। ये 4 लोग खड़े हुए पिक्चर में, इनमें से आप देख सकते हैं कि जो इसका 0.71 है ही इज़ अनहेल्दी, जिसका 0.51 है, that is unhealthy, but the person here in the middle, 0.38 and 0.47, they should be considered as healthy individuals. So nice guidelines के बदौलत हमें अपनी वेस्ट और हाइट जो है उसका सर्कमफ्रेंस एवरेज लेना चाहिए. क्या करना चाहिए? यहाँ पर हम लेक्चर देते हैं, बाहर डब्बों में खाने हैं जिसमें समोसे, पकोड़े, बीफ, वो सारा कुछ खाएंगे, and everything goes down the drain. So we need to act in concert. Literally, मैं जाता हूँ प्रिवेंशन की मीटिंग में टॉक देता हूँ, टॉक के बाद फार्मास्यूटिकल वाले लेविश डिनर, लेविश मील्स लगा देते हैं. So what's the hell? There is no fun about it. So we need to be careful. हमें रिकमेंडेशंस फॉलो करनी है. रिकमेंडेशंस ये हैं ऑफ कोर्स कि 20 से 45 साल के लोग हर साल अपना लिपिड प्रोफाइल करा के चेक कर लें, प्राइमरी स्क्रीनिंग चेक कर लें, HbA1c कितना है. वी नीड टू कीप आवर HbA1c बिलो द प्री डायबिटीज़ लेवल, बिलो 5.7, एंड फास्टिंग ब्लड ग्लूकोज करा के देख लें. फास्टिंग ग्लूकोज 100 से ज़्यादा नहीं होनी चाहिए. रैंडम ब्लड शुगर्स 140 से ज़्यादा नहीं होनी चाहिए. अगर इससे ज़्यादा है तो दैन द पेशेंट्स बिकम इम्पेयर्ड फास्टिंग और इम्पेयर्ड ग्लूकोज टॉलरेंट. Ultrasound is the first line diagnostic test to rule out the importance, the very important diagnosis NAFLD. जब हम मेडिकल स्टूडेंट थे, अल्ट्रासाउंड पे फैटी लिवर आता था, वी यूज टू इग्नोर. हम परवाह नहीं करते थे फैटी लिवर की. राइट नाउ फैटी लिवर इज कंसिडर्ड टू बी अ हार्बिंजर ऑफ एथेरोस्क्लेरोटिक कार्डियोवैस्कुलर डिजीज. इट लीड्स टू कैंसर्स. इट्स द नंबर 1 cause of hepatocellular carcinoma. It has superseded hepatitis B and hepatitis C. तो इसको हमें बहुत देखना ज़रूरी है. इसके अलावा पेडियाट्रिक सर्जरी की गाइडलाइंस बता चुके हैं कैसर जमाल साहब. इफ़ द पेशेंट हैज़ गॉट नो डिजीज़ एंड हिज BMI or her BMI is more than 40, he is a candidate for pediatric surgery. If he has comorbids like diabetes, ischemic heart disease, then 35 becomes the threshold. इसके अलावा इस पर भी डिस्कशन हो चुकी है सुबह. द सुपर 7 of the American Heart Association: quit smoking, control your sugars, control lipids, control uric acid, diet, exercise, and of course move along. थेरेपिटिक्स पे बात नहीं करूंगा, बहुत सारे नोटेबल स्पीकर्स हैं मेरे बाद आने वाले, वो थेरेपिटिक्स पे बात करेंगे. देयर आर सो मैनी एंटी ओबेसिटी मेडिकेशंस. इस वक्त जो नंबर 1 मेडिकेशन है एंटी ओबेसिटी, दैट इज सीमाग्लूटाइड एट द डोज ऑफ 2.4 milligrams, बट यू कैन नॉट स्टार्ट विद 2.4 milligrams. यू हैव टू अप टाइट्रेट द डोज, स्टार्ट लो एंड गो स्लो. उस पर बात हो सकती है. और उसके बाद बेरियाट्रिक सर्जरी पे मुख्तलिफ मोडालिटीज़ हैं, इस पर बात हो जाएगी. लेकिन जो मैं अपना प्रैक्टिकल एक्सपीरियंस शेयर करता हूँ, दैट इज़ माई ओन प्रोग्राम that I run, and I've been running that program for the past 6-7 years now. I've got more than 50 students. Being a cardiologist, being a physician, being an expert in diabetes, if you start listening from the horse's mouth, तो उसका असर होता है. तो मैंने आज से 6-7 साल पहले खुद अमेरिका में जाके ट्रेनिंग की, कंडीशनिंग की और हाई इंटेंसिटी इंटरवल ट्रेनिंग की, और उसके बाद मैंने अपना ग्रुप बनाया रॉसिट के नाम से, जहाँ पर हम वी ट्राई टू इम्प्रूव एंड इनकरेज द हेल्थ स्पैन, नॉट द लाइफ स्पैन. किसी को नहीं पता कौन कितना जिंदा रहेगा, किसी को नहीं पता, लेकिन हेल्थ स्पैन के लिए वी कैन वर्क टुगेदर. We guide our people, our students, and we do this. We regularly measure the height and weight. I do dietary counseling. I teach high-intensity interval training, and this is what we emphasize on: healthy eating. ठीक है. I still remember कि एक लेक्चर था मेरा, प्रोफेसर मंसूर साहब बैठे हुए थे सामने, तो किसी ने मुझसे पूछा कि आप डाइटिंग के बारे में बताएं. तो मैंने बड़ी हाई फाई किस्म की बातें की, सर खड़े हो गए, कहने लगे नो, डाइटिंग इज़ नॉट दैट. एंड आई फुली एग्री. मैं नीचे जाके होता है, एंड आई रिस्पेक्ट प्रोफेसर मंसूर साहब. इनकी जो बात थी वो ये थी, विच स्टैंड्स ट्रू टिल डेट: डाइटिंग इज़ वॉट यू कैन अचीव अकॉर्डिंग टू योर सर्कमस्टांसिस. मतलब मैं जब अमेरिका गया ट्रेनिंग करने, तो मेरा गुरु था, उसने मुझे अपने घर खाने पे बुलाया और टेबल पे सिर्फ पत्ते रखे हुए थे, सिर्फ पत्ते, पता नहीं मुख्तलिफ किस्म के हरे हरे पत्ते, कि ये खाओ बैठ के. सो आई कुड नॉट ईट एनीथिंग ऑफ इट, बिकॉज मेरी सर्कमस्टांसिस में वो डाइटिंग नहीं है. हमारी सर्कमस्टांसिस में डाइटिंग क्या है कि वी स्टॉप टेकिंग रिफाइंड कार्बोहाइड्रेट्स, एज सिंपल एज दैट. कोई हाई फाई चार्ट बना के मरीजों को देने की ज़रूरत नहीं है. रिफाइंड कार्बोहाइड्रेट्स नहीं लेने, कॉम्प्लेक्स कार्बोहाइड्रेट्स ले सकते हैं पोषण कंट्रोल के साथ. प्रोटीन इंटेक रखना है, फाइबर इंटेक रखना है, पानी बहुत पीना है, और आपने पोषण कंट्रोल इख्तियार करना है. दैट इज़ वॉट आवर डाइटिंग स्टैंड्स फॉर. इसके अलावा वी डू एक्सरसाइजेज, एंड दीज एक्सरसाइजेज आर ए मस्ट. 60% डाइट, 30% exercise, 10% meditation. This is what it takes, and this is a lifetime commitment. And if you commit yourselves to it, then this is what happens. I'm standing in front of you. I was 99 kilos and I started doing cardio and this is what happens. So this is how we prevent. मेरे पास ऐसे कई लोग हैं जिनको डायबिटीज़ थी, now they have, जो रिमिशन की बात हो रही थी ना, तो रिमिशन की बात होती है कि आप 800 कैलोरीज इस्तेमाल करें, भूखे रहें, कुछ ना खाएं, कुछ ना पिएं, ऐसा नहीं है. You go for healthy diet, you observe portion control and you observe good sleeping habits, be consistent, and only then you'll be able to achieve your targets, and this is achievable, and let's do it. So if it really exists, the answer is yes. Thank you very much.
Thank you, Dr. Rian. Now we will take our next speaker on the Zoom from the Lahore. He is Mr. Abdul Wajid from the Punjab Institute of Cardiology, and his talk is about the prevention of the rheumatic heart disease and the role of society. May I request to IT department that he is online? Yes, you are with us, Mr. Wajid.
Can you hear us? Can you hear me?
Yes, yes.
Yes. Bismillahirrahmanirrahim. Thank you very much for giving me the opportunity to speak on this forum. It's a very important forum for me to show some of the slides about the work we are doing for the prevention of rheumatic heart disease. Rheumatic heart disease is a field which is less well discussed and less well done, because rheumatic heart disease is thought to be a rare disease, but it's not so. It's a very high prevalent disease and very high mortality, and it's for the very young people. So we will focus on the rheumatic heart disease. And what I thought, I'm working on this society for last 10 years or so. The main thing which is lacking in our society is awareness. People don't know that a sore throat or pharyngitis can lead to a severe heart disease or valvular heart disease. So this is the message which we should convey to all our society, and we should do a strong effort to give this. The pharyngitis is not a minor thing. You should not treat it as nothing will happen if you have sore throat. It's not like that. It can lead to a life-threatening condition. So awareness is the first step in the prevention, and we have made our society, which is known as Rheumatic Heart Disease Awareness Society. I belong to Punjab Institute of Cardiology, Lahore. I'm professor there. Next slide. This is our logo, Rheumatic Heart Disease Awareness Society. This is our phone number, email. You can have all information about the rheumatic heart disease on this website. This is the www.rhdwareness.com. This is our web desk. Next. This is our core team, and legendary Professor Chima Saab, who left us. He did a lot in this regard. Professor Zubair and all other colleagues, which have made this society successful. Next. So these are our small contributions. We meet with the health minister, governor, and all health strategies, but still we are lacking to maintain, to make some program on the government level, which can do a better job for the whole. We are doing on our own as a part of society, but not at the government level. We're trying to have success at the government level. Inshallah, we'll do that. Next. So this is our framework, how we do work. We go to the schools because the target population is school children, 5 to 15 years age group. And we go to the schools of Punjab, all over the Punjab in various districts. And we go to the high schools of boys and girls, both, and convey the message that rheumatic heart disease can occur from a small, which we thought pharyngitis is a minor disease, but it is not so. Next. This is our pamphlet, which we display at the school at the entry point, which is clearly demonstrating the few words that दिल के वैल्स की बीमारी, rheumatic heart, एक जिस्मानी वजह से होने वाली बीमारी है, जो 5 से 15 साल के बच्चों में होती है और ये गला खराब होने से होती है. यह बीमारी दिल के मुतअद्दिद वाल्व खराब कर देती है. इस बीमारी से आसानी से बचा जा सकता है, बशर्ते कि बर वक्त मुस्तनद डॉक्टर से इलाज करवाया जाए. मुकम्मल और मौसर इलाज की सूरत में ये जो सुमा दिल के वाल्व को खराब नहीं करता. इसलिए जब भी आपके बच्चे का गला खराब हो तो इसे मामूली ना समझा जाए और फ़ौरन किसी मुस्तनद डॉक्टर से इलाज करवाया जाए. आपकी ज़रा सी एहतियात से आपको सारी उम्र की बीमारी से तहफ़्फ़ुज़ मिल सकता है। बर वक्त इलाज होने पर मामूली खर्च आपके बच्चे की बीमारी पर खर्च लाखों रुपये और ज़िंदगी भर की मुताजे से बचा सकता है। ये पम्फलेट जो हम स्कूल डिस्प्ले करते हैं कि एंट्री पॉइंट पे, नेक्स्ट, और ये हम बच्चों में डिस्ट्रीब्यूट करते हैं, स्कूल चिल्ड्रन होते हैं में डिस्ट्रीब्यूट करते हैं कि खुद भी पढ़ें, अपने पेरेंट्स को बताएं, जाके अपने कोलीग्स को भी बताएं, ताकि ये मैसेज ज़्यादा से ज़्यादा जो है ना वो स्प्रेड करें। नेक्स्ट, then we go to the DHQs and basic health facilities of the government. We think that not only the children and the school teachers need awareness, but the doctors also need awareness, because doctors think that rheumatic heart disease is not in Pakistan. Even so much so that our health minister, which was ex-health minister, she said that rheumatic heart disease is not in Pakistan. This is not the case, and I think that we should have a major effort on the awareness of the disease. Next. So our goals, which I want to be there for a comprehensive program should be initiated at the government level in all over Pakistan. We can have national-wide rheumatic heart disease prevention program, so we can save our youth from this deadly disease. This disease starts at the very younger age, 9-10 years of the child, and patient dies at 25 or 30 years. So very, very thoughtful thing that we should do a nationwide program to achieve effective measures to reduce the rheumatic heart disease burden, which is 100% preventable. Ischemic heart disease is not 100% preventable, but rheumatic heart disease is 100% preventable. It's on our part that we are doing not the right job. So we should start school health services. This is the prime target of me and my team. We think that if school health services are started, then we can achieve this target. Second point is penicillin V. The main drawback of benzibiotic injection is very painful and anaphylaxis reaction. So most of the doctors do not prescribe benzibiotic, and most of the patient do not take it. And the result is that they have recurrent attacks of rheumatic heart disease, and the disease is so severe in Pakistan. So penicillin V is very cheap. Even syrup tablets are available in America, China, and different parts of the world. And the disease is more in Pakistan, and Pakistan don't have penicillin V. So I think on behalf of Pakistan Cardiac Society, I will urge them to please do something to make available the penicillin V. Third most important thing, which I think is RAD test. RAD test is rapid antigen detection test. It is a clinic-based test which can decide there and then that this patient has streptococcus pharyngitis or viral pharyngitis. If a streptococcus pharyngitis, we should give a proper course of antibiotics that he could not go into the rheumatic heart disease. That test is available in our neighboring countries, but not in Pakistan. It should be available in every general practitioner. So he can decide that, because throat swab culture takes 6 or 7 days, which is too long. So in the clinic, we can rapidly assess that this patient is having streptococcus pharyngitis. We can start the antibiotics aggressively. So RAD test must be available in all our general practitioners. So these are three my points which I want to highlight in this society, that they can help us or help Pakistan in achieving this goal of reducing the rheumatic heart disease. So this is the crux of my all presentation, that these 3 points must be presented in Pakistan Cardiac Society and all the levels which can do something for this. Next slide, please. So this is a brief review of the rheumatic fever and rheumatic heart disease. I think everyone knows about this, but I will rapidly go through it. Why rheumatic heart disease is important? Rheumatic heart disease is the most common acquired heart disease below the age of 25. So look at the age, which is so important. The youth is suffering all over the world. The most common acquired heart disease, says the World Heart Federation. And in 2016, 30 million people are suffering from rheumatic heart disease, which is almost double since 1990. It's increasing, not decreasing, especially in Africa and South Asia. Next. Not only the disease's burden is more in Pakistan and the neighboring countries, but the mortality and morbidity is very high. Recently, we conducted a trial, Invictus trial. We were part of the Invictus trial, and our site has almost maximum number of patients in that trial. That's about 4,500 patient trial that was conducted in 27 countries. 3 continents were involved: South America, Asia, and Africa. And more than 100 sites were involved, and PAC was also the site. 4,500 patients were enrolled, and 1,000 of them died. Look at the mortality: 22.2% patient died over a period of 3 years. And these are those patients which were regularly monitored and managed, and regular follow-ups. So look at the mortality of those patients. And what about those patients who are not going to the doctors even? So what will be the mortality there? It will be higher than 50%, I think so. So each year, 0.6 million patients suffer from heart failure, and the number is being doubled. And one very important point that it involves a younger age individual and leads to lifelong disability in contrast with ischemic heart disease, which is a relatively later age group involvement. Next slide, please. So out of 30 million, 70 million are male and 30 million are female. And in India trial, which we conducted recently, there were 72% female. So it's a disease of females, and it is all important because of a female with mitral stenosis, how miserable her life will be. She has go through the pregnancy and labor and all that. And with mitral stenosis, the mortality is very, very high. A patient with mitral stenosis can't deliver. I think she will go into myocardial edema or complications during labor, and very, very high mortality. And 72.3% patients are female. And female patient of the age of childbearing age group, look at the misery which are having. Next slide, please. So the most important point in the primary prevention is the recognition of viral or bacterial pharyngitis. If bacterial pharyngitis, it should be treated aggressively. And in 80% of cases, pharyngitis is viral. So it's very important which patient to be given antibiotics. And if doubt, you should give antibiotics, whether it is viral or bacterial. Streptococcal infection is 15 to 20% in the world, but in Pakistan, a study was conducted in Karachi. They used a rat test at the general practitioner level, and they found that no, Pakistan have higher incidence of streptococcal pharyngitis. It is 25% cases. Yani 1 out of every 4 pharyngitis is suffering from streptococcal pharyngitis, and it can go into the rheumatic heart disease. Next, please. Next, please. And this is a throat which should not be missed by any doctor. This is a typical picture of streptococcal pharyngitis with the tonsils inflamed and creamy white exudate. This picture, when we see this patient, should give aggressive antibiotics for at least 7 to 10 days to have safety from the rheumatic heart disease. Next. This is the red dots in the uvula and the soft palate. This is the pathognomonic sign of the streptococcal pharyngitis. This is found is a diagnostic. Next. So this is a Centaur score. Centaur score is the most important score which can tell us what is the probability of patient having a streptococcal pharyngitis. So absence of a cough. Coughing child will have a viral or allergic pharyngitis, but a patient who has pain in the throat and extremely painful deglutition, if it has less cough, it means it's a streptococcal. Presence of cough is against a streptococcal pharyngitis. Swollen, tender cervical fluid, just put a hand on the neck of the patient, he will try it. Temperature more than 100 degrees Fahrenheit, tonsil exudates as I have shown in the slide, and age less than 15. How important the age is? The age, the 5 to 15 years age group, one study was conducted in Costa Rica that every child of 5 to 15 years age group, whether he is having viral pharyngitis or bacterial pharyngitis, must be given antibiotics. And they concluded that by giving extra antibiotics to this age group, they reduce the number of rheumatic heart disease. Next. So this is a score which we calculate. We sum up the points which are present in the children and then get the probability without doing any test. So less than 10% probability if the only one point is positive. So nothing is required, no antibiotic, no culture required. If 11 to 2 points are positive out of these 5, then 11 to 17% probability, and we should give antibiotics based on the culture. Culture takes long time. We should go rapid antigen detection test. And number 3, 3 points are positive, then 28 to 35% probability of rheumatic streptococcal pharyngitis. We should go antibiotics depending on the culture or rapid antigen detection test. If 4 or 5 points are positive, then nothing is doing. Straight to start antibiotics. Next slide, please. So as opposed to bacterial pharyngitis, viral pharyngitis has more cough, fever, coryza, everything is running, diarrhea. Diarrhea is more common in viral, and vomiting is more common in the streptococcal pharyngitis. Next, please. So rheumatic fever, once a doctor misses the child for 9 days, there are 9 days to activate the human antibodies against the streptococcal antigen. So within 9 days, we have to treat the child. If we miss those 9 days, then patient will have rheumatic fever. So then the game is over. So I emphasize that on the general practitioner level and as a society, we must give awareness to the doctors and the children that they must get early treatment as soon as they have pharyngitis. Because the time is crucial, we waste initial 2 weeks, then the nature will decide that he is going to have rheumatic fever or not. Doctor can't help much. So this is a immune-mediated disease where antibodies against bacterial hepatitis cross-react with the antigens found in the heart and skin and joint and brains. And after 2 to 3 weeks of bacterial pharyngitis, patient again have fever. And this fever is not pharyngitis, but this fever is due to rheumatic fever. And patient can have a major criteria of carditis, arthritis, skin manifestations, and like that. Next, please. So diagnosis of rheumatic fever, preceding evidence of streptococcal pharyngitis or infection. Swab culture was positive or rat test was positive. Recent history of scarlet fever or rising IS titers of more than 200 units will tell us that patient has recent past has streptococcal pharyngitis. Next, please. And on top of that, these are major criteria. If anyone is positive, then the patient is having rheumatic fever. Carditis, it is present in 50 to 70% of cases. Arthritis in 35 to 66% of cases. It is typically migratory polyarthritis. But recently, in the Australia and New Zealand, they have formulated new guidelines. They said that even monoarthritis or sometimes polyarthralgia is now must be considered as major criteria because most of the people take brufen or some non-steroid inflammatory drugs and they don't present with the arthritis, typical arthritis. So even arthralgia should be taken into account in the major criteria. Sydenham chorea in 10 to 30% of cases, subcutaneous nodule in 10%, and excision marginatum less than 6% of cases.
Excuse me, Professor Wajid, we are short of time. Please wind up your discussion.
I close it up. Next slide, please. These are erythema marginatum patient. Next. Subcutaneous nodules. So these are minor criteria: fever, arthralgia, arteria. Next. So first act is always between 5 to 15 years of age and no treatment, only discipline of steroids, but that is a palliative treatment. Next. Primary prevention is a streptococcal pharyngitis within 9 days of onset of pharyngitis. Antibiotics are the only choice. Next. Secondary prevention includes benzathine, penicillin. And next, please. Cephalosporins, next. Macrolides, next. If patient sensitive to penicillin, then we should use macrolides. Next, please. Duration of therapy: 10 days with penicillin, 5 days with cefoperoxime, Fabrinor or Azomax. Next. Single daily dose of penicillin. Next, please. Penicillin V is the drug of choice. Next, please. So these are secondary prophylaxis, then antibiotics, penicillin V, BD, erythromycin BD, erythromycin 1 gram BD. If patient allergic to penicillin, we can give erythromycin or macrolides. Next. So vaccine not yet available, only antibiotics are the mainstay of preventive measure. Next. So these are the pyramid, triangle, doctors, parents and teachers all on the corner of the child which is 5 to 15 years old. And we as a society must have our effort to prevent rheumatic heart disease. Next, please. So this is our logo, prevent rheumatic heart and have a happy heart. Thank you very much for giving me the opportunity to speak in this forum.
बिस्मिल्लाह, सॉरी फॉर इंटरप्शन। मैं क्या डॉक्टर प्रोफेसर मंसूर को ये रिक्वेस्ट करता हूँ कि वो हमारे जो CEO हैं जनाब अख्तर मोहसिन साहब, उनको शीट प्रोवाइड करें जिन्होंने हमें हर लिहाज से हर जगह पे सर्विस दी है। प्रोफेसर मंसूर अहमद एंड अख्तर मोहसिन साहब।
He is the chief operating officer here who looks after everything. Or his support was immense. I think I just had to call him and things were done. So, Akhtar Mohsin Sahab, in gratitude for his support.
Thank you very much. Thank you for your support. Next.
The next speaker is Professor Zaid Mia. He is a professor of endocrinology in Bakai Institute of Diabetes and Endocrinology. Dr. Zaid Mia, heart-friendly diabetic drugs.
अस्सलाम वालेकुम, थैंक यू वेरी मच। मेरे ख्याल में ज़रा बहुत देर से बैठे हुए हैं, तो ये पीछे वाले लोग थोड़ा सा एक्सरसाइज करो यार। खड़े जल्दी से, खड़े जल्दी, खड़े 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 जल्दी से, शाबाश, जल्दी खड़े हो, खड़े खड़े, शाबाश, do some exercise, जरा हिलो हिलो हिलो, हिलो शाबाश, move on, move on, move on, थोड़ा सा हिलो, वेरी गुड, बस चलो आप जाग गए। चलो ये जगाने का तरीका था ना। अब बैठ जाओ सुकून से, सुन लो जरा, सुन लेना है क्या कहना है, क्योंकि ये जो लोग इस वक्त यहाँ पर आए हैं मेरे अलावा, ये ऐसे लोग हैं जो कभी कभी बोलते हैं और इनको सुनने के लिए लोग तरसते हैं। तो इसलिए ज़रा ऐसे लोगों को आराम से सुनो, उनकी बातों को ज़रा एक्सेप्ट करने की कोशिश करो कि क्या समझने की कोशिश। ओके, सो वो है मेरे पास कुछ। ओके, सो 2 दिन पहले रशीद भाई का फ़ोन आया, डॉक्टर रशीद साहब का, सॉरी, कह रहे हैं ये जाहिद मियाँ तुम्हारी जो टॉक है। मैंने कहा टॉक है? कहेंगे वो प्रोग्राम है। मैंने कहा प्रोग्राम तो पोस्टपोन हो गया था सर। कह लेंगे नहीं तुम्हारी टॉक है। तो मैंने कहा टॉक क्या है? कह लेंगे कार्डियक फ्रेंडली ग्लूकोज लोअरिंग ड्रग। तो मैं समझ गया फ्रेंड का मतलब क्या होता है। तो फ्रेंड का मतलब इन्होंने, रशीद साहब ने ये लिया कि मुझे बड़े 24 घंटे के नोटिस पे ये फ्रेंड का मतलब है, ठीक है। सो द फ्रेंड, so what I will discuss, or in this 13 minutes time, I will discuss, is diabetes a friend to the heart, and what are the cardiac friendly glucose lowering drugs in the past, and what are the cardiac friendly drugs, glucose lowering drugs at present, and what do you mean by a true friend in terms of cardiac drug? And I will not discuss about the other friends. आप समझ रहे हैं इसके बाद मैं क्या कहना चाहूँ। And the other relationship which someone has, हाँ? तो ये इधर उधर की बातें ज़रा सी रोक देंगे आज क्योंकि टाइम नहीं है। So friends, तो बात दोस्ती की हो रही है। तो दोस्ती क्या है? ये ऑक्सफोर्ड यूनिवर्सिटी में और ऑक्सफोर्ड जो डिक्शनरी, ए पर्सन हु हैज ए स्ट्रॉन्ग लाइकिंग फॉर एंड ट्रस्ट एन अनदर। ठीक है, ओ भाई दोस्तों पहले समझ लो दोस्ती होती क्या है, फिर बातें करना। हाँ पहले समझ तो लो दोस्ती क्या है। बस ऐसे बैठ गए, हर बराबर में बैठने वाला दोस्त नहीं होता, ये ख्याल रखना, ये ख्याल रखना। हाँ तो आप समझो पहले दोस्ती क्या होती है। So, what is friend? And एक मिनट खामोश खामोश। And a person who is not an enemy. Okay? So this is friendship, friend. So in terms of medical terminology, so what is friend? In terms of drugs, a molecule with a beneficial effect. जिसका कोई फायदा हो, ऐसी ड्रग। एंड ए मॉलिक्यूल विद नो हार्म, जो कोई नुकसान ना पहुंचा सके। इट मीन्स न्यूट्रल। ये ज़रा मैंने डर के कहा है क्योंकि ये ज़रा आजकल सियासी हो गया न्यूट्रल का वर्ड। तो न्यूट्रल मैं नहीं कह रहा, मैं कह रहा हूँ ए मॉलिक्यूल विद नो हार्म। ओके, सो ये यार खाना बाद में देना यार, खुदा के लिए खाने में लग जाएंगे क्या फायदा। हाँ सो ये फ्रेंडशिप बाद में निपटाना। हाँ अभी हाइपो नहीं हुआ है किसी को और मैं होने भी नहीं दूंगा। ओके, सो लेट्स think about Diabetes is a friend or a foe? भाई दोस्त है या दुश्मन है बराबर में बैठे वाला यार, पता तो हो कि क्या है. So, my dear friends, the people with diabetes, they are 2 to 4 times more likely to have cardiovascular disease as compared to those who do not have this. And the majority of the people with diabetes, type 2 diabetes especially, are at the risk of cardiovascular disease. And about 70% of them are at risk, and the remaining 30% are actually having cardiovascular disease, which is called the established cardiovascular disease. And this risk of cardiovascular disease starts from very beginning. But at the time of diagnosis, जिस दिन diagnosis हुई, that risk actually doubles or triples. And what I am showing over here is the elevated risk of cardiac disease. Whatever the number is, जितनी ग्लूकोज होगी उतनी ही खतरनाक है. फॉर एग्जाम्पल, एक ये ग्रुप है, एक ये ग्रुप है, एक ये ग्रुप है, एक ये ग्रुप है. इस ग्रुप की 80 है, इस ग्रुप की 100 है, इस ग्रुप की 120 है, इस ग्रुप की 140 है. ऑल्दो कि 80 वाले को शुगर नहीं है और रैंडम, और 120 वाले को भी शुगर नहीं है, बट जिसकी 120 है उसको 80 से ज़्यादा रिस्क है, जिसको 140 है उसको 120 से ज़्यादा रिस्क है, जिसकी 150 है उसको 140 वाले से ज़्यादा रिस्क है ऑफ डेवलपिंग कार्डियोवैस्कुलर प्रॉब्लम. सो वी आर टॉकिंग that the people are yet not have diabetes, but they have risk of cardiovascular disease. And sir, आपको याद होगा, DECODE study and the DECODER study clearly shows that in a different tertiles of fasting blood glucose and the random blood glucose, the people are at risk of having diabetes as compared to the others. So, and this is one of the clinical, जैसे आप लोग कार्डियोलॉजी, मैं अकेला थॉर्न हूँ, वैसे तो आप लोग सारे कार्डियोलॉजिस्ट माशाल्लाह गुलदस्ते हैं गुलाबों के, लेकिन अगर आप अपने वार्ड में देखें, दिस इज़ द स्टडी, वेरी इंटरेस्टिंग स्टडी, 3 बहुत इंपॉर्टेंट स्टडीज़ हैं. One is the GAMI studies and the other is the EuroHeart study, and the third one is the Chinese heart study. And what they did at the time of discharge of a patient who has a cardiovascular problem, admission due to the cardiovascular problem. आपके पास होता है ना, एडमिट हुआ एंजाइना के साथ, एडमिट हुआ अनस्टेबल एंजाइना के साथ, एडमिट हुआ MI के साथ, एडमिट हुआ हार्ट फेलियर के साथ, whatever it is. But the patient don't have diabetes, or he don't know that he has diabetes. What they did at the time of discharge, they have done a 75 gram glucose load. क्या किया? जाते जैसे अभी आप लोग जा रहे हैं ना, ये जो डिब्बे दिए हैं आपको, ये 75 ग्राम ग्लूकोज लोड के हैं, और उसके बाद जाने के बाद आप लोगों का 2 घंटे बाद टेस्ट कर लिया रैंडम ब्लड ग्लूकोज. And how interesting are the results here? And you can see over here, the GAMI study shows the 31% are people who do not know that they have diabetes were actually diabetic. And 35% of the people who were not having diabetes, but they are pre-diabetes. So this means about 2/3 of the population who admitted at your hospital and who don't know that they have diabetes, but they have an event. They are actually having a dysglycemia over here. And I'm also working in one of the cardiology setup in Karachi. So they have got the same result over here. So this is what we are talking about. And we are forgetting the heart failure as a complication of cardiovascular disease. And this is one of the latest heart failure and underappreciated complication of diabetes. So the cardiovascular risk is greatest when both diabetes and CKD are present. And my dear friends and colleagues, every 6 seconds, जितनी देर मैंने यहाँ बात की है, 6 सेकंड में एक आदमी डायबिटीज से जा रहा है पूरी दुनिया में. और अब तक जितने बातें कर ली हम लोगों ने, तकरीबन 1400 लोग, 14,000 लोग, नॉट 1400, 14,000 लोग इस वक्त जा चुके हैं डायबिटीज की वजह से. वी आर टॉकिंग अबाउट दिस डब्बास हैं यूनाइटेड किंग के, तो यही दे रहे हैं. Okay, and what is the reason? And the only reason is the cardiovascular problem. So my dear friends and colleagues, तो diabetes friend है या नहीं है? नहीं है. वाह जी वाह, इसका मतलब आप लोग जाग रहे हैं. So let's talk about, are the glucose lowering drugs are cardiac friendly or not? So this is the management of diabetes, which over the period of time will learn much better as we goes along. 2008 से पहले, we have drugs like metformin, sulfonylurea, ठीक है, तो glimepiride भी आ गई थी उस वक्त तक, and we had got acarbose, we have got glitazones. ये 4-5 drugs थी, and we have insulin. 2008. And this was the Cochrane analysis at 2011. And you can see over here, none of these drugs have got the benefit on the cardiovascular endpoints. And you can see the all-cause mortality, no difference. In terms of cardiovascular mortality, no difference. In terms of non-fatal MI, there was some difference, but not statistical difference. And then, on the other hand, the people who have got the intensive control have got the hypoglycemia. And they went into the emergency and have some mortality as well. And there are 4 landmark trials before that for these oral hypoglycemic agent. One is the Eucapedias, the other was the Advance, third one is the VADT and the Accord. And you can see over here, none of these trial shows a macrovascular or a cardiovascular endpoint beneficial. There was no benefit. There's only glucocentric drugs. Apart from one, जिसके सर बहुत, आज थोड़ी सी बात कर लूँ अगर आप इजाज़त दें, तो मुझे मालूम है आप किस चीज़ के फ्रेंड हैं, लेकिन फिर भी. So the Accord was the trial which was done on the rosiglitazone. And rosiglitazone is the TZDA. And what was happened in that Accord trial? There was increased death. So जो ट्रायल था उसको पहले ही बंद करना पड़ गया क्योंकि डेथ ज़्यादा हो गई और कार्डियोवैस्कुलर डेथ हो गई. अब उसके रीज़न बाद में डिस्कस कर लेंगे, लेकिन कार्डियोवैस्कुलर डेथ ज़्यादा हो गई रोजिग्लिटाज़ोन की वजह से. एंड दैट वाज द रीज़न, दैट वाज द टर्निंग पॉइंट इन द मैनेजमेंट ऑफ डायबिटीज़. और वो क्या था कि FDA ने 2008 में कहा कि देयर इज नो मेडिसिन, जो अब नई ड्रग आएगी, दे हैव टू हैव ए कार्डियोवैस्कुलर प्रोटेक्शन. सो द न्यू ड्रग्स which should come, so there is a mandating long-term cardiovascular outcome trial for the safety. They have to be safe for the cardiovascular point of view. ऐसा ना हो कि आपने दवा दी और वो दिल लेके बैठ गया. ऐसा बहुत दफ़ा होता है वैसे तो दिल लेके लोग बैठ जाते हैं. लेकिन दवा की वजह से दिल लेके कोई ना बैठे. So this is what the 2008 FDA recommendations. And after that, there are a number of trials, 18 trials, and 18 new molecules which comes in, and they have to have a cardiovascular non-inferiority. Non-inferiority means, मैंने क्या बताया था फ्रेंड्स का, कि कम से कम हार्म ना पहुंचाए वो, कम से कम हार्म ना दे, यानी कि अगर फायदा नहीं दे रहे हैं तो नुकसान भी ना दे. दैट इज द नॉन इन्फीरियरिटी. नॉन इन्फीरियरिटी इसको कहते हैं. और सुपीरियरिटी का मतलब है उससे जो आपने सोचा था उससे ज्यादा फायदा दे दिया. तो बहुत से जो ट्रायल हैं, मैं इसको देख के डरे नहीं, मैं इसमें से कोई भी नहीं बताऊंगा. सो ये जो 3 नीले ये जो आसमानी कलर के ट्रायल है, ये DPP-4 के ट्रायल है. सो DPP-4 कम आउट एज ए न्यूट्रल. मैं जरा सा हल्की आवाज में, न्यूट्रल. तो न्यूट्रल हैं, यानी दे आर गिविंग नो हार्म टू द कार्डियोवैस्कुलर एक्सेप्ट फॉर द 2 ड्रग्स. One is the algo and the other one the sexa. Luckily we don't have the sexa now, and we don't have the algo over here in Pakistan. तो भी बच गए हम लोग, मरीज भी बच गए. And then we have, oh ये क्या? Is this friendly? हाँ? ये friendly है? बोलो भाई. नहीं है. So this is the Gila monster. Monster का friendly होता है. But my dear friends, this was the first, the saliva of this monster gives an opening, a door to the management of diabetes, which changed the table around. इसके saliva से the first incretin mimetic, the GLP-1 axanidin बनी थी. And that is actually, जो कहते हैं ना, हर देखने वाला दोस्त नहीं होता और हर देखने वाला दुश्मन भी नहीं होता. तो ये दुश्मन नहीं, दोस्त है भाई. सो दोस्त है. एंड ये तो मुझे लग रहा है मेरे घर के बाहर है. ये क्या है? What is this? दोस्त है, दुश्मन है. दोस्त है, दुश्मन है. दोस्त क्यों? सेब का दरख्त. सेब ऐसे भी खाने से दोस्ती होती है. ठीक है ना? तो सेब एक्चुअली दरख्त इस आपका ये जो एप्पल बार्क है, the SGLT2 comes from there. एप्पल बार्क, एप्पल जो ट्री है उसके बार्क से. The SGLT2 comes from here. So these 2 things opens the door for the new drugs in the field of diabetes. और उसकी वजह से अब कार्डियोलॉजिस्ट कह रहा है ये मेरी ड्रग है, नेफ्रोलॉजिस्ट कह रहा है ये मेरी ड्रग है, हेपेटोलॉजिस्ट कह रहा है ये मेरी ड्रग है, सब लोग कह रहे हैं, इंटरनल मेडिसिन वाला कह रहा है ये तो मेरी ड्रग है, ओबेसिटी, मेटाबॉलिक डिजीज वाला कह रहा है मेरी ड्रग है. हम कह रहे हैं ये हम सब का पाकिस्तान है, मतलब ये हम सब की ड्रग है. ठीक है. सो दिस इज हम सब की ड्रग. एंड द 2 ड्रग्स विच कम्स फ्रॉम दिस मॉन्स्टर, मैं बस 5 मुझे 2 मिनट दीजिएगा, मैं वाइंड अप कर रहा हूँ. सो वन इज द liraglutide, the leader trial, the first drugs, first GLP-1 synthetic, recombinant GLP-1s, ये मॉन्स्टर से नहीं आया है, इसको बनाया recombinant है, बट उससे मॉन्स्टर से मदद मिली थी कैसा होना चाहिए. And I will just only discuss the MACE, the 3-point MACE. And the 3-point MACE means the cardiovascular death, the non-fatal myocardial infarction, and non-fatal stroke. And you can see this was the first result which changed the things around for the management of type 2 diabetes. And this is 13% statistically risk reduction in MACE. And also 22% risk reduction in the cardiovascular death as well. And there is also a 15% reduction in the all-cause mortality. इसको देखने के बाद, after looking at these results, now you can see a number of GLP receptor agonists in the market, and they have a wonderful results. And you can see the Alexa, Leader, Sustain, Excel, Rewind, Pioneer. Now we have got the liraglutide in Pakistan, we have got the dulaglutide in Pakistan, we have the semaglutide in Pakistan. These are the drugs which are present in Pakistan, okay, and available in Pakistan. And this they have got, apart from the SEMA, you can see the number of the patient, number of the population in this all trial, huge number of the people, around 10,000 people. And if you look at the whole picture over here, so all of these GLP trial, or cardiovascular outcome trial, has got, you can see they all have got a prior history of cardiovascular disease. It means they all have an established cardiovascular disease. कुछ भी हो, angina, unstable angina हो, or bypass हो चुका हो, stent डल चुका हो, anything, कुछ भी हुआ हो, peripheral artery disease भी इसमें शामिल है. They all have got the leader, semaglutide, and except for the Rewind trial, the dulaglutide, in which 70% of the people were actually at a high risk of having cardiovascular problem. Only 30% are having the established cardiovascular disease. So this means that this trial showing a primary sort of prevention, and the other trial showing that yes, of course, the people who has got the established cardiovascular, they can all be benefited from the GLP-1. So the people who do not have cardiovascular disease can be benefited, and the people who have established cardiovascular disease can also be benefited from the GLP-1. This is a wonderful drug. The only problem with all of these drugs, they have got an injection. Injection से सब डरते हैं. But luckily we have the semaglutide over here, जिसकी tablet भी मौजूद है. Oh, and look at the MACE over here. The leader, and the Rewind and the Sustain, all has got on the MACE, 3-point MACE पे ये तीनों की, only 3 drug has got the 3-point MACE benefit. अभी खोलना नहीं, डब्बे नहीं खोलना, खबरदार, डब्बे नहीं खोले इस वक्त, हाँ, खबरदार. Okay. So now we are talking about the last one. Last दो slide की बात. So the last one, the EMPA-REC trial from the SGLT2 inhibitors was the first one which shows the primary outcome, 3-point MACE benefit, death from cardiovascular disease benefit, death from any cause benefit, hospitalization for the heart failure benefit. So these are the drugs which can change anything. And you can see इसी तरह different trial के population different है. So the dapagliflozin has got a different population. They have got the high risk individual as compared to the empagliflozin who has got all established cardiovascular disease. So the result may be different, but they all benefit. Only the 2 drugs, the canagliflozin and the empagliflozin, only benefit to the 3-point MACE. Okay, but if you look at over here, hospitalization for the heart failure, all of these drugs, SGLT2, कोई भी आप नाम ले लें, DAPA ले लें, EMPA ले लें, CANA ले लें, and R2 ले लें, any of the SGLT2 inhibitor are beneficials. So, my dear friends, these are these. So, with this amount of evidence, with this amount of evidence, the ESDA and ADA has changed their guidelines. Or anyone who has got established cardiovascular disease, he has to have either a GLP-1 or a SGLT2 inhibitors. कोई सा भी होना ज़रूरी है. अगर आप नहीं दे रहे हैं, इसका मतलब you are not doing good for the patient. Unless there is a contraindication. Okay. And similarly, heart failure. Anyone. And the last slide. So ESC also saying this. So what are the true friend are? असल दोस्त क्या है? असल दोस्त वो है कि if you compare the relative risk reduction of 3-point MACE and the cardiovascular death with these drugs, with the statin, cardiologists हैं आप लोग, तो statin से compare कर लें. Now, these drug has got 38% cardiovascular death come as compared to the, you can compare with the statin. They are going with the statin, and in fact, they are giving more benefit to the patient as compared to the statin. Or a friend indeed is a friend in need. यही कहते हैं ना, दोस्त वही है जो वक्त पे काम आए. So the last slide. So the SGLT2 inhibitors, number needed to treat. किसी भी ड्रग का बेनिफिट देखने के लिए ज़रूरी है कि उससे एक कितने नंबर चाहिए हैं, कितने लोग चाहिए ट्रीट होंगे तो एक इवेंट बचेगा. ज़रा गौर तो करें, इसको कंपेयर करें आप एस्प्रिन से, स्टैटिन से और एंटीहाइपरटेंसिव से. जस्ट कंपेयर इट. एम्पाग्लाइसिन 63% नंबर्स चाहिए 3 साल में एक इवेंट बचाने के लिए. स्टैटिन को 83 लोग चाहिए ट्रीट करने के लिए 5 साल तक देंगे जब बचेगा एक. एंड सिमिलरली 125 दिन चाहिए एंटी हाइपरटेंसिव को जब एक आदमी बचेगा. माय डियर फ्रेंड्स, and these are the summary. So these are the beneficial drugs, and the cardiac drugs are the diabetes drugs could save the 1,000 of life. Thank you very much for your patient listening.
My humble request to all speakers, please try and stick to time. We are running almost 2 hours late. Please stick to time. I'm very grateful for that.
Thank you, Zaid Mia, for your friendly style of teaching. And, and the next speaker is Mr. Nawaz Lashari, Professor of Cardiology at the Dow University of Medical Sciences. And his topic is GLT2 inhibitor in prevention and his role in the heart failure. Dr. Nawaz Lashari, please.
कितने टाइम में ख़त्म कर? बिस्मिल्लाहिर्रहमानिर्रहीम. मेरा ख्याल है आप सारे बॉक्स ले लें और ईट शुरू कर दें, और बट बी क्वाइट. सो एनर्जी होगी, देन यू लिसन मी प्रॉपरली. सो फर्स्ट ऑफ आई विल congratulate Professor Mansoor and Professor Abdul Rashid Khan for excellent arrangement regarding the prevention of the cardiovascular diseases. So my talk is the how the SGLT prevent the heart failure. किसकी भाई स्लाइड्स लगा दे? सारी मेरा ख्याल है स्लाइड्स किसी और चेंज कर दी है इसने. सो हाँ वही ना. सिफारिश हो रही है कि आप वर्बली बोल दें, नो प्रॉब्लम। एक्चुअली SGLT inhibitors, how they prevent the heart failure. As you know, what's the problems going with the patient with heart failure? The one is that there is a decreased myocardial contractility. Other is the decreased relaxation of the muscles. This leads to the diastolic dysfunction. And other problem is the increased volume in the body. And if this is not maintained, this affect the kidneys. And this leads to the vicious cycle. That's we call the cardio-renal vicious cycle. And this all is precipitated by the diabetes mellitus. So मैंने एक स्लाइड लगा इसमें इंसर्ट किए थे the how the research was started. Already Dr. Zahid Mia said these are some group of the member of family who has a mutation and they develop the diabetes in spiders, and they saw that patients who develop the diabetes in spiders, instead they control their blood sugar, although their blood sugar is not normal, but they are excreting more sugar in the urine and their kidneys remain normal. Second, ये जो डॉक्टर जाहिद मियाँ ने कहा ना कि आपको एप्पल सीडर, एप्पल जो है ना बाहर की यूज़ करें, प्लीज़ डोंट स्प्रेड दिस आउटसाइड, क्योंकि बाहर कोई ना कोई एक स्टॉल लगा देगा एप्पल के बाहर का, वो सब डायबिटीज़ वाले मरीजों का ये खा लें क्योंकि फलाने डॉक्टर ने कहा था आपकी शुगर कंट्रोल हो जाएगी. Although it's right, this is the actually basic invention regarding the new introduction of the drugs. प्रॉब्लम उसमें क्या था, दिस इज लेस बायोबिलिटी, आप जितना भाग लेंगे अवेलेबल ड्रग कम होगी एंड दैट्स लीड्स टू मोर साइड इफेक्ट्स. दैट्स इम्पॉर्टेंट. एंड एक्चुअली दिस वाज आल्सो यूज्ड फॉर द हॉर्सेस. हॉर्स को जब ये खिलाते थे तो दे बिकम स्मार्ट एंड बिकम मोर एक्टिव. सो दिस इज द बेस्ट बैकग्राउंड ऑफ दिस ड्रग. हाउ SGLT inhibitors, they prevent the heart failure. As you know, they cause the glycosuria, means cause the excretion of the glucose in the urine. Where they act on the proximal convoluted tubules. As you know, the 100% or 90% of this glucose is reabsorbed from that, and this drug acts on that. Why not this normally? This is actually 180 is the threshold of these tubules. If the sugar become increased, they cause the reabsorption, they cause the excretion. If this remain less than 80, 180, it means they doesn't cause the excretion of this sugar. So that's the beauty of this drug. It means causing the diuresis but doesn't cause the hypoglycemia. That's a very important thing that should be. So if the diuresis occurs, this causes the decreased volume in the body, and in decreasing the volume in the body, it's also decreasing the cardiac cell edema also. So once you decrease the cardiac cell edema, they causes the more contraction of the myocardium. So means you are increasing the contractility of the muscles. Second effect of the diuresis is that they decrease the blood pressure. And third is they control the blood sugar. If you control the blood sugar, they cause the decreased oxidative stress. But these are actually not effects which are useful for the prevention of the cardiovascular disease, cardiovascular death. These are other effects which are very important. Cardiovascular death. What are those? Actually, they increase the lipolysis also. What is mean by lipolysis? They cause the breakdown of the lipids in the body, especially skinny lipids. What do you mean by skinny lipid? In the central obesity, thigh muscles, liver protein, lipids. So this drug causes the lipolysis of lipids in that side. And with what is the benefit of that lipolysis? One, they decrease the weight. So you decrease the weight, and in addition to that, they cause the more ketone bodies in the body. As you know, the ketone body is the cheapest fuel used for the production of energy in the body, especially when there is a decreased oxygen, when there is a decreased nutrition, especially in the heart failure. So these are the some effects, and most important also, once the patient with heart failure, their cells, they become weak, and their mitochondria, they also become weak. They cause the more autophagy, means they cause a more engulfing of these raw material in the cells, give chance to come others and make the energy system in the body. So these are the actually major effects of the SGLT inhibitors. They cause the prevention of the heart failure. But when you use these drugs, always look upon the cost, affordability of the patients, and then always look for the side effects of the drugs, because every drug has the side effects. And be cautious, especially in the patients who are hypoglycemic or who has hypovolemia. Sometimes already patient is a high dose of diuretics and you are using this drug, they cause the hypovolemia, and this cause the renal deterioration in this patient, especially patients who are going for the surgery. So, and always ask about the history about the urinary symptoms when you are starting these drugs, and do the blood test, especially urea creatinine in these patients. See the GFR and the creatinine level in these patients. If there's less than 30, be cautious in these patients, and especially in end-stage renal diseases. Finally, if you control the diabetes in relation to level of glucose, in relation to the level of the oxidative radicals or volume, and then you encourage the patients of the heart failure for the exercise. This is very important. Increase the muscle mass of these patients. And this also cause the increase in the cardiac output, and they cause the reverse modeling of the heart. Reverse modeling means they decrease the size, thickness, and they decrease the fibrosis of the muscle. So make the heart healthy for the life. So thank you very much for your attention. Unlike my slides, I don't think so. So again, thanks for this. So use the drugs, always look the safety and keep eye on the precautions also, any drug. Thank you very much.
Thank you, Professor Lashari. Now, at the last, I will invite to Professor Bilal Moeddin for his talk, Stroke and Prevention in the Patient with Non-Valvular Atrial Fibrillation. Professor Bilal is Professor of Cardiology at the Gangaram Hospital, Lahore.
हाँ ये चल रही है साइडें या ये भी बंद है चल पड़ी अच्छा ये हुक्म क्या है 10 मिनट का 5 मिनट का चलिए मैं वो टाइमर ऑन कर रहा हूँ अपना ताकि ये मुझे उससे कोई फ़ायदा नहीं ये अपना basically the issue is that if you are in atrial fibrillation you are prone towards a condition which is called thromboembolism. Thromboembolism is basically a condition in which जिस्म के अंदर कहीं एक खून का लोथड़ा बन जाता है और वो जाके आपकी किसी मेन वेसल को शट डाउन करे. So that thing then leads to stoppage of blood supply. So for that reason, this becomes an important talk. Firstly, I would like to thank all the organizers for giving me this opportunity and asking me to come in. And this is my disclosure that Bayer has helped me out with this whole program over here. So, can anyone have a look at this ECG? This is something that we all see every day, and this is the one which scares us away. एक होती है जिसमें ECG बिल्कुल तेज होती है. Heart rate is going at 120, 130, 140, and you know you have to slow it down. But when you have these ECGs coming in, when the heart rate is apparently well controlled, but the patient has a problem. And this problem that this patient developed, he was a diabetic, elderly gentleman, और कोविड के दिनों ने हमें एक ये चीज़ सिखाई कि पहले आप लोग फिल्में दे दिया करते थे, एक्सरेज बन जाती थी. कोविड के दिनों ने हमें ये चीज़ सिखाई कि इतना ज़्यादा केसेस के एक्सरेज होते थे तो मोबाइल से तस्वीर खींची दे दिया. डिजिटल कैमरास का ये फायदा है. If you look at this thing, you see something. For the young people over here who may not be able to understand this whole thing, this part of this gentleman, mind you, this pen sort of walked in, had a problem, but sort of walked in, and had a stroke about 4 years back. This is an old stroke. And this one is of the middle cerebral artery area. But up to this part, stroke is above the interior cerebral artery, up to about this part is the middle cerebral artery, and this is a very big middle cerebral artery involvement. So जब ये मरीज़ आपके पास आ गया और आपने इसको देखा और उसको जब एग्जामिन किया गया तो he had those weaknesses and he was gradually improving. But the biggest problem that person had, he did not have a gag reflex. और अगर आप इस गैग रिफ्लेक्स की अहमियत को समझो, आप रात को सो रहे होते हो, something comes up, you cough it out. This person would inhale it. So what a simple thing, yet such a big problem. And this person today is admitted in my adjoining unit and is gradually improving with this thing all. So जिस वक्त आप बात करते हैं anticoagulation management की in order to make sure that this disease in this person does not progress, and mind you, we did an echocardiogram on this patient. LV size is normal, LA is normal, right? And you do not say that you see any thrombi over there. There is a 20% stenosis in both the carotids, which may then actually be responsible for causing all this problem. So सवाल ये है कि भाई करना क्या? 3 minutes have gone. So we quickly have a look at it, and we had these various trials which were done, basically talking about 2 or 3 medicine, dabigatran, apixaban, and all of them came in, and they all had a trial studies to see कि भाई क्या होता है. In these trial studies, the rocket atrial fibrillation trial, which actually was done in high risk population. आप पॉपुलेशन को कैसे स्क्रीन करते हैं? पॉपुलेशन को स्क्रीन करने के लिए कैलकुलेटर्स अवेलेबल है. एक कैलकुलेटर पहले आया, उसका नाम था चैट स्कोर, CHAD करके ना, उसमें क्रॉनिक हार्ट फेलियर था, हाइपरटेंशन थी, एज किसकी थी, डायबिटीज़ थी, और फिर स्ट्रोक का इशू था. फिर उसका चैट वैस्क आ गया, उसका फर्दर असेसमेंट्स आ गई, एज एंड पीपल हैड हाई रिस्क स्कोर्स. एंड देन यू हैव दिस the bleed scores coming up. So all of these things were actually are there to help you decide कि इस मरीज के लिए करना क्या है. So these trials, when you go through them, you can have an analysis, but I just go through this rocket trial a little bit. This is a very high mean score. Usually जितने भी trial studies होती है ना, वो 2.5 के ऊपर हो रही होती है. इसका 3 का स्कोर के ऊपर उन्होंने trial studies conduct की. And they had these 2 dosages of 20 milligram and 15 milligrams, and in all of them they showed that this medicine had a benefit. The real part actually comes down in one of those later slides is when they say that all medicines cause bleeding. But the question is basically, which medicine causes less intracranial bleeding? You see, GI bleeding agar ho jaye, so it is something which is relatively easier managed because you have a place to go in. But if you have an intracerebral bleed, it becomes more challenging because many times it just can't be assessed to. And if you look at all these patients that were there, they all had these big groups in all of these trials. But this one, the rocket one, had more rough patients coming in. That is to say that 3 to 6 risk factors were there in most of their patients. Similarly, in the other trials also, and the points about these trials to be remembered was that look at all the maximum number of patients being taken up. Mean age 73, everyone was in heart failure, a lot of patients had hypertension, a lot of patients had even 55% had a prior stroke. thus actually giving you a confidence in a medicine that this medicine can be relatively safely used. Yes, but it does cause problems. These trials of this medicine have been done in various parts of the world. Even Pakistan was one of them in this Xanep trial. And if you go into the literature, you can just have a look at it. Same thing over here. All these various things, the Rocket trial and Xantus trials, they showed that the things were involved. But do remember that as far as the CHAD scores were concerned, with 0 to 1, they did not have anyone. Everyone was with a problem that was included in it. Similarly, all of these perspectives were taken up, and that is how the whole thing was looked at. And we started gradually developing a concept. अच्छा फिर आप करते क्या? आप अपनी मार्केट को देखते हो. हमारे पास यहाँ पे कौन सी चीज़ें अवेलेबल है? हमारे पास ज़्यादा रिवारोक्साबैन अवेलेबल है और एपेक्सिबैन अवेलेबल है. And then you start looking at these things that which is easier to use. The same thing over here in various trials that all showed that the stroke rate, etc., despite this 3.5, it was still over here. And these other trials were, the benefits were seen. Now, whenever you will be asked to decide which management you need to do, you will always be asked to look at the fact that which drug can cause more bleeding. And it is from there that you start assessing. And everyone pitches against warfarin. अच्छा, warfarin के साथ मसला क्या है? Warfarin is affected by diet. Warfarin is affected by so many other factors in your life. These medicines, which are called the novel oral anticoagulants, इनका effect उन चीज़ों पे कम है. Thus, the reliability of a medicine is improved. Reliability is something which is extremely essential. कि आपको ये पता है कि यार ये गोली खा ली इसका फ़ायदा है. शर्त सिर्फ ये है कि वो गोली असली हो, जाली ना हो. अगर वो जाली गोली है तो again you really don't know because there is no way of assessing this or finding it out. Thus, the whole concept of proper therapeutics over here. The same thing was noted on of these various trials, and most of you have seen these trials before. The VKA trial, the vitamin antagonist, the warfarin, and the rivaroxaban, thereby the primary endpoints were better over there. इस चीज़ को देखो ध्यान से सारे गौर से कि आपके पास ischemic strokes, TIAs and myocardial infarction की probabilities क्या हैं. So you are using warfarin, the probability is higher. You are using these novel anticoagulants, the probability is better. So you have a medicine which all the trials are. आजकल कोई trial जो करते हैं ना सारे, कोई superiority trial नहीं करता, उसको डर लगा होता है कि मैं superiority prove नहीं कर पाऊंगा, मेरी दवाई बैठ जाएगी, इसलिए वो non-inferiority trials करते हैं सारे. So you have a trial which actually suggests that this medicine is superior. आपको अपने वो थोड़ी सी percentage ही को improve कर पाओगे. These are all those things, you have to read them out properly and carefully. 10 minute हो गए. So in short, the bleeding outcomes are related to patient characteristics and not to the drug. The thing about is that एक दवाई का क्यों है? वैसे सारों दवाइयों से फायदा है, मगर एक में bleeding के chances relatively कम है. You have this HS has blood score, and that also has the same thing. That all comes out with the same answer. A head-to-head analysis. Now, these are the difficult things that people do. And a lot of matched analysis was done. इनके आप देखें तो ये सारे scores बराबर हैं. At the end of the day, it all actually says that this medicine, as compared to apexaban, has a better result. And the reason why it has a better result is this: that the probability that the person is going to be taking the medicine regularly is better over here because it is OD medication. Once a day. Wo twice a day. So it's a twice a day versus once a day. And that is why this medicine becomes sort of superior to that other medicine. So for those who are interested to find out उस मरीज के साथ हुआ क्या, उस मरीज की वो ट्रीटमेंट दी गई, कार्डियोलॉजिस्ट ने दी, and the heart rate stabilized. And the heart rate and became into a sinus rhythm. But remember one thing, as a young physician, I was told this, and at that time this was a relatively new thing, but now everyone knows this, that when a ECG says sinus, it does not mean that the atrium is contracting. Normally, an atrium takes some time later to come back. तो जैसी साइनस में आया उसका ये मतलब नहीं हो गया वो रिस्क से बाहर निकल गया, वो अभी भी रिस्क में है. Echocardiography is your tool which helps you to make up this opinion, is the patient in true sinus or not in sinus. So that is why the reason that the echocardiographies are repeated in these patients many a times. And when you want to start these medicines is the next question. This is basically a neurologist's game, but the way we do it is, okay, in the very acute phase of stroke, you do not start medicine. You have to wait. Why? This is the thrombus which has gone there and it can bleed inside. So you give a medicine which causes bleeding, it may worsen the situation. So depending on the size, there are various studies. I understand a new study just came out in May this year, in the up-to-date if you want to go and have a look. And that will give you some timing concepts. But basically, you have to play safe so that tomorrow you can do a better job. And with that, I'll say thank you. I took 2 extra minutes.
Thank you, Dr. Bilal Moeddin. No, at the last, I will invite to Professor Yusuf Kamal for his final expert opinion in the metabolic disorder and its effect on the cardiovascular.
Thank you. Dear students, residents, Assalamu alaikum. I am the last man. I am not going to bore you. There are going to be no slides, no nothing. You are going to be with me in the discussion which we are going to have as a summary. The difference between all the excellent past speakers and myself is the years of experience. You cannot beat that. Like Dr. Bilal and Dr. Hamid, we are graduates from King Edward Medical College. And the beauty of King Edward Medical College in our times was we had tremendous clinicians. Then we went to, and all your colleges here had ex-King Edward people teaching you. But the beauty of the thing was that they taught us always question why and when and where. You know, that's just good. 50 years ago, I'll pose a question to you which I was asked. कि gout में toe में क्यों दर्द होता है 50 years ago और किसी जगह क्यों नहीं होता? Can anybody answer? toe में क्यों होता है बाकी क्यों नहीं होता? Why aren't you answering this? Because you never questioned it. That's my point. They taught us why. They taught. Can anybody tell, or should I tell you what it is? Toe is the most distal part from the heart. The circulation is slow there. The temperature is cold there. Uric acid precipitates at 6 milligrams. That's the answer. Those were the type of people who taught us, and then we went to States and England and sharpened our education and came back. So we have best of both worlds in that sense. You send a case of backache to a neurologist. I'm building up there's a reason for it, with a backache. What is the first thing the neurologist or neurosurgeon do? MRI of the back. Will it change the treatment? What is he looking for? 20,000 आपकी पॉकेट के हल्के हुए. They taught us कि straight leg raising करो. अगर आप straight leg raising 90 degrees कर सकते हो तो disc नहीं हो सकती. But do we ever do it? You see what I am trying to say? So anybody, we talked about diabetes, we talked about hypertension. Can anybody define diabetes? Can anybody? But if you don't do it, then फायदा कोई नहीं सारे सेमिनार का. डॉक्टर मंसूर ने इतनी मेहनत की, डॉक्टर रशीद ने, कि पर्पस के लिए ना. तो आप प्रिवेंशन ट्रीटमेंट कर रहे हो, लेकिन डिजीज का भी तो पता होना चाहिए. What is, yes, please stand up. Yeah, can you give me the microphone, please, so everybody can hear? ये माइक्रोफोन दे दीजिए. मैंने कहा ना, there will be no slides. It's just a discussion and a take-home message. I want you to, when you go home, you should have a message.
Uncontrolled blood sugar.
Why? It doesn't, it can be due to what?
Due to beta cell defects.
Okay, partly correct, but it's uncontrolled. Anybody else can improve upon it? It's a good start. Yes? Okay, but why? You haven't defined it. Why? Why? Diabetes is partial or complete absence of insulin due to a variety of factors, which could be autoimmune disease, it could be weight, it could be environments, it could be genetic, and the most important thing is insulin resistance. That is the cause of type 2 diabetes, autoimmune type 1. So it's partial or complete absence of insulin due to a variety of factors leading to hyperglycemia and leading to inflammatory vasculitis. It's not only for 100 years, do you know that we have been only treating the hyperglycemia? 100 years तक. Till 2008, हम insulin use करते थे, sulfonylurea use करते थे, metformin, only to reduce the blood sugar, in the hope कि blood sugar reduce करेंगे तो हम complications reduce करेंगे. But never happened. It never. 15% improvement हुई थी सिर्फ cardiovascular, only 15%. Then in 2008 they realized कि भी drug की safety भी देखनी चाहिए, जैसे डॉक्टर जाहिद भी, और उसके बाद फिर 218 के बाद देखे कि इनका क्या फ़ायदा जब तक कि कार्डियोवैस्कुलर और रीनल बेनिफिट्स ना हो. इसी तरह आपकी हाइपरटेंशन में when we were practicing, the tenormin and Tenoret was still the best medicines for control of blood pressure even today. But they had no cardiovascular benefits in the end. So now, when you are treating a disease, the first question you should ask yourself, why am I treating diabetes? Are you treating diabetes to keep the blood sugar level 120 and 110? Is that the reason? Why are you treating diabetes? Anybody else? Come on, answer this question. Why are you treating diabetes? I want the young residents and young doctors to think in that term. Anybody? Disappointing. आपको पता ही नहीं है कि आप क्यों ट्रीट कर रहे हैं. वो जी मैंने कहा ना, it's not going to be a lecture, so take जी exactly. जब आपको ब्लड प्रेशर है तो ब्लड प्रेशर की वजह से पीछे पंप को क्या हो रहा है और आगे ऑर्गन्स में जहाँ ब्लड नहीं जा रहा ठीक उनमें क्या हो रहा है और ब्लड वेसल्स में क्या हो रहा है. सो हाइपरटेंशन में आप जब दवाइयाँ देंगे तो सिर्फ ये नहीं देंगे कि ब्लड प्रेशर कम है, आपको पीछे पंप का भी ख्याल रखना पड़ेगा, आगे ऑर्गन्स का भी ख्याल रखना पड़ेगा. इसी तरह डायबिटीज़ में अगर डायबिटीज़ की आप ट्रीटमेंट आपने करनी है तो एक तो प्रिवेंशन है ना, हेल्थ स्टाइल, लाइफ स्टाइल और ये वाला नहीं, आपने 5 चीज़ें प्रिवेंट करनी है. आपने पेरिफेरल आर्टरी डिजीज़ को कंट्रोल करना है, आपने ब्रेन की वेसल्स को कंट्रोल करना है, आपने हार्ट की वेसल्स को कंट्रोल करना है, आपने नर्व्स को कंट्रोल करना है, आपने किडनीज़ को कंट्रोल करना है. जब तक आप ये नहीं करेंगे तो यू आर अ शुगरोलॉजिस्ट, यू आर नॉट अ डायबिटोलॉजिस्ट. This is the message I want you to carry when you go back, that when you treat a case, whether it's hypertension or it is diabetes, you have to give the preventive side in it. If the person has comorbids, then you double the prevention measures. But if he doesn't, every case of diabetes is a potential cardiac risk equivalent. जब हम मेडिकल स्टूडेंट थे तो फास्टिंग ब्लड शुगर किंग एडवर्ड में हम 130, 140 एक्सेप्ट करते थे. उसके बाद 126 हुआ, फिर 110 हुआ, अब 100 है. Anybody? Why? I asked this question in an endocrinology conference and no doctor answered. एक आदमी की जरूरत थी, उसने आंसर किया कि नहीं जी ये तो फार्मा वालों का चक्कर है, जितना कम करें उतनी दवाइयाँ ज़्यादा इस्तेमाल. But at least he answered. Anybody? Can you say why 100? Why not 95? Why not 105? ये जब तक जज्बा आपके दिमाग में इंक्वायरी का नहीं होगा, you can never become a good doctor. Always question a move. Why? Shall I tell you or you are going to tell me? It is at 100 that you detect in retinopathy. आप न्यूरोपैथी नहीं दे सकते, नेफ्रोपैथी नहीं दे सकते, लेकिन रेटिनोपैथी आप आँख के अंदर से देख सकते हो. ये अलहदा प्रॉब्लम है कि आप जितने बैठे हो आपकी जनरेशन को मैक्यूला देखना ही नहीं आता. हमारे ज़माने में IENT was a subject. We had to see the macula, we had to see the vessels, we had to define the vessels, we had to see the cone of light, we had to do everything. But younger generation में they send it to the eye specialist to see. So it is, and so what does it mean कि pre-diabetes 100 से start हुई? It means कि microvascular complications have already started in diabetes. लेकिन उसका ब्लड शुगर 100 है, आप ट्रीट करेंगे? नहीं करेंगे ना, नहीं करते. हम ट्रीट करते हैं जब 126 से ऊपर हो जाता है, और इसको 7 साल लगते हैं. 7 साल के अंदर हम पेशेंट को कहते हैं नहीं बस मिठाई ना खाओ, वर्जिश करो. और ये when you, or why this happened? आप उनका इंसुलिन लेवल देखें तो इंसुलिन लेवल 24 से ऊपर होगा. इट मीन्स कि कमी नहीं है इंसुलिन की. Have you ever thought of it? And yet we give sulfonylureas and drugs which stimulate the beta cells to produce more insulin. But insulin is already high. What is the problem is insulin resistance. That is the problem. और अब ये जो नए ड्रग्स आए हैं इनमें इतने कार्डियक बेनिफिट्स हैं, रीनल बेनिफिट्स हैं, लेकिन अभी भी हम 40% तक इम्प्रूवमेंट कर चुके हैं. Why not 100% बेसिक 40%? 100% इसलिए कि अभी तक हमने कोई डिस्कवर नहीं किया ड्रग जो कि इंसुलिन रेजिस्टेंस को ब्रेक करे. और जब इंसुलिन रेजिस्टेंस ब्रेक होगी, इंसुलिन रेजिस्टेंस होती क्यों है? एनीबॉडी? एनीबॉडी? जी जी, कौन से रिसेप्टर? Insulin resistance occurs because of adiponectin-leptin mechanism. Adiponectin के receptors होते हैं, और वो adiponectin के receptors active नहीं होते तो insulin resistance होती है. That is why exercise करें तो white fat changes into brown fat, which is metabolically active. So इसलिए लास्ट मेरा जो मैसेज आपके लिए है कि जब भी कोई डिजीज़ ट्रीट करें तो प्लीज़ आस्क द क्वेश्चन व्हाट इज़ द डिजीज़, एंड देन what that disease is going to do. So treat not only the disease itself, the figures, but also treat the complications. Thank you.
Thank you, Professor Yusuf Kamal, for the concluding remarks. May I request it to Professor Mansoor Ahmed to please come on stage.
I think not concluding remark, just a little announcement. This session is now closed. We have, in fact, we had an hour-long session on Google Scholar, but since we have short time, what we'll do, we'll ask Dr. Masood here. He's an expert on Google Scholar. At least he can give us an instruction for 10-15 minutes before we pass on to all the red ladies. Oh, there is one not so red, but majority are red. So, Masood, please. And thank you so much for being here. Over to Masood for your, I think this I thought was one of the most important sessions, but unfortunately, time is so short. Aye, Masood, come over.
जी थैंक्स अ लॉट. और जैसे बात हुई तो अच्छी ख़बर और बुरी ख़बर ये थी कि टाइम स्लॉट के अंदर 45 मिनट्स लिखे हुए नज़र आ रहे हैं आपको मेरी तकरीर के, जिसके लिए मैं आ गया हूँ. और अच्छी ख़बर आपके लिए ये है कि आई वॉज टोल्ड टू कम्प्लीट दैट जस्ट अ डिस्कशन नाउ फॉर 10 मिनट्स, लेकिन आई ट्राई टू बी ब्रीफ एंड आई फिनिश इन 5 मिनट्स और सो. So that's a wonderful thing for you, and you can enjoy that thing. One thing from all, mostly my colleagues and the juniors, do you know what the Google Scholar can do? Anyone? Article search, wonderful. One thing is done is it was a search engine, yes. And Google Classroom, okay. Google Classroom is the product of Google, yes, but not Google Scholar, yes, of course. Okay, more. Let me open my browser, and if I can write, difficult to look from there and there. Okay, this is the window of Google Scholar. So let me say. Okay, so one thing that it's a search engine. Any more? That is a major things for us. We have seen a wonderful presentations of different speakers who talked about the latest in the research. We talked about New England Journal of Medicine to Lancet to all others, but we need to learn to do that research our own self. उस रिसर्च को सीखने के लिए हमें बहुत से टूल्स और चीज़ें, नॉलेज और स्किल्स दोनों चाहिए. बहुत सारी चीज़ें ऐसी हैं जिसकी कॉस्ट होती है. SPSS आपको सीखना है, इवन सॉफ्टवेयर की भी कॉस्ट है, आप बाकी सीखना आपकी अपनी जगह. बट व्हेन वी टॉक्ड अबाउट मैनी डिफरेंट थिंग्स विच आर फ्रीली अवेलेबल, गूगल के कोई पैसे हैं, इट्स अ फ्री. सो ऑफ कोर्स प्लान तो 1 घंटे का था, बट आई एम नॉट गोइंग टू शो यू ऑल अदर थिंग्स. लेकिन मैं आपको सिर्फ फीचर्स बता दूँ गूगल को. अगर आपने गूगल स्कॉलर को लेना है, और अभी तो खैर इतना ही टाइम मिलेगा, मैं ये बता दूं. नंबर 1, अपार्ट फ्रॉम सर्च इंजन, हम में से कितने लोगों को वैंकूवर स्टाइल में रेफरेंस लिखने आते हैं, या APA स्टाइल में, या MLA स्टाइल के अंदर? गूगल स्कॉलर आपके लिटरेचर हर पेपर पे एक क्लिक के ऊपर वो सारे रेफरेंसेस उस फॉर्मेट के अंदर आपको दे देगा, जिसको आप कॉपी पेस्ट कर लें माइक्रोसॉफ्ट वर्ड में. इवन आप लोगों में से जो लोग एंड नोट इस्तेमाल करते होंगे वो एंड नोट के अंदर एक्सपोर्ट कर लें. इसी तरह और आगे चलें तो हम और चलते हैं. तो हम लोग कितने लोग, अभी सर ने तो बात की कि सर को बायर वालों ने एक ज़बरदस्त कॉन्फ्रेंस के अंदर लेकर आ गए, जो कि ऐसा ही काम करने चाहिए इंडस्ट्री को. लेकिन हम में से अगर चाहती हूँ कि हम लिटरेचर कर रहे हैं और सर्च कर रहे हैं, और हर महीने कोई शख्स हमें उसके रीसेंट रेफरेंस डाउनलोड करके दे दे, तो क्या बायर वाले या कोई और कंपनी वाले हमारे लिए काम करेंगे, या सोहेल यूनिवर्सिटी कर लेगी ये काम? सोशियोमेट्रिक का डिपार्टमेंट होता है मुख्तलिफ यूनिवर्सिटीज़ में. अगेन गूगल स्कॉलर के ऊपर अगर अलर्ट के अंदर जाएं तो ये फ्री के अंदर आपको ये सर्विस मिलती है. और अगर मैं सिर्फ अगर ये मे बी अगर ये चल पड़े, दरअसल इस वक्त लैपटॉप भी मेरे सामने नहीं है ना, तो इट्स अ डिफ़िकल्ट वे टू डू. ओके, यस, ओके, आई हैव रिटन समथिंग. अब इसके अंदर ओके, आपको सिर्फ दिखाने के लिए मैंने एक सिर्फ टर्म सर्च किए. अच्छा, रेफरेंस मैंने आपको करना बताए थे, ये देखें, इस रेफरेंस को मैंने साइट का बटन दबाया और इसने हर तरह के रेफरेंसेस आपके सामने रख दिए. कितनी देर लगी इसमें? ठीक है, जस्ट द वे. और दूसरी चीज़ जो मैं आपको बताया, मैं कॉग्निटिव लोड थ्योरी पर रिसर्च करना चाहता हूँ. दैट इज़ माई इंटरेस्ट. फॉर एग्जाम्पल एज एन एजुकेटर, अगर मैं इस पर फॉलो करना चाहता हूँ और मैं चाहता हूँ कि इसके लेटेस्ट आर्टिकल मुझे हर हफ्ते आ जाएँ, तो क्या करेंगे? अभी तो कुछ नहीं करेंगे, आप सिर्फ आके ये क्रिएट अलर्ट का बटन यहाँ दबा देंगे, आपकी विंडो ओपन कर देगा, अपना ईमेल एड्रेस डाल दें, एवरी वीक द लेटेस्ट इन दैट टॉपिक पब्लिश वर्ल्ड वाइड वेब आपके इनबॉक्स के अंदर आएगा. तो सिर्फ आपको कुछ 2 फीचर्स दिखा रहा था मैं कि इसके अंदर आप इसके जाएँ. इसी के साथ अब जब हम बात कर रहे हैं तो बहुत से पेड आर्टिकल होते हैं, बहुत से फ्री आर्टिकल होते हैं. एक वक्त में एक आर्टिकल जब पब्लिश होता है तो दुनिया के अंदर बहुत सारी जगहों के ऊपर जाता है. फॉर एग्जांपल अगर मैं बात करूं, एलिज़वेयर का ये पेपर है कॉग्निटिव लोड थ्योरी का. लेट्स सपोज इफ़ वी वांट टू रीड दैट पेपर, ओके, इसके अंदर तो पूरा परचेज PDF, ओके, कितने का है? 40. क्रेडिट कार्ड 10,000 रुपए का. ओके, तो आपने देखा एक पेपर विच इज अवेलेबल फॉर दैट कॉस्ट. लेट मी गो बैक to the cognitive load theory, and there are 14 versions of this paper is available on World Wide Web. Let me click into these 14 versions, and if I'll try, for example, this one, $40 just now in your browser. मुस्कुराने के चलें, हाँ मुस्कुरा भी लें आप लोग, बिल्कुल सही है। तो आपने दिल मांगे मोर। तो आपने देखा गूगल स्कॉलर को अगर हम देखें, ओवर देयर आर सो मेनी फीचर्स इवन नाउ। लास्ट एक चीज़ मैं बोलूँगा और इसके बाद मैं यहाँ से गायब हो जाऊँगा आपके सामने से। इस वक्त दुनिया और हम सब एज अ जूनियर, हमें उससे दुनिया स्टार्ट हुई थी टू बिकम promotion and to become at a higher level 5 research articles. Then we talked about 8 research articles, then 12 research articles. Now HEC said 15 research articles. हम लेकिन अब दुनिया इसके ऊपर बात नहीं करती और इवन HEC में भी ये बातें हो रही हैं। अब क्या कहा जाता है? फैक्टर्स। जर्नल्स के लिए इम्पैक्ट फैक्टर, आई बिलोंग टू अ जर्नल विच वी हैव द हाईएस्ट इम्पैक्ट फैक्टर फॉर लास्ट 5 years. लेकिन वो जर्नल्स के इम्पैक्ट फैक्टर होते हैं। ऑथर्स के अपने इम्पैक्ट फैक्टर देखे जाते हैं, ऑथर के प्रोडक्टिविटी देखा जाता है। कोई नाम बताएगा? उसको एक और डब्बा दे देंगे। ऑथर्स का इम्पैक्ट देखने के लिए कौन सा है? सर आप डब्बा लेके क्या करेंगे आप? ऑथर के इम्पैक्ट फैक्टर की बहुत से क्राइटेरिया मौजूद हैं। इस वक्त दुनिया के अंदर जो सबसे ज़्यादा यूज़ किया जाता है अब वो, अच्छा ये साइटेशन से होता है। नाउ इट्स नॉट अबाउट द नंबर ऑफ पब्लिकेशन बट नंबर ऑफ साइटेशन। जो ऑथर्स का इम्पैक्ट देखा जाता है इस वक्त सबसे ज़्यादा यूज़ होता है एच इंडेक्स, हेयर्श इंडेक्स यूज़ होती है ऑथर्स इम्पैक्ट देखने के लिए। लास्ट मीटिंग में HEC में एक जगह बात हो रही थी जर्नल एडिटिंग की। रिव्यूअर वही होना चाहिए जिसका एच इंडेक्स 10 हो। तो वहाँ कुछ दोस्त अहबाब भी थे, तो उन्होंने बोला जी आप लोगों में से जो बैठे हैं किसका एच इंडेक्स 10 है? तो वो खामोशी इसलिए छा गई कि एक के अलावा किसी का 10 नहीं था। तो एच इंडेक्स मैं कैलकुलेशन नहीं आपको बताता, उसकी कैलकुलेशन होती है आपके नंबर ऑफ पब्लिकेशन, उसकी साइटेशंस किस जर्नल्स के अंदर हो रही हैं, उसके बाद किसी शख्स का एच इंडेक्स आता है जो 1, 2, 3, 4, 5 से होता है। यूजुअली 3, 4 ऑनवर्ड के ऊपर अच्छा समझा जाता है। लेकिन जैसे मैंने बात की थी रिव्यूअर्स के लिए एक आया था 10, मे बी डाउन द लाइन आ जाए टू बिकम अ प्रोफेसर यू नीड एन एच इंडेक्स ऑफ 15 मे बी। तो उस वक्त से हम सबको डरना चाहिए क्योंकि दुनिया एक ही दिन बैठ के हमारे यहाँ गाइडलाइन आ जाती हैं और वो अप्लाई हो जाती हैं सारी की सारी। तो हम सबको उसी के लिए तैयारी करनी चाहिए। लेकिन मैं भी रैंडमली कुछ स्पीकर्स की प्रोफाइल ऐसे सर्च करके नाम सर्च कर रहा था। गूगल बताने का आपको मकसद ये था कि आप गूगल स्कॉलर पे अपनी फ्री प्रोफाइल बनाते हैं तो आप ये सारी इंडेक्सेस अपनी देख सकते हैं, आप एक्सपोर्ट कर सकते हैं, आप डाउनलोड कर सकते हैं। और मैं यहाँ पे अपना नाम लिख के देखा, अगर आपकी प्रोफाइल हो और वो पब्लिकली अवेलेबल हो, लेट मी सर्च माई राइट नाउ। तो देखें मेरी प्रोफाइल क्योंकि मौजूद है तो वेन एवर समबडी सर्च द फर्स्ट थिंग, इस वक्त दुनिया के अंदर जब आप इंटरव्यूज़ देने जाते हैं, जो आप सब लोग भी जा रहे होंगे कल को, आपके जाने से पहले चीज़ें मौजूद होती हैं वहाँ। वो देख चुके होते हैं कि व्हाट यू आर डूइंग राइट नाउ, वेयर यू आर स्टैंडिंग, आपकी क्या स्टैंडिंग है उसके अंदर। तो आप यहाँ पे अगर जाएंगे, जैसे मैंने बताया एच इंडेक्स कैलकुलेशन है सारी, लेकिन आपकी एच इंडेक्स 5, 6, 7 स्पेशलिटी वाइज भी डिफरेंट होती हैं। लेकिन अगर आप जाएंगे तो गूगल आपको ऑटोमेटिकली आपकी प्रोफाइल होती है। तो ये देखें राइट साइड के ऊपर आपके सारी इंडेक्सेस दे रहा होता है जिसके मेरी ये यहाँ पे इस वक्त 30 है राइट नाउ। यहाँ पे आप अगर आएंगे तो आप यहाँ पे अगर इसको मैं थोड़ा सा बड़ा कर दूँ, चलें खैर छोड़ो, ओके। ऑटोमेटिकली ये लास्ट 5 years की भी दे रहा होता है और ये आपकी साइटेशन बता रहा है। फॉर एग्जांपल 2022 के अंदर इस ऑथर की 452 साइटेशन थी, 2023 में 281 साइटेशन है एंड इट्स गोज ऑन एंड बेस्ड ऑन दोज थिंग्स इट 10 द I10 इंडेक्स। I10 इंडेक्स ये वो होता है कितने इस ऑथर के पेपर एटलीस्ट 10 टाइम्स साइट हुए हैं, दैट इज़ एन I10 इंडेक्स। इसी तरह कितने पेपर ये एच इंडेक्स की कैलकुलेशन फिर है। जैसे बात हुई थी कि जब हम प्लान भी कर रहे थे तो एक 1 hour का सेशन था, बिकॉज लिमिटेड अमाउंट ऑफ टाइम वी वांट टू परस्यू लाइक दिस। लेकिन सर मैं आप लोग ऑर्गेनाइज़र यहाँ पे मौजूद हैं, आप लोगों में से जितने लोग इंटरेस्टेड होंगे और वो चाहेंगे तो वी कैन रन एन ऑनलाइन सेशन ऑफ 1 hour ऑफ ड्यूरेशन जो कि जूम पे आप लोगों के लिए अरेंज हो जाएगा। आप लोग बोलेंगे तो उसके अंदर हम स्टेप बाय स्टेप प्रोसेस में ना सिर्फ ये सारे फीचर्स, व्हाट इज़ एच इंडेक्स, हाउ टू मेक योर ओन प्रोफाइल, एच इंडेक्स की कैलकुलेशन क्या से होती है इन 1 hour, सो इट्स कैन बी डन द होल वे एज वेल। तो ये जाएंगे, लेकिन आपका टेक होम ये होगा कि प्रिपेयर योर सेल्फ फॉर द फ्यूचर, प्रिपेयर योर सेल्फ फॉर द फ्यूचर। जब हमने आगे जाना है एज अ स्कॉलरली काम करना है तो अपार्ट फ्रॉम अ गुड पेशेंट केयर, अपार्ट फ्रॉम प्राइमरी प्रिवेंशन, अपार्ट फ्रॉम सेकेंडरी प्रिवेंशन, द गुड स्कॉलरली output is one of the money which is we got as an educator, as a faculty member. So thanks a lot for your time and looking forward. Thank you.
I'm sorry I'm taking this place once again. I want to acknowledge certain people who have been instrumental and volunteered. You might have seen our young colleagues. अपना कमाल साहब चले गए, उन्होंने तो उन्हें डॉक्टर मानने से इनकार कर दिया, but I believe all these medical students who have been here, they were very helpful and I think they worked day and night for the last few days. और आज की जितनी भी हॉस्पिटैलिटी आप देख रहे हैं इसमें 80 to 90% इन्हीं का दखल है. There are two groups, इनका आपस में कंपटीशन नहीं है लकीली. तो इसमें एक मीडिया सोसाइटी है जिन्ना मेडिकल कॉलेज की और दूसरी एक केयर सोसाइटी है. तो मीडिया सोसाइटी से वी हैव सैयद मोहम्मद यासीन, ही इज़ द प्रेसिडेंट. देन घनश्याम दास, he is the general secretary here. साज कुमार कहाँ हो गई? There you are. अच्छा फ़ोटो भी ले रहे हो? चलो, he is the management head of the team. इनके ऑब्जेक्टिव हैं to represent JMDC on all social media and public platform. They act as medium between students and administration. Administration पे इनका बड़ा influence है. I don't know how they manage that. हम लोगों में से किसी का रहा कभी influence? Never. But this day and age, then bringing new talent in front. So I don't know if they are bringing या मैं लाया हूँ इन्हें. तो this is a wonderful group of people. There are many more, लेकिन कुछ चले गए हैं, कुछ खुशी से गए, कुछ नाराज़ होके गए. By the way, नाराज़ होने की वजह मैं नहीं बोलूँगा अभी, लेकिन हमसे नहीं नाराज़ हैं, ना इस कांग्रेस से नाराज़ हैं. Am I right? Thank you ever so much. I'm so grateful. दूसरा ग्रुप हमारा है केयर सोसाइटी का. केयर सोसाइटी में खिजरा इसहाक, शी इज़ द प्रेसिडेंट ऑफ द सोसाइटी. तो आपने देखा यहाँ पे जेंडर बायस भी नहीं है और द लीडर्स आर लीडर्स वट एवर जेंडर दे बिलोंग टू. और सैयद जुनैद हुमैल ये को प्रेसिडेंट हैं. अभी थे कहाँ? हाँ, नेक्स्ट टू हर इज़ जुनैद. दे बोथ हैव बीन वेरी वेरी हेल्पफुल. दानियाल अलवी, नहीं इसको रेहान उमर के हवाले कर देना है. दानियाल अलवी, बाय द वे रेहान को आई हैव सीन हिम इन हिज 92 or 100 kg and today he is mashallah so good. So Danial Alvi, Vice President, Amina Khan, General Secretary. Okay. Or this society actually is interested in rehabilitation in emergency organizations and is a rehabilitation in emergency organization. It was established 20 years ago by the student of this college. The aim is to provide all patients with equal access to healthcare facilities regardless of their socio-economic background. Mission is to provide free of cost radiology and other services, medications, and even in surgical interventions if needed. We are committed to make a positive impact on patients' lives. एक पेज और टर्न करके देख लो. I think that is all. And these people run on donations. So anybody who is interested in donating any amount, they will be happy to collect. So I'm so grateful to you and both of your groups. And thank you ever so much. And you are leaving a good legacy behind, and that legacy will continue year after year. Thank you so much. And now over to, we continue our sessions. Achha, we are starting the next session, and I think we have to hand over to Dr. Khalda and company. And this group of ladies have been unstoppable. And no, I think we have done a great job. This is such an important aspect. Please, over to you. Up.
Yes, okay.
Thank you. So that's the power of GoRate. So So thank you so much, sir, Dr. Samad and Dr. Mansoor, Professor Mansoor. So Assalamu alaikum. Why everyone is leaving? This is also an interesting session. I would request if so. We will talk about the women. So I think you should stay and listen. They are very interesting talk. Agree. So Assalamu alaikum everyone. So we are starting the session 4. Of course, welcome all for National Congress of Preventive Cardiology. And this session is in collaboration with the Go Red for Women, PCS AHA, chaired by Professor Khalda Sumro. She is a representative in Pakistan for this group. And myself, I am Dr. Farhala Baloch. I am consultant cardiologist, a PhD scholar in Afghan University Hospital, and I will be moderating this session. Like the previous session, you all have gone through that we have honorable chairperson for this session, and we have speakers. And for the next 1 hour, we will talk about the CVD in women. When we talk about the CVD in women, we always say that women have a different presentation than men. They present late, they have atypical symptoms, they have different outcomes. But the question is, do the women really follow the same preventive strategies like men for the prevention of cardiovascular diseases, especially the gender-focused circumstances like pregnancy and menopause? Do they have the same level of understanding of the cardiovascular diseases compared to the men? And do they get the equal chance of getting awareness and lifestyle modification compared to the men? So these are certain questions that will be answered by our honorable speakers and the panelists. So let us start with the introduction of the panelist, the chairperson of this session. One of our honorable chairperson, Professor Dr. Ambar Ashraf, she has joined online. She is the professor of cardiology and head of cardiology department, Khyber Institute of Peshawar. Dr. Ambar, are you online with us? Can the media person confirm, please, if Dr. Ambar is online with us? Okay. So our next chairperson is Professor Dr. Abdul Rashid Khan. He don't need any introduction. So he's a professor of cardiology and head of cardiac department, Medicare Hospital. Okay, so our next chairperson is Dr. Hana Asgar. Dr. Hana Asgar is assistant professor and consultant cardiologist at National Institute of Cardiovascular Diseases, and he is a co-director of preventive services at the National Institute of Cardiovascular Diseases. She is our speaker also for this session. The next chairperson is Dr. Farzana Amir. Dr. Farzana Amir is the head of Department of Preventive Cardiology and Rehabilitation and Director of Allied Health Sciences at Tabba Heart Institute. So thank you so much for joining us, for our honorable chairpersons. So I would like to start with the session now. Our first speaker is Professor Sultana Habib. Dr. Sultana Habib is a professor of cardiology currently at the Kidney Postgraduate Training Center at the Kidney Institute of Kidney Center, Karachi. She is a country coordinator of ROPEC, which is the Registry of Pregnancy and Cardiac Diseases, European Society of Cardiology. She is a chairperson of cardiovascular imaging guidelines in women with heart disease, hypertensive disease for the Go-ridden women, Pakistan. And she is an ex-professor of cardiology, National Institute of Cardiovascular Diseases in Karachi. She will talk about the women-centered preventive strategies, recognizing the unique aspect of cardiovascular health in the women. Professor Sultana, over to you. Thank you.
Can I have the pointer?
I think it is, if it is working.
अस्सलाम वालेकुम एवरीवन. आप स्लाइड शो पे डालें इसको. हाँ, स्लाइड शो पे डालें उसका. Assalamu alaikum everyone. Bismillahir Rahmanir Rahim. I'm thankful to the organizer of this symposium. आगे हम मुझे करना है खुद ही? अच्छा, इसी से करना है. अच्छा. My topic is part of women-centered preventive strategy, and I'll be talking on recognizing the unique aspects of cardiovascular health in women. Why this topic is important? Scientific research have uncovered significant gender differences in different aspects of cardiovascular disease in both gender. Awareness on this, on gender differences in cardiovascular disease by healthcare provider can result in better screening, better prevention, better evaluation, better diagnosis, and better treatment for the prevention of cardiovascular disease in women. Now we look at the current perspective of cardiovascular disease in general, but also in context with gender differences. The upper part show decline in percentage of rate of cardiovascular death over the years from 2010 to 2011. And what we see here that it has been color coded. It has been color coded, and we see that the burden of cardiovascular disease is on rise all over the world. If we look at the, अच्छा वो pointer आपका नीचे ऊपर नहीं होगा. Okay. If we look at the gender differences in this regard, we see that there has been a gradual rise in death rate due to cardiovascular disease in both gender, but male are more affected than female. If we look at the different countries, the middle income countries and low income countries like China and India, we see they have the highest number of cardiovascular deaths as compared to the high income countries. Now, if we look at the mortality due to acute myocardial infarction, we see that it is significantly higher in younger women as compared to men of the similar age group, and this gap almost equalizes in the elderly group. The reason for this discrepancy I will discuss later on in my presentation. How are the different cardiovascular disease vary in men, in women? There we see large number of cardiovascular disease prevalence in the society. But if we look at the proportion of cardiovascular death by causes, different causes, we see that the rate of death is highest in the ischemic heart disease and due to cerebrovascular disease in general population. We look at the prevalence of different cardiovascular risk factor except for stroke. We see that prevalence of different risk factors are more commonly seen in men than in women. If we look at a different women population in United States of America, we see that prevalence of coronary artery disease, you can compare it. Coronary artery disease is more common in South Asian population as compared to the other cardiovascular disease. This is in contrast to the other population in which the prevalence of other cardiovascular diseases are also commonly seen. Now, as I have already told you, ischemic heart disease bears the burden of cardiovascular disease, and it has been seen in ischemic heart disease that unique gender differences is more evident in it. So I will be keeping my discussion on gender differences mostly on ischemic heart disease or coronary artery disease. So causes and risk factor of coronary artery disease are traditional risk factor and non-traditional or sex-specific risk factor. most of the traditional risk factors are more or less similar in both gender, but we see that some of these major risk factors increase risk of adverse cardiovascular outcome more in women than in men. So next, when we come to the sex-specific risk factor, which is also called risk enhancer, if it is present in a woman, this similarly increased risk for adverse outcome in women. All these risk factors increases the risk of adverse outcome more in women than in, but for this especially. Now we see prevalence of different risk factors. They are more or less similar in both gender. And if we look at the prevalence of these risk factors, they are surprisingly very high in different women population in United States of America. This is the current status. This is what depression and anxiety is important risk factor for coronary artery disease in women, and you can see that it is twice, the prevalence of depression is twice more common in women than in men, and surprisingly you will see there are more younger women who are affected by it. So coming to the unique cardiophysiology and anatomy in women versus men, this is an important slide. You all have to, this is the basic of coronary artery disease. This is a hypothetical understanding of coronary artery disease pathophysiology. Especially I will be talking on women. Any cause of hypoestrogen will lead to development of increased risk factor, which will cause inflammatory milieu in the body. And it has been seen that there is always a very high level of inflammation in women than in men. And all these inflammatory factors produces abnormal coronary reactivity and positive coronary remodeling, which together are called vascular dysfunction, have been named as vascular dysfunction. And these vascular dysfunction in coronary artery disease are seen more in women than in men. Because of these different vascular dysfunction, we get different type of atherosclerotic processes which result in different type of non-obstructive coronary artery disease and obstructive coronary artery disease in women. So now it is very important that we cardiologists should be aware of the female pattern of coronary artery disease and ischemic heart disease. As I have said, vascular dysfunction is very prominent in women in coronary artery pathophysiology. So because of the sex-specific atherosclerotic processes, there are different types of atherosclerotic pathology occur in women who has more of non-obstructive coronary disease than obstructive. And it has been seen that non-obstructive coronary artery disease is more seen in women than in men. So these pathologies should be kept in mind when you are evaluating non-obstructive coronary disease as other. For the diagnosis, obstructive के लिए तो कोई मसला नहीं है, coronary angio से हो जाता है. For non-obstructive, it is very important, or it is a complex entity. We need to have different kind and sensitive kind of cardiac imaging to diagnose presence of diagnose, as well as we must assess prognostic. We must evaluate prognostic risk assessment in them for estimating the extent of ischemia in women with non-obstructive coronary artery disease. So Due to different anatomy, women can experience AMI with no obstructive coronary artery disease. There are other causes, vasospastic disorder, spontaneous coronary artery disease. These are more commonly seen as a cause of coronary artery disease in women than in men. It is important that they should be aware of the signs and symptoms of a coronary artery disease. You can see that there is a significant gender differences in presentation of acute coronary syndrome, and we see here that in women, there are multiple signs and symptoms as well as they are very persistent in contrast to men. And this has been attributed to the presence of more non-obstructive coronary artery disease in women than in men. Coming to the classical presentation of ACS, chest pain and discomfort is seen more in men than in women, and atypical presentation of ACS is seen more in women. Despite all this knowledge, there is a pervasive gap in the knowledge and awareness of cardiovascular disease in women, which has led to the underdiagnosis and undertreatment of women with the coronary artery disease. There are other barriers also which play part in it. These are myths and misconceptions which are prevailing in the society on coronary artery disease. All these myths needs to be debunked for the prevention of cardiovascular disease in women. Women lack in perception of acute coronary syndrome. Other barriers are provider sexism, ageism, and definitely there is a huge lack in knowledge and recognition of women pattern anatomy in cardiovascular disease. Now coming to the imaging differences, we see that there are a number of innovative and sensitive cardiac imaging are available for the diagnosis of obstructive as well as non-obstructive coronary artery disease for women. You all need to know all these things, that non-obstructive can also be diagnosed by the modalities we have now. The conventional modalities like exercise, stress and echocardiography and MPI with SPECT can very nicely diagnose any case of obstructive coronary artery disease. But for the non-obstructive coronary artery disease, the problem lies. As I have told you, it is a complex entity. It needs something which can, besides making a diagnosis of ischemia in women, it should be able to evaluate prognostic risk of that woman who has ischemia, but due to non-obstructive. For that, we have very refined modalities available to us: MPI with SPECT, MPI with PET, coronary artery calcium, and CTA, IVUS, FFR. All these has really helped in making a correct diagnosis and estimated risk for women who are suffering from non-obstructive coronary artery disease. The ACC and AHA clinical practice guideline recommend a use of quantitative risk assessment in decision making for atherosclerotic coronary artery disease. There are a number of scores available to us, and fortunately we have our own local risk stratification score available to us, published by Professor Tariq Kushwaha. We can easily use our own risk stratification. Prevention part will be taken by Professor Khalda Sumro. I will add a single word on it. For reducing cardiovascular risk in women, over here I would like to emphasize that we must, from now on, integrate sex-specific risk factor in the quantification, in the quantification of risk across the lifespan of women, not at a certain period of time. This will be dealt by Dr. Khalda. In conclusion, I would like to address I thought I will be dealing with cardiologists. I would like to address the cardiologists here. They should remember women are not men. They should be treated differently. My presentation has put forth the unique pathophysiology anatomy for ischemic heart disease due to both novel and traditional risk factor added, as well as I have discussed use of new cardiovascular imaging for diagnosis, prognostication, outcome in non-obstructive coronary artery disease in women, and finally, important thing is integration of sex-specific risk factor as coronary risk factor in risk assessment of IHD. I hope that new treatment paradigm will be developed in our society also to improve prevention in women with coronary artery disease. Thank you very much.
Thank you, Professor Sultana. So we have 2 minutes for question answer for this talk. If anyone has the question, can raise the hand. We can provide the mic or. So we can have the question answer in the end also if someone can write down or note down. So our next speaker is Dr. Sumaira Ahsan. Dr. Sumaira is Associate Professor of Cardiology at Hamdard University, Karachi, and she has a special interest in cardiovascular disease in the women and hypertensive heart disease in the women. Today's topic is risk factors and preventive measures for the hypertension in women. Dr. Sumaira, please come on the stage for your talk.
First of all, I would thank you for inviting me to the National Conference of Preventive Cardiology. Special thanks to Dr. Professor Mansoor and Dr. Rashid for taking the first step. Always the first step is difficult, but later on, I wish the journey will be easy. So, my talk is about the risk factor and prevention. I believe on the Dr. Rashid message that the presentation should be 10 minutes. So I just made 6 slides, that's it. Excellent. The prevalence of hypertension is no longer the man's disease. And we have an old survey from NHS which shows the prevalence of hypertension is 18%, something like that. In 2017, it shows that prevalence of man and woman is now equal, 32 to 34, and this is age between 30 to 79. So hypertension is no longer the disease of post-menopausal women. It's now become the disease of perimenopausal disease, and it no longer the disease of post-menopausal. And there is steeper rise in the systolic hypertension in third decade. And there is basically cultural difference in different provinces of Pakistan. We have a data from Dr. Tazeen Jafar, which she showed in 2017. She showed that the highest prevalence in women hypertension is found in Balochistan. It's because of the cultural difference, or because our women, the Pakistani women or Asian women, are very salt sensitive. So it's depend on the cultural habits and the one message I remember, the cooking salt intake, followed by Pakhtun, then followed by Punjabis, and then followed by Sindhis. The new paradigm which Dr. Sultana has come up, which is latest come up in this month, American Heart of Journal published a very state-of-the-art review article on women hypertension, and it is published in Journal of Hypertension. I got it, I read it, and find out very difficult. They define this paradigm into social, the traditional risk factors, reproductive, and the vascular. These all risk factors are interpolated for hypertension, and the focus here is basically on the focus. Like this is all we know, that women are underrepresented in to the healthcare service ageism, racism, and all this we know that. And these traditional risk factors we all discussed since morning, the diet, the salt intake, physical inactivity. Then now they focus on the reproductive element. The woman who has a good reproductive health have a good hypertension and good CVD health in the future. So now the future is dependent on the reproductive health. Women have hypertension throughout the lifespan. It started from the childhood to premenopausal to pregnancy, which is very important, to the menopause. Our children, at the age of 12, the child have a steeper rise in systolic blood pressure. The causes are obesity, stress, domestic stress, and family history, smoking, and the diet, which is basically the junk diets. And there's one, when I'm going through the hypertension in childhood, I just go through that if the child who are using the seafoods are more preventable from the hypertension by as compared to more eating fruits and vegetables. So seafood consumption is better in childhood as compared to the fruit. And then come in the premenopausal. So PCOS, we all agreed, it is known that's one of the major risk factors. Other risk factor, that menarche, even single missed menarche needs a red signal sign. The women or ladies students who are sitting here, if you miss your period, that's need an alarming sign, and we have to refer to the gynecologist. This is the new thing, and I'm very amazed that uterine fibroid, we I and many people उसको हम इतना वो फोकस नहीं करते, but to my amazing that 10 to 30% of women uterine fibroid is associated with hypertension, and it is an independent risk factor of CVD in perimenopausal women, endometriosis, and fibromuscular dysplasia. So these factors, especially in perimenopausal women and childhood, post-nasal dripping, which cause obstructive sleep apnea. If these factors are taken care here, they will not go into the adulthood. And then pregnancy factors, I leave here for that Dr. Hanana and that other speaker to discuss. Menopausal, the same risk factors, the obesity, BMI, lack of physical activity, diabetes, dyslipidemia, smoking, and use of hormone replacement therapy. This is the old thing, we all know, that's physical activity and thing. The new preventive module, which I need a little focus, which is that for women, salt reduction is now, they cut it down from 2.3 to 1.5 gram per day for control. Yes, 1.5 gram per day for reduction of blood pressure. Smoking cessation is important for women. For weight reduction, there is no role of exercise in women. This is a point which I deliberately bring it here for discussion. And reference is given here. And I have searched out 2-3. They have done a lot, 4,000 people comparative study, and they found that for weight loss in women, there is no role of exercise. And adequate dietary potassium, calcium, and magnesium can decrease the hypertension, but it should be from the dietary sources like legumes, lentils, and not from the processed food. And avoidance of alcohol intake, avoidance of caffeine, especially avoidance of non-steroidal inflammatory drugs and steroids and hormonal replacement therapy in women is basically this. So for this paradigm, is actually pointing out toward a good cardio-obstructive module a good cardio-obstructive team with the training of gynecologists, early referral to the gynecologist, and training of cardiologists for if they found the uterine fibroid or missed periods, they should refer to the gynecologist, and also the nursing staff who are handling it. With this, I conclude with 3 messages only. Healthy reproductive system is central to the woman cardiovascular disease, including the hypertension, early detection, better management of hypertension, and cardiovascular risk factor in premenopausal women decrease the hypertension and future CVD risk. And management of risk factor result in healthier pregnancies, reducing the hypertension and CVD in future generations. So if we treat all these risk factors are treatable, so do not, basically, first of all, that's very important thing in children, and premenopausal should be the focus of attention, not the postmenopausal, because too late, because these postmenopausal women come us with complications. And we want to, if we want to stop the epidemic of hypertension, we have to act at childhood and the perimenopausal woman, and involving the gynecologist and the good reproductive health. That's it. With this, I end the presentation in 10 minutes of time. Any questions? I'm welcome for questions. Yes. Weight reduction, there is no role. Yes. Yeah. Yes. Yeah. Yeah.
As if the women don't need exercise.
Even aerobic exercise, they didn't mention that as any role in.
But you see,
I understand your point. I understand
you
your
have to
point.
keep this in mind, that it is how it is an exercise is being conducted, what is its role.
Mhm.
Now, in our traditional way of living, the classical traditional way of living, a woman does a lot of exercise. She has to clean the house, she has to sweep the place, she has to do a lot of things. Others are there. But the point is, when you say there is no role of exercise, now that needs to be taken with a pinch of salt, just like a person says, actually a lot of,
Yes.
so, and then again salt causes hypertension. So,
I think a physical activity I didn't deny it, like walking for 30 minutes, brisk walking, that's physical activity. Weight, yeah. Yes. 2.3 grams, yeah. Yes. Yes.
Sumera? Sumera, you...
Yes. No. That's the point I want to clear for myself as well.
Sumera?
Yes. Yeah.
Sumera, you can add use of OCT therapy in the causation of hypertension in women.
Yes, that's there.
You have not mentioned. Neither. OCT, use of OCT.
OCT, use of hormonal
Drugs which can predispose a woman,
Yeah, this
that
is
should
OCT
be
we are
avoided in.
Yes, this is I did use of hormonal replacement therapy. Thank you. Thank you so much.
Thank you so much, Dr. Sumaira. So लाल कपड़े तो नहीं पहने इन्होंने. So our next speaker is Dr. Najia Aslam Sumro. Dr. Najia Aslam is assistant professor and consultant cardiologist at Liaquat National Hospital Medical College, Karachi, and she has a special interest in non-invasive cardiology and imaging. She'll talk about rheumatic valvular heart diseases and pregnancy. Thank you, Dr. Najia.
Bismillahirrahmanirrahim. Assalamu alaikum everyone. I want to say thank you to the National Congress of Preventive Cardiology and GoRed for Women for giving me the chance to present this topic of rheumatic heart disease and pregnancy. So, as we all know, that this rheumatic heart disease is actually the disease of poverty. So now there are many studies are going on, and now it is luckily the priority in global health that they are giving some interest in rheumatic heart disease in pregnancy, especially to the women diseases. They are giving some special interest. So there are these studies, they show that there is enormous burden of the rheumatic heart disease that persists in the countries with emerging and developing economies. It is especially prevalent in the Asia, and it is mentioned that it is especially prevalent in the Pakistan as well. India, China, Indonesia, and African population. It accounts for 73% of global cases and greatest in the women with the childbearing age. So the pre-existing cardiac conditions, it increases the maternal mortality, and it is, as I have mentioned, in low to middle income countries, and it is attributable to the severity of rheumatic heart disease, especially when it becomes very severe. So in Africa, they showed that 71 to 84% of antenatal heart disease are more with the rheumatic heart disease. So in these are mostly unmasked by the hemodynamic challenges which are women facing during the pregnancies. Sorry. So in this, if there is a younger age, the woman has more severe of the disease at the presentation. So the normal heart can bear the physiological changes of the pregnancy, but if there is a valvular heart disease, the hemodynamic challenges are barely tolerated during pregnancy and at the time of delivery. So the physical changes of pregnancy, like all hemodynamic changes like stroke, volume, heart rate, cardiac output, they are poorly tolerated. So there is an increased risk to the mother as well as to the fetus, and it is dependent mostly on the severity of valve disease. So neonatal adverse outcome contribute to the worsened infant morbidity and mortality, as well as prematurity, low birth weight, and it's parallel to the maternal risk as well. So as Dr. Sultana mentioned, there is a RUPEC study, and she is lucky we have a contributor in our country with us, Dr. Sultana. She is the part of the RUPEC study. They have done study on rheumatic heart disease with the pregnancy, and they showed that there is, if mild or asymptomatic valve disease, the pregnancy, it is well tolerated in the pregnancy. But as the valve severity increases, it is less tolerated during the pregnancy. So it may be with the patient can present with the heart failure and increase in hospitalization. So this is the independent predictor of the adverse fetal and maternal outcome, and the severity of regurgitation is equal as the stenosis of the metal stenosis or stenotic lesion. They are doing worse, as well as the severe regurgitation as well. So, as we said that if there are mixed mitral valve disease like stenosis, regurgitation, they behave worse, as well as the atrial fibrillation, pulmonary hypertension if it's severe, and if there is a heart failure. So anticoagulation is another risk factor which causes the adverse outcome in the women. As we know that rheumatic heart disease is because of the damage to the heart resulting from acute rheumatic fever, and rheumatic fever is because of streptococcal infection. So rheumatic fever is again, I am focusing it like it's because of the poor living condition, overcrowding, and low socioeconomic conditions. The high-risk population is especially the women who are living in the rheumatic fever endemic settings, low to middle income countries, and living in the crowded areas, and the low socioeconomic status and history of rheumatic fever in women less than 40 years. The signs and symptoms are especially if the women, they are presented in their pregnancy with the breathlessness, shortness of breath, significant reduction in exercise, incapacity. These all symptoms or any undiagnosed cardiac murmurs, we should focus on that. It is in previous presentation, like they have mentioned the rheumatic fever, so I'm not going to in details of the rheumatic fever. The rheumatic heart disease can be borderline or it can be definite. So diagnosis on the echocardiography, it may be no, it may be mild or moderate or severe. So we assess the women from the preconception. So the assessment should be done. And it is key to diagnose, like with the clinical examination. It is more important that we can diagnose any murmur with the clinical examination. We can do the echocardiography. It is the must if we are suspecting any rheumatic heart disease women. And the cardiology consultation is important at the initial stage with the women if we are suspecting rheumatic heart disease. So they should tell them the risk of rheumatic heart disease during pregnancy, about the medications. They can guide about the medication and contraception if it is needed, because there are some conditions in which the pregnancy is not recommended. That are like the severe conditions, severe stenosis, severe regurgitation, heart failure, and severe pulmonary artery hypertension. So if it is not recommended, then it is very important for the multidisciplinary team to counsel the patient, and they need a psychological, emotional support if they are counseled about the not recommending the pregnancy. So there are some, this is the very good slide or ACCH guideline in which they can, you can see that what I have said, they have mentioned that it's important, the clinical examination, transthoracic echo, just repetition of the same thing, and then if there is severe stenosis or regurgitation, they should be diagnosed early and should be counseled. And if there is an needed intervention before pregnancy, then it is recommended that it should be intervened before pregnancy. So we have severe valve lesions like severe AS, severe MS, and severe MR, which should these lesions should be done before pregnancies. So this is very good chart in which these all things are mentioned that if we are suspecting any rheumatic heart disease in pregnancy, we should have clinical examination and transthoracic echo. And if it is showing the severe valve disease, then we should go the pathway, like if they have symptoms. Yes, if they have symptoms and these are showing the severe diseases, then if it is, we can do some intervention, it can be done on that basis. But if they have no symptoms, then the exercise test should be done. And if there is symptoms, again we will follow the pathway of intervention. If there are normal but no symptoms, then on the basis of echo, if it is severe MS, again commissurotomy can be done. If it is severe AS, then again the valve intervention done, and a severe MR, then again the intervention is needed. If there is nothing, then we can continue with the observation with the multidisciplinary team. So care pathway should be done as the antenatal pathway, as echocardiography and multidisciplinary team of obstetric and cardiologists. So it's, as we already discussed, there are high rate of perinatal morbidity and mortality, so early diagnosis and management can change the results. So these are the risk factors, as we already, like severity of any lesion and any LV dysfunction, these all can increases the risk of pregnancy. So we can risk stratify with the good history, examination, and with the echocardiography and or multidisciplinary team. So if there is unknown rheumatic heart disease, so suspect more if they have any previous cardiac history, if they have any previous cardiac records, or if there is a new murmur diagnosed on the cardiovascular examination. And if it's unknown rheumatic heart disease, then we should risk stratify according to severity of any lesion, any valve lesion, with the echocardiography, with the symptoms, and we should modify their medication accordingly. And in that case, fetal growth and well-being is again important. So this chart can summarize all these things that like extreme risk are again those which are severe, and very high risk again the severe, and we should follow all those care pathways. Anticoagulation is again a risk factor, as we already discussed. It can be needed in the mechanical heart valve with the atrial fibrillations and thromboembolism. So here are some guidelines for the medication. These are the two indications we are using, the beta blockers and diuretics. So if they are now going for the planning birth, then vaginal delivery is preferable. There is no cardiology indication for the cesarean, but if there is obstetric indication, then they can go for the cesarean. So intrapartum care is again important because there is high risk, there is cardiac output increases, there is autotransfusion, and they should have monitored setup, they should monitor fluid balance. And again, for the antibiotics are not indicated for any cardiac cause, but they can be given for their obstetric cause. So if we are going to the intervention during pregnancy, again the mitral intervention is indicated as a 2 indication if they have symptoms or they have NYHA 3-4 class symptoms in the severe MS, severe MR, and severe AS. Again, in postpartum, they need postnatal observation and care, and signs and symptoms should be mostly, if they are not diagnosed, they can be diagnosed during postpartum periods. So this clinical surveillance postpartum is also needed. In discharge planning, we should counsel them about the secondary prophylaxis treatment if it's needed, and promote the health literacy with the discharge plan. Contraception counseling is again needed for planning the future birth, and follow-up of cardiologist is needed. So I conclude my presentation by giving that rheumatic fever and rheumatic heart disease thrive in squalid conditions and in regions with poor public health system. So as our conference is about the prevention is cheap, readily available, and cost effective. Thank you. Hope I have finished on time.
Yes, exactly. So we have 2 minutes of question answer. Can we share the mic with the Dr. Bilal, please, for the question?
Question and as well as an observation. And I would like actually the ladies all to have an input. You said this is a disease of the poor. And then we label everything in one phrase, socio-economic.
Yes.
ठीक कहते हैं ना? मुझे एक छोटी सी बात बताइए, एक अमीर आदमी, सो कॉल्ड करोड़पति आदमी, आपके अस्पताल के वार्ड में अकेला लेटा हुआ है और उसका इलाज हो रहा है। दूसरी तरफ एक गरीब आदमी है जो लेटा हुआ है एक जनरल वार्ड में और उसके 2 बेटे उसके पाँव दबा रहे हैं, 4 लोग बाहर फिक्र कर रहे हैं, दुआएं कर रहे हैं। सोशली कौन अमीर है इनमें से?
So the second one is
the richer
अमीर,
वो अमीर है।
but the women के हम बात करें तो वो गरीब हैं हमारी women.
वजह ये है कि it is very interesting because जो औरत हो या मर्द हो, मैं सिर्फ इसलिए चीज़ खास तौर पे
But sir, you initially you were gender biased. आपने कहा अमीर आदमी लेटा हुआ था, उधर भी अमीर आदमी लेटा था, आपने औरत नहीं बताया।
मैंने नहीं औरत बोला था। My point that the point that I'm trying to say is, Nizar, I'm not off target. I'll tell you why. The reason why I'm saying this is that this disease is not socio-economically dependent. That's where you go wrong.
No, sir, because the studies which are done globally now, the congenital heart disease is.
Please let me explain myself what I'm saying.
Okay.
When you say socio-economically, it is poor. It is not socio-economically poor.
Only economically we can say.
Economically poor.
Okay.
It is economic
Next time
challenge.
we will write down this. It is economically, not socio-economically.
Because socially.
Okay.
Because having a large family is a risk factor for rheumatic
For
heart
rheumatic.
disease also. So
Yes.
economically poor, and if they have
But-
so
but-
many as Bilal is suggesting, then there is higher likelihood of
Higher likely, yes. Now you are right. Like, because if there is socially they are crowded, then again they have more diseases because economically already they are poor, but socially if they are rich, they have increased more chances of the rheum. Yeah.
No, I think it is the very first, you see, this is during our studying days with जब हम rheumatic heart disease पढ़ते थे, overcrowding is one of the risk factors for rheumatic heart disease. So
Yeah. So
overcrowding, what do you mean? What do you mean? मोहल्ले वालों की overcrowding?
But if the woman overcrowded in the ward, she is more likely to have rheumatic heart disease.
Large family living in a small house was one of the factor. I want to add something to you, to your presentation. You could have mentioned a little bit on a woman, pregnant woman who became pregnant and has crossed the first trimester or she is in second. There is a recommendation how to go about dealing with them. So, and a prevention of complication later on. Either they can be delivered earlier with taking care of the newborn. So this is a kind of message you could have given it. No, it was your duty to give this message to.
Okay, so I think we should move forward. Thank you, Dr. Najia, for an excellent talk. मुझे बहुत ज़्यादा खुशी हो रही है because I can see कि yes, Dr. Hannah, please go.
just want to make a point, like it was a great presentation by Dr. Najia. As Dr. Sultana said, about the care of the patient. I think majority of the women which we are seeing at NICVD, they are presenting in their second or third trimester, and they are already NYHA class 3 or 4. They have PA pressures in the 60s and 70s. And also, if somebody presents early, the decision to abort a child is a very big ethical decision. And the concept is, ji bacha abort kara le, wo kisi ke paas gaye. But the guidelines clearly say it is a decision of the parents. You have to have informed decision making, which hum to yahan थोड़ा कॉन्सेप्ट ये बस लिख के दे दें ये करा लें because a lot of times these women इनके मियाँ छोड़ दें इनको ये बहुत social issues है हमारे माशरे में. So what we are doing is we are helping them. We are doing frequent follow-up. So here the cardio ops team comes as a big role because Yes. So what we typically, yeah. So what? Yes. So we individualize the decision, right? If somebody's first pregnancy versus somebody's fifth pregnancy, right? If somebody is coming with the first pregnancy, then, but obviously if the mother is really sick, you make that decision for the patient. Like I had a lady, she had combined valve disease. She had severe AS, severe MS, and an EF of 20%. I didn't leave the decision to her. I made the decision for her. But again, her risk is prohibitive. But I'm talking about a patient in the first pregnancy hoti hai. They are 20 years old. They're younger than my children, Yeah, so, yeah. Yes. Yes, and that's why informed decision making and involving the father and the team is very important. Your team-based care is the cardiologist and the gynecologist. The father of the baby. Father of the baby, the mother and the father, But here the decision is sometimes women come with the boy's father. No.
I think yes. I think that these. I think we can. Yes, so we can conclude this discussion like decisions are always not patthar pe laki se Dr. Bilal ne kaha, decisions are always individualized based on patient scenario and your hospital scenario. And of course, pregnancy with the heart disease is not an easy decision always. So let's move on to our next topic, and I'm very happy कि Go Red for Women का जो discussion है वो बहुत अच्छा जा रहा है. Everyone is participating. The next speaker is Dr. Hana Asgar herself. So she is assistant professor at NICVD and co-director of preventive cardiology, and she will talk about the female-specific risk factor for coronary artery disease. Dr. Hana, please.
presentation लगा रहे हैं? Not this one, the one before this one. इससे पहले वाली जो है ना? Yes, this one. Assalamu alaikum everybody, and I thank Dr. Mansoor and Dr. Rashid for giving me the opportunity to come here and talk about female-specific risk factors for coronary artery disease. We've had a lot of discussion already about this. Dr. Sultana touched on it, Dr. Sumaira touched on it, so I'm going to just go over really quickly about what are the main risk factors, especially female-specific risk factors. So the global burden of CVD in Pakistan is one of the highest in the world. And as we can see, it's not only contributes to the burden of CVD, but also to the disability-adjusted life years. And if we look at the data, it has climbed up. Ischemic heart disease has stayed at number 2, but stroke has increased, contributing to the overall deaths. And if we look at what is one of the most common risk factors between stroke and coronary artery disease, hypertension. So hypertension, the control in the community is extremely poor. Even according to the Western literature, the control of hypertension in the community is around 30–40%. So even in our population, less than probably 60% of people have controlled hypertension. So hypertension, if we can make one change to the practice, to the prevalence of the risk factors for coronary artery disease, we should get better at control of hypertension. So this is the inter-heart data, and I just want to point out one thing. If we look at women, women in Pakistan in less than 40, the cases which were reported from the inter-heart study were 0. And over the years, this was a study published in Pakistan Heart Journal by National Institute of Cardiovascular Diseases. So the percentage of women with heart disease, with MIs increased to 8%. And the data from last year from NICVD from January 22 to December 22 showed that 24% were women with heart disease, with primary, who got primary angioplasty. So over the years, the incidence of acute MI is increasing in women. And you know, when we looked at the risk factors, so the top 3 risk factors for all, this is for all comers, for ACS, for hypertension, tobacco use, and diabetes. And you know, the data which has been shown over the day, the course of the day, the prevalence of diabetes is increasing, hypertension is becoming one of the major risk factors, and also with the younger generation, especially we talk about the preconception health, as was a discussion before. Vaping is becoming very common in our culture now, in the schools. So these problems will just add over time, and these are very unrecognized, you know. But you know, my daughter, she's 16, and she's like, the vapes are carried in school, and they have major, you know, because they don't even know, and it's even available on Panda Mart. I mean, the children just order it, they have access to money, and parents half the time don't even know what it looks like. Because, you know, cigarette smell, you can smell a cigarette, your child has smoked. But this, again, and this will just add up to the burden of young population with MIs. And this not only has as we talked about the social determinants of health, these people, when they have families, men are still today, men are the main breadwinners of the family. So, you know, the consequences of heart failure, age lost due to life years. So again, so, you know, we talked briefly about the different atherosclerotic cardiovascular disease, endothelial dysfunction. So the cardiac disease in women is a big, from rheumatic heart disease, cardiac disease of pregnancy, peripartum cardiomyopathy, cancer. So it's a big area now. It's not only coronary artery disease. So Dr. Sultana talked about the microvascular dysfunction. So trends in cardiovascular disease in men which were initially on the decline are slowly rising. And this is again being recognized by AHA. and ACC. And as we talked, preconception health, pregnancy health, postpartum, everything matters. So again, catching, like especially early, and we are seeing more and more risk factors like PCO, adverse pregnancy outcomes. So preconception health is extremely important. And all this is related to the diet, lack of exercise, fast food. I mean, there's an epidemic of PCO now. First used to hear very infrequently, but now it has become very common. And the change in the hormonal milieu which comes with this diseases eventually affects your cardiovascular health. And so history of premature menopause, pregnancy-related conditions are now risk-enhancing factors in the latest prevention guidelines. So younger women, early menarche, earlier than 10 years. Again, obesity is one of the contributors to early menarche. Late menarche also after 15 years. So PCO, use of OCPs, which have a high concentration of estrogen, are associated with increased risk of atherosclerotic cardiovascular disease later in life. So pregnancy is like a stress test. If you fail that stress test, you're at a higher risk of developing adverse cardiovascular outcomes later in your life. And now when we are counseling our patients or seeing the younger patients, both for primary and secondary prevention, we are looking at these risk factors. Did you develop gestational diabetes? And most of these women are not followed up. They're told they're lost to follow up. They get hypertension in their pregnancy. They get diabetes in their pregnancy. 15 years, they develop full-blown, either they come with an event or they come with full-blown diabetes. So you've lost that time window where this could have been prevented. And for some, it is like a young stroke. I mean, again, as Dr. Bilal talked about, once you lose a mother, I still remember I was 13 when my mother had a TIA, and she had hypertensive disorders in pregnancy when she was like 35 in 1971. Nobody and my father was a cardiologist, but again, she lived a good life. So again, this is extremely important, early recognition and treatment. And so in older women, hormonal replacement therapy was very common in the 80s and 90s. However, with the WISE study, hormonal therapy did not lead to decreased cardiovascular outcomes. So it was actually in older women, it was shown to have higher, increased risk of heart attack. So it's not routinely recommended. Now it's only recommended for very young, premature menopause if somebody, just to cover that time to 40 to 50 or 40 to 55. So I talked about it briefly, if you're less than 10 years, or late menarche, increased risk of adverse cardiovascular events. Again, these are the people you want to pick up early and for prevention, right? If you have an obese 15 or 16-year-old, you can counsel them so they don't develop hypertension or diabetes. Now they're even recommending screening lipids once in teenage, so you know where they're standing. And OCPs increased risk of, especially the high estrogen-containing ones. So if you're thinking about hormonal contraception, you think about ones which have a lower estrogen or progestin, only pills or, the IUD. PCO we talked about, again, the entire gamut eventually leads to inflammation, metabolic syndrome we've talked about, this whole day, hypertension, dyslipidemia, insulin resistance, and it's the hyperandrogenic type, the one which has a higher testosterone to estrogen ratio. That is the one which contributes to subclinical CVD and eventually to clinical CVD. Women are having careers, choosing to get pregnant later, fertility therapy leading to ovarian hyperstimulation, increased renin-angiotensin, aldosterone activation leading to problems with cardiovascular disease. Again, so they should be under close surveillance. If somebody has received assisted reproduction, they should be counseled. At least get the hypertension, and early, every year you can screen them for diabetes or hypertension. So the hypertensive disorders of pregnancy, the main reason behind the pathogenesis is the vascular remodeling of the placenta, and this is like kind of an early marker of late development of hypertension or cardiovascular disease. So we talked about this. So preeclampsia, preterm delivery, is not only increases your subsequent rate of heart failure, subsequent rate of CVD. So gestational diabetes is a marker of maternal CVD. So 70% of people with gestational diabetes develop diabetes within 5 years, and 25 risk of develop CVD. So again, these are the hazard ratios of preeclampsia for hypertension, CVD, stroke, heart failure. So all these disorders, adverse pregnancy outcomes, and how often do we ask our patients about these? So there you can see all preterm birth, gestational diabetes, gestational hypertension, small for gestational age babies, the increased risk of hypertension, CVD, stroke, heart failure, and diabetes long term. And again, all of this leads to the cardiometabolic syndrome and inflammation, and again increases your cardiovascular risk. So menopause, early menopause, premature menopause is called before 45 years, 40 to 45 years, increased risk of cardiovascular disease long term. And it's the iatrogenic which has a higher risk. And it's the other thing which I want to point out was the testosterone to estradiol ratio. So higher the testosterone to estradiol ratio, higher the hazard ratio from the MESA study for developing cardiovascular, coronary artery disease, and heart failure. But it's only recommended in the younger population. Like if somebody has menopause at 45, you can recommend them menopausal therapy, but not when they're older. And again, you can estimate their risk of a future event by coronary calcium can help you over there. And also vasomotor symptoms, which women are commonly seen by their gynecologists for, they by itself increase your risk of cardiovascular disease long term. So this, I'm just going to go. So again, so if you have a woman, you assess the risk, you look at the risk enhancing factors, and when you're uncertain, you add imaging like coronary calcium or vascular imaging to look at plaque. So the other thing which I'm just going to briefly touch on, breast cancer and cardiovascular disease share quite a few risk factors. So again, this is an entire, cardio-oncology is one of the new branches of cardiology, because these women, like hormonal contraception use, obesity. Again, everything points to metabolic syndrome and eventual development of inflammation, increasing your cardiovascular risk. Cardiorheumatology, women are more likely to have autoimmune disease, lupus, RA, very common in women, and again, it's very unrecognized in our population, under-recognized, right? So they go to the orthopedic surgeon, they'll go to some other person, some chiropractor, and then, but eventually by the time they present to the rheumatologist, they have burnt out disease again, they're at a higher risk of developing CVD long term. So, and it's not only the disease process itself, leading to increased inflammation, but also the steroids and the immunosuppressants which are used. So, reducing the burden of CVD in women, multidisciplinary approach, raising awareness, engaging communities, and early recognition. And again, the joint, women get obscured, they're lost to follow-up, they have hypertension, diabetes, and then they develop 15, 20 years, they come to the cardiologist. So combining, women's health programs with gynecologists and cardiologists, I think, would help prevent the development of cardiovascular disease and its heart failure and the other complications long term. And the heart and mind-body connection is very important. Women have, get obviously stress of life, stress of careers. They have to manage the house, husband, everything. So eventually, this is very not commonly. We don't talk about it. The concept of wellness is very important. Not getting care only when you're diseased, but again, early recognition and then eventual prevention. Talked about it. Thank you.
you are at a back by that time. So these are the realities, and in tobacco smoking, especially with this new vape thing, they all say that has 8,000 compounds, this has only 200. Reality is the compound that we are against, the nicotine, it is higher concentration in the vape than in that one, because that's the one which keeps calling you back. So all the best with it.
Thank you. Okay, so tobacco prevalence is, I think, very high, but the thing is that we don't report it, we underreport it. So that's the probably fact, Dr. Hannah. You are right that we. Exactly. So you know, our data actually show 95% of patients, they say that we never smoke, which is not true. We don't believe. So before we move on to our last speaker, and of course the head of Go Red for Women, I would like to ask a question from Dr. Faizana, because she is the head of a rehabilitation center. So how at the Heart Institute, how do you find the approach of our women to rehabilitation when with the cardiovascular diseases? If you can just comment 2 lines before we move on.
Thank you very much for giving this opportunity. Actually, adding to Dr. Bilal's point, he said that the women's live longer. Actually, it's not the matter of years in your life, it's the quality of life. Unfortunately, the quality of life in our females are very much compromised as compared to male. And as I'm involved in rehabilitating females, I personally feel it's very difficult to rehabilitate a female as compared to a male. It takes longer, it's harder to rehabilitate a female as compared to a male. They are not compliant, they are not concerned about the quality of life. Quality of life and self-care is not in their priority list at all.
Agreed.
So they tend to, with the span of life and with the responsibilities they carry, the self-care and the quality of life is at the end of their list. So it's very difficult at the age when they have gone through the different sequences of their life. Even they have passed a very tough time in their life during pregnancy and during different physiological changes while taking care of their children and family and all that. So they have, they end up very early. So they have, it's very difficult.
Thank you.
Okay. Thank you.
So yes, there are still differences, but our approach is actually improved. The difference is there. So let me invite my last speaker of this Go Red for Women session in this NCPC, Professor Khalda Sumro. She is the CEO and coordinator of Go Red for Women PCS AHA and Chairperson Scientific Council of Women with Heart Disease of Pakistan Cardiac Society. She will talk about the role of precision medicine aims to tailor prevention strategies. Very difficult topic, madam. Thank you, sir.
So, keeping in view of empty hall and as well as the anxiousness of the audience who are waiting for to go, I will be very brief and will try to summarize this topic within a few minutes. We all know that despite of the increased mortality in women, 80% of the CVDs in women are preventable through lifestyle modification and risk factor management in developed countries. I'm not talking about the Pakistan or other South Asian countries where the preventive measures adopted by women are pathetic. Because of the, even considering this AHA guidelines say that prevention of CVD is paramount to the health of every woman and every nation. Even the modest control can be enormous impact. We know that all the traditional cardiac factors, new risk factors, woman-specific risk factors are common in all women, but we have to take the increased mortality could be due to the non-traditional risk factors, and which are comparatively better in the developed countries than us. We are very poor in all these non-traditional risk factors, and they are leading to increased mortality in our women. Apart from these risk factors, due to the impact of these risk factor is on the women, as well as not only from these risk factors, but because of giving family care to a family, due to the stress, sleep deprivation, fatigue, general lack of the personal time. Not only these risk factors, but we have to think about the genetic involvement. We know that the women in the period of premenopausal and postmenopausal higher estrogen level are responsible. Not only the higher estrogen level are responsible, but these women differ in phenotype expression, which could be a cause for the increased atherosclerotic disease or CVD. Sex hormones, sex-specific gene expression is very important in women for preventive purposes. So, precisional medicine, which comprises all these parameters for the genetic analysis in various age groups of the women, is important for the genetic assessment and better outcome and the preventive measures through the genomics, new generation DNA, transcriptomics, complete set of the RNA, and proteomics, all protein expressed in cell or tissue, metabolic, small molecules or metabolites present in the biological cell sample, which not only gives us the entire set of the genes and their relation to the development and the progression of the CVD in women, but also helps in targeting the development of the targeted treatment in these patients. Recently, rapid dedication research in the phenotype sequencing of the human genome has provided novel insight into the genetic mechanism. By polygenic risk scores for the common CVDs and genome editing. These exciting future endeavors will change the established clinical approaches, and they provide readily accessibility, will decrease the cost of the next generation sequencing technologies in women with patients with CVD. Here I want to tell you that I'm not expecting this development in near future in South Asian countries, but we can benefit from the developed countries. Their research, their analysis, and their contribution of their research to the South Asian countries will help us, and if they will make the genetic analysis cost effective, and we can adopt it. So main genotype assessment is mainly in few diseases are very impressive. Mendelian disease, hypertrophic cardiomyopathy, dilated cardiomyopathy, and congenital heart diseases, whereas in non-Mendelian diseases, analysis in coronary artery disease, AF, and hypertension is having a very rapid progress. So, in women, the improved, it will help in improved risk prediction in the high-risk women, and can help in targeted treatment with increased treatment efficacy while minimizing the side effects and better quality of life. As I have already told that cost saving, if they will decrease the cost of the genetic analysis, we can take help from those cost effectiveness. So in future, network medicine and clinical recording will potentially explore the development of the novel drugs from the natural compounds as well, and the proposing the current drugs such as statins and metformin in these patients, especially women. So several clinical trials already exploited the epigenetic tags and the epigenetic sensitive drugs both in primary and the secondary prevention of diseases in women. These drugs usually, by the advancement in genomic and omics technologies and data analysis, will make the precision medicine more accessible and increase its potential for widespread implementation across the healthcare. As well as it will help in collaborative research and data sharing. As I have already told that their data sharing will help us in future. And among the researchers and the institutions, they will help and accelerate the implementation of the precision medicine approaches and improved outcome in women with the coronary cardiovascular diseases. And one of the major benefits will be making the guidelines. Proper medical guidelines in the women we are lacking. It also empowered the women by educating the women about their cardiovascular health risks and preventive measures, encouraging the active participation in decision making regarding their health, just as was discussed during the cardio-obstetric presentations, and utilizing the digital health technologies, especially wearable devices to monitor and track progress. So this is all the country, I think we can empower the women and revolutionize the prevention and management of cardiovascular diseases, leading to better health outcomes and healthier future by overcoming the challenges like ethical consideration, integration to healthcare system, and promoting equitable access. Thank you.
Thank you, Professor Khalda, for the talk on a different aspect of women in CVD, like genetic aspect. So with this, we conclude our session. I would like to say thank you to Professor Rashid as a chairperson of our session, Professor Mansoor for organizing such an excellent academic activity and incorporating ORED for women and giving the red women the chance to present themselves. Dr. Hana Asghar on her talk and being the part of the panelists, Dr. Farzana, Dr. Najia Sumro, and Dr. Sumaira, Professor Sultana. And so if there is no other question or comment regarding the cardiovascular diseases in women, is there any other question or comment? Okay, Vana kar diya gaya. So we can say, so I think I can conclude that initially I said that when we talk about the CVD in the women, we always say that the CVD is women is different than the men. This is a fact, this is a research-based fact, and we all accept it. But the important thing that we are seeing for the last decade, I can say, or maybe a half decade, and especially in 2023, that our approach to the CVD in the women is now improved. And that is definitely because of these academic activities and the contribution by our seniors like sitting in front of me. So thank you so much. And with this, we conclude our session for GORED for Women. And I would like to invite Dr. Adil for the last session. Thank you.
Thank you so much for all your patience. Please have some more. We have a couple of talks more. I'm Dr. Mohammad Adil Khabar, working as Assistant Professor Cardiology at Jinnah Medical and Dental College. I would like to call on stage Ms. Noreen for her talk. Please come on the stage.
Assalamu alaikum. I am Noreen Anjum Sajid from Karachi Institute of Heart Diseases. First of all, I would like to thank Dr. Abdul Rashid and Sir Mansoor for giving me an opportunity to present my research. My topic is association between malnutrition and frailty on readmission in heart failure patient. Background is malnutrition and frailty are common conditions that are often present in heart failure patient and are significantly associated with adverse health outcome and increased health related issues like falling, decreasing mobility, decreasing ability to perform the basic activities of daily living, increased frequency of hospitalization and death. The presence of malnutrition can cause frailty and the presence of frailty can cause malnutrition. Either one can develop before the other. Frailty and malnutrition among heart failure patients may be triggered by malabsorption associated with gut edema, anorexia, cytokine production, and food restriction as well as loss of appetite. All these mechanisms may also worsen heart failure condition. Although prevalence of heart failure is high, but there is a very limited data available on frailty and malnutrition and its association with readmission among hospitalized heart failure patients. The basic definition of frailty is Fried et al. ने create की थी 2001 में. According to frailty criteria, there are 5 domains of frailty which include unintentional weight loss, fatigue, weak hand grip, slow gait speed, and decreased physical function, who may experience at least 3 of 5 criteria that defined as frailty. According to WHO, malnutrition refers to deficiency or excessive in nutrient intake, imbalance of essential nutrients, or impaired nutrient utilization. जो ऑब्जेक्टिव्स थे हमारी स्टडी के उसमें हमने मेल न्यूट्रिशन और फ्रैलिटी की जो है वो फ्रीक्वेंसी देखी थी कि पेशेंट्स में कितनी आ रही है और इनकी एसोसिएशन और देन फ्रैलिटी की एसोसिएशन विद रीएडमिशन. डिफरेंट ये लिटरेचर्स हैं जिसके थ्रू जो है वो हमें पता चलता है कि फ्रैलिटी जो है उसकी प्रेवलेंस कितनी ज़्यादा है. ये सिस्टमैटिक रिव्यूज़ हैं. फर्स्ट जो है उसमें है कि 1.5 फोल्ड्स जो हैं वो एक्सपोज ग्रुप के अंदर रीएडमिशन होते हैं एज़ कम्पेयर टू अनएक्सपोज ग्रुप. इसके अलावा दूसरी स्टडी जो है वो 26 स्टडीज़ जो हैं उसमें 6,896 हार्ट फेलियर पेशेंट जो हैं उनको कंक्लूड किया गया था कि एवरी 1 in 2 पेशेंट जो हैं उनके अंदर फ्रैलिटी मौजूद होती है. ये एक और स्टडी है जो सिमिलरली मेरी स्टडी जैसी थी तो इसलिए वो मैंने ऐड कर दी थी जो कि चाइना में हुई हुई थी और इसमें भी इन्होंने रीएडमिशन देखा था फ्रैलिटी की एसोसिएशन के साथ. हमने जो पेशेंट उसमें ऐड किए थे 415 पेशेंट्स थे. ये एक कोहॉर्ट स्टडी थी जिसमें हमने आउटकम देखा था रीएडमिशन का. इंक्लूजन क्राइटेरिया में हार्ट फेलियर के कंफर्म पेशेंट जिनका इजेक्शन फ्रैक्शन 25 to 35% था. HB मेल्स में जो था वो मोर देन और इक्वल टू 12 मिलीग्राम पर डेसीलीटर एंड फीमेल्स में 10 और मोर देन 10 मिलीग्राम और इक्वल टू 10 मिलीग्राम फीमेल्स के अंदर था. पॉजिटिव प्रो-BNP बोथ जेंडर, एज लेस देन मोर देन 50 और लेस देन 70 ईयर्स और पेशेंट ऑन ओरल डाइट. एक्सक्लूजन क्राइटेरिया में वेल्वुलर रिमेटिक कंजेनाइटल हार्ट डिजीजेस पेशेंट और कार्डियोमायोपैथी, पल्मनरी एडिमा सेकेंडरी टू हाइपरटेंशन, kidney diseases, neurological condition, non-compliance to their cardiac medicine were excluded from my study. 2 टेक्निक्स जो हैं वो फ्रैलिटी के लिए ली थी, एक सब्जेक्टिव मेथड था एंड द अदर मेथड जो था वो ऑब्जेक्टिव था। सब्जेक्टिव मेथड के अंदर क्वेश्चनर यूज़ किया था जिसके 15 क्वेश्चनर्स थे और 3 कंपोनेंट्स थे, फिजिकल, साइकोलॉजिकल एंड सोशल। और जो ऑब्जेक्टिव मेथड था वो हैंड ग्रिप डायनामोमीटर था। ये हैंड ग्रिप डायनामोमीटर है, इसकी 3 रीडिंग्स ली गई थी और देन उसका मीन हमने यूज़ किया था फ्रैलिटी के लिए। देन मेल न्यूट्रिशन को असेस करने के लिए हमने मेल न्यूट्रिशन यूनिवर्सल स्क्रीनिंग टूल लिया था। इसके 5 स्टेप्स थे और इसको जो है वो हमने कैटेगराइज किया था लो, मीडियम एंड हाई रिस्क ऑफ मेल न्यूट्रिशन पर। और उसके बाद पोस्ट डिस्चार्ज जो है वो 3 कंसेक्टिव मंथ्स में हमने पेशेंट को फ़ोन कॉल या उनकी हिस्ट्री से उनका रीएडमिशन देखा। रिज़ल्ट्स जो थे उसमें 415 स्टडी पार्टिसिपेंट्स में 60.2% जो थे वो मेल थे, 39.8% जो थी वो फीमेल्स थी। इंसिडेंस ऑफ री एडमिशन वॉज 35.2%। फ्रीक्वेंसी ऑफ फ्रैलिटी इन हार्ट फेलियर वॉज सरप्राइजिंगली वॉज 81% एंड द रेस्ट वर नॉन फ्रेल, whereas 45.8% participants were found to be at high risk of malnutrition. मेल न्यूट्रिशन और फ्रैलिटी की कोरिलेशन जो थी वो मॉडरेटली पॉजिटिव थी, मतलब मॉडरेटली पॉजिटिवली जो हैं ये एसोसिएटेड थे एक दूसरे के साथ। ये मल्टीवेरिएट एनालिसिस थी जिसके अंदर हमने एडजस्ट किया था 2 मॉडल्स को, जिसमें जो है जो कंफाउंडर्स थे उनको एडजस्ट किया गया था। तो जो फीमेल्स थी उनके अंदर 6.29% हायर चांसेस थे एज़ कम्पेयर टू मेल रीएडमिशन के। इसी तरह अंडर वेट में 10% जो थे वो ज़्यादा चांसेस थे बाकी अदर कैटेगरीज़ के। इसी तरह जो मस्ट अगर हम देखें तो हाई रिस्क पेशेंट में 2% चांसेस थे रीएडमिशन के, जबकि फ्रेल में भी 10% चांसेस थे रीएडमिशन के एज़ कम्पेयर टू अदर ग्रुप्स। This is the first study that presents the association between malnutrition and frailty on hospital readmission among heart failure patients in Pakistani adults. Even though the rate of hospital admission was high among male heart failure subjects, जो हमारे heart failure subjects थे उसमें male जो participants थे वो ज़्यादा थे, लेकिन जो frail थी वो female ज़्यादा थी, इसीलिए उनके admission readmission भी ज़्यादा हुए थे। Although frailty is not related to geriatric only, but globally there is limited data available on younger adults. Our study identified the impact of frailty on a younger population less than 60 years. In conclusion, a strong association between frailty and readmission was found among heart failure patients with positive correlation between malnutrition and frailty. Stratification of these patients by frailty and nutritional status provides prognostic information and may inform priority of heart failure intervention and management. Assessment and close monitoring of the frailty and nutritional status of heart failure patients can potentially better guide their clinical management. Anyhow, more studies are needed to investigate the possible underlying impact of malnutrition and frailty on readmission. Thank you.
Thank you so much, Ms. Noreen, for your talk. And I would like to call Dr. Farzana on the stage, please, and give your talk.
Thank you very much for giving me this opportunity, especially Dr. Mansoor and Dr. Rashid. आप सब लोग डाइट और एक्सरसाइज पे सुबह से सुन के इन गाइडलाइंस पे थक चुके होंगे. I'll try to make it short, quick, and I'll try to make a difference to guidelines so we all know that what are the guidelines for exercise and diet and lifestyle modification, but the actually जो practical challenge होता है in application, the ground reality जो चैलेंज और जो मोस्ट फ्रीक्वेंटली क्वेश्चंस होते हैं हमारे पेशेंट्स के टू प्रोवाइड द सोल्यूशन फॉर दैट.
So this is my main objective. As I said, I'll try to give a practical approach toward lifestyle modification. We all know the risk factors and lifestyle modification for all risk factor management. And 30 to 40% आप अपना जो mortality rate है और quality of life improve कर सकते हैं only by means adding 30 minutes of exercise of moderate intensity. There are numerous studies, I'm not going to into the detail for that, which shows that mortality benefit in inactive, low active, moderately active in different individuals. There is benefit in every case. So I'm just going to skip it. WHO recommend that despite of all that, we know all the factor, it's a class 1A indication, only 26% men's and 19% women's and 20% adolescents are active. So this is actually, we need to understand that despite of guideline, despite of studies and being conscious, physical activity with advancement and technology are we compromising day by day. So we need to find out the solution that in this digital era, how we can increase physical activity. That's a real challenge. So cardiac rehabilitation is one of the most effective way of lifestyle modification. But despite of its recommendation class 1A, चाहे आप physically attend करें, even the home-based distance learning programs are effective to only less than 20% patients get registered for cardiac rehabilitation, and out of that only 47 to 50%, only 47 or less than 47%, I would say between 30 to 47% patients adhere to the 1 month, even 1 month activity. So this is really alarming. So the benefits of cardiac rehabilitation are obvious. Mortality, quality of life, managing all risk factors in every aspect. कितनी करनी चाहिए? 150 minutes to 300 minutes of moderate physical activity, or we can do 150 minutes of high intensity exercises. The benefits of exercise, as Dr. Bilal said, it's not, the benefit of exercise is not, actually the purpose is not for weight reduction. It's a misconception. We use exercise, अब जैसे like the individuals in the normal weight, जब वो gym में होते हैं, exercise कर रहे होते हैं, तो people used to say, why do you need exercise? You don't need exercise. अब मज़ीद exercise करके कहाँ जाएंगी? So this is basically a misconcept. Exercise is not for weight reduction, but there are numerous other benefits of exercises, which is still there. So one of our key role is not for prescribing exercises, but to educate masses too. So start writing, what I would suggest, start writing about exercise and lifestyle modification on your prescription. Like you like medication for dyslipidemia, hypertension and all that, just add a line for exercise too. It really, in countries में ये practice किया गया, it really has an impact. Before prescribing exercise, assessment is very essential. Why assessment is essential? Because high-risk individuals are recommended to start their working under supervision or under monitoring. And then moderate risk individuals can work with supervision. Yes, only low-risk patients can be recommended for just start kar le exercise, walk kar le and all that. Because safety is very important. The exercise components, हम जो हमेशा बात करते हैं aerobics है, it's more than aerobics. The exercises, whatever, कितनी कर रहे हैं आप, कितने मिनट कर रहे हैं, it is one question, but the other thing is there should be stretchings, aerobics, strengthening and physical activity increase करने के tips. All these 4 areas should be in your prescription. There's a difference between physical activity and exercise. What is the difference? Anyone? The difference between being physically active or physical activity or exercise. Because दोनों के results and दोनों के impact are different. The impact of exercise, हम जो guidelines में पढ़ते हैं, that is because exercise always is structured on a formula. Fixed time, fixed intensity, fixed pace, different for everyone. So there's a difference being physically active and exercise. So it's equally important to be physical active, but exercise, induction of exercise. So exercise, physical activity cannot replace exercise, but you cannot deny the benefits of being physical active. There are benefits of being physical active. So exercise components are warm up, cool down to assure safety, because gradual raise in blood pressure, heart rate and all that during activity saves any episode of angina or any other mishap during activity. So that's why warm up and cool downs are very important. Severe the disease, longer the warm up will be. And exercises, more moderate intensity exercises can be done, or high intensity exercises can be done, either depending on function. I'm not going to. So this is again the repetition, 150 minutes to 300 minutes of moderate intensity. That this is about aerobics, mice. Okay? And this 75 to 150 minutes, this is about high intensity, which can be done twice a week. This is about high intensity exercises, basically for to improve insulin resistance and to burn the fat in your and weight reduction. So being physically active, what a way you can ask your patients to be physically active, कि अगर आपका long sitting hours है, after every 20 minutes they can stand up for 8 minutes and then do any sort of physical activity for 2 minutes. Is easy. Whatever you are doing, you can do this thing after every 20 minutes. Get up for 8 minutes and do some sort of physical activity. Move your arm, move your hands. Just walk around in your corridor while you're attending the mobile phone. Okay? But do that for 2 minutes. So it's easy to change. Empower your patients to use the gadgets for self-monitoring. And now about diet. We do not ask to deprive any component from your diet. All components are equally important, even the fat is. So, but the moderation is the key. So we do not keep the plate colorful. So enjoy the taste. All carbs are not bad. So, but the choice is very important. Choose healthy carbs. Protein, now there's a debate between red meat and white meat, but red meat is not prohibited. And do not restrict the salt and sugar. We do not restrict, but ask the moderation. And we ask our patient to avoid the other sources of sugar and salt. Those are more harmful than adding खाने को फीका मत करें. Otherwise या तो वो follow नहीं करते या फिर they lose their interest. खाना हमारी ज़िंदगी में बहुत important role play करता है to add happiness in our life. And if you अगर आप deprive कर देते हैं तो stress itself is very bad for the quality of your life. खाना खुशी देता है. हम जब enjoy करते हैं, celebration करते हैं, especially being in Asian, meal is a important part of every celebration. So you cannot deprive your patients कि वो celebration का part ना बने. But the moderation is the key. So I personally like the concept of moderation. We need to understand different researches जो मुख्तलिफ time पे हुई है. There is no particular food item which is bad. Different times पे हम different food items को culprit करते रहे, which is not true. Actually, it's the whole combination. It's not any one item. So keep your 50% fruits and vegetables and then 1/4 of your grain and 1/4 of protein. There's a simple formula. So the portion control. Have you ever noticed what happened with our diet and portion size over the time? ठीक है. Have you noticed this? कि वक्त के साथ हमारा portion size किस तरह से बढ़ रहा है unintentionally, and we haven't noticed it. कितना फ़र्क पड़ता है पोर्शन साइज़ के बड़े होने से, द टोटल अमाउंट ऑफ कैलोरीज एंड टोटल अमाउंट व्हाट वी आर टेकिंग. और जो बड़ी डील है वो सस्ती मिलती है और जो छोटी डील्स हैं आर मोर एक्सपेंसिव. सो वी in this greed we buy a bigger deal, so we eat more. So this is a marketing tactic we need to understand. Similarly, you can see the difference, कितना फ़र्क पड़ता है. Similarly, हमारे जो the crockery we use, डिनर प्लेट का साइज़ दिन ब दिन बढ़ता चला जा रहा है. What does it, क्या इम्पैक्ट कॉज करता है? सिर्फ प्लेट का साइज, पेट का साइज़ और प्लेट का साइज़ साथ साथ बढ़ रहा है. तो ओनली बाय एक बड़ी प्लेट में आप अपना जो मील लेते हैं और एक छोटी प्लेट में मील लेते हैं, सी द डिफरेंस. आपको फील भी नहीं होता फिर, बट देयर इज़ अ डिफरेंस. इसी तरह you can enjoy every meal, but like for example you want to enjoy a high calorie diet, so use this concept. Replace 50% with the healthy items and then enjoy. ठीक है. Healthy swaps can make flyers of healthy swaps and ask them to switch. Even like French fries की जगह saute potatoes they can use. Just an example. So can develop the handouts for the healthy swaps. So what about this, the famous lal sharbat? Can see the difference. Similarly, हम salad की बात करते हैं, raw salad use करते हैं, but we add a lot of high calorie dressings in that. ठीक है, these are the healthy swaps. इसी तरह brown rice की बहुत hype है. The brown rice are more healthier and low calorie, but actually there is no difference. We have kept, for busy physicians, we have kept a lot of short videos on our YouTube channel to create an awareness. You even can ask your patient to visit that, and we have a lot of videos related to misconceptions and different type of diet plans, different type of diet instructions and physical activity instructions. You can ask your patient to view that for. And similarly, that's the only tool which we can use. लोग अब flyer नहीं पढ़ते हैं. They are more onto WhatsApp. They are more onto TikTok. So even to educate them, we have to use these forums too. Thank you very much. Agree.
That's a very, very valid point. कि खाना जो है आपने diet is something very important.
Very important.
हमारे यहाँ नहीं
Sorry, Danya.
Thank you very much for
Thank you.
Thank you so much, Dr. Farzana, for such a great talk on diet and exercise for the prevention of cardiovascular disease. Now I'll call Dr. Ashar Bilal to please come on the stage and give your talk.
Assalamu alaikum. Can I have this pointer, please? Dr. Adil. Oh, thank you. Thank you. Assalamu alaikum, everybody. I know that we are very late. A very important topic, actually, it is. But unfortunately, I don't have the audience which I want to, target. सारे जवान लड़के और लड़कियां गायब हो गए हैं. लड़के तो ख़ास तौर पे जो मेरे टारगेट थे वो सब चले गए हैं. तो एनीवे बहुत शॉर्ट करते हैं, क्विकली करते हैं. बहुत बड़ा बर्डन है. देखिए आप अप्रॉक्सीमेटली 21% ऑफ ऑल कॉरोनरी हार्ट डिजीज डेथ जो होती हैं वो स्मोकिंग की वजह से होती है. वेरी इंपॉर्टेंट. सो टोबैको हम सबको पता है कि स्मोक टोबैको होती है, स्मोकलेस टोबैको है जो हमारे माशरे में ख़ास तौर पे साउथ ईस्ट एशिया में और या एशिया में बहुत ज़्यादा यूज्ड होती हैं एज़ कम्पेयर टू यूरोप. हाँ, मैं इसको टारगेट करना चाहता हूँ. सेकेंड हैंड स्मोक जो मेरी ख़वातीन हैं उनके लिए सबसे ज़्यादा इम्पॉर्टेंट है. दे कैन प्ले अ बिग पार्ट स्मोकिंग को ख़त्म करने के लिए हमारे माशरे में. तो ये कुछ न्यू ड्रग न्यू जो हैं वो स्मोक्स की. ओके नाउ सो वेरी बिग प्रॉब्लम, वेरी बिग प्रॉब्लम. आप ये देखिए कि कोरोनरी हार्ट डिजीज़ लाइक मोस्ट Non-communicable chronic disease is complex and influenced by interrelated personal and social and commercial factors include होते हैं 9.4% million lives and over 203 million disabilities होती हैं every year. So it's a big impact on people's life and change their future forever, smoking. So it's very important. So look at the extent of the impact of tobacco which they can have. So coronary heart disease also been linked to decrease in work productivity, subsequent emotional distress में patients चले जाते हैं. Addition to that, middle age income countries जो होते हैं, families suffered करती हैं, वो लॉस करते हैं अपना काम जब वो बीमार होते हैं, तो big impact. So pathology I want to skip because the audience नहीं है, so pathology I want to skip. We'll go directly on to with the short of time. या ये तो आपका कंप्यूटर भी थोड़ा स्लो है. Okay, so I will directly come to prevention. So second hand smoke, I just want to address this one because जो ख़वातीन है यहाँ पे, देखिए ये बहुत important है कि आप लोगों को अपना part play करना पड़ेगा. Ask your husbands, ask your brothers, ask your whatever the male who is smoking in front of you, kick out them out the room. जाएं बाहर जाके पिएं. क्यों? क्योंकि सिर्फ आप नहीं प्रॉब्लम कर रहे, आपको प्रॉब्लम नहीं हो रही, मेरे बच्चों को और मुझे भी हो रही है. सो दैट्स वेरी इंपॉर्टेंट. सिर्फ आप बीमार नहीं होंगे, हम भी सिगरेट पी रहे हैं आपके साथ, तो हम अब जब हम नहीं पीते तो हम क्यों पिएं? सो बाहर जाइए, लॉन्ज में जाके पीजिए. जब आप ये करेंगे माशरा चेंज होगा. सो मेल से ज़्यादा फीमेल्स पर जिम्मेदारी आती है. तो मेरी भाभी ने यही किया कि उनके घर मेरे चचा आए, बाहर भेज दिया उन्हें. वो तो सोच ही नहीं सकते थे कि मैं ससुर हूँ, ससुर को बाहर भेज दिया स्मोकिंग के लिए. सो बट वी हैव टू डू दैट पोलाइट वे में, आराम से, लेकिन हमें करना पड़ेगा अपने माशरे को तब्दील करने के लिए. सो लुक एट व्हाट वी आर डूइंग विद आवर फ्यूचर. लार्जेस्ट नंबर ऑफ स्मोकलेस टोबैको यूजर्स आर इन साउथ. सॉरी पॉइंटर वे यार, पॉइंटर के लिए कौन सा है? ये है साउथ ईस्ट एशिया में. सो ये हमारे जो बच्चे हैं सारे हमारे लो सोशो इकोनॉमिक एरियाज, अनफॉर्चुनेट, वेरी अनफॉर्चुनेट. आप देखिए यंग बच्चे कुछ नहीं करते हैं, दिन भर काम करते हैं और रात को उनकी सिर्फ इंजॉयमेंट क्या होती है कि कोई बीड़ी रख के मुंह में घुस है, किसी ने जो गुटखा रखा हुआ है, किसी ने कुछ रखा हुआ है और अपने घर के गली के बाहर बातें कर रहे हैं और रात तक बातें करते रहते हैं, खाते रहते हैं गुटखा. 27, 28 साल के लड़के जिनकी शादी होनी चाहिए वो कैंसर से मरते हैं, माउथ कैंसर से. सो हमें एज ए माशरा इसको सीरियस, बहुत ज़्यादा सीरियस लेना चाहिए. ये जो स्मोकलेस टोबैको है, प्रॉब्लम ये है कि ये यूरोप अमेरिका में है ही नहीं, बहुत कम है, तो दे डोंट बॉदर. तो यहाँ कहीं डिस्कस नहीं होती ये चीज़, यह जो कि हमारा माशरा सफ़र कर रहा है. सो दैट्स वन पॉइंट आई वांट टू रेज. इंटर हार्ट स्टडी आपको सबको पता है, ये इंटर हार्ट स्टडी ने यही चीज़ बताई है कि साउथ ईस्ट एशिया में कितनी डेथ्स हो रही हैं. पाकिस्तान का नाम स्पेशली अलग से लिखा है उन्होंने. सो वी हैव टू थिंक अगेन कि हम क्या कर रहे हैं अपने साथ. सो और सारी जो रिसर्च हैं सब में वही एविडेंस आ रहे हैं बार बार. कहने को तो ये कहते हैं कि इनमें कम जो है वह निकोटीन है और दूसरी चीज़ें, बट एवरीथिंग इज़ डूइंग हार्म. थोड़ा बहुत 2019 का डिफरेंस है एंड दैट्स इट. सो आपको बचना है, दैट्स मोर इम्पॉर्टेंट. सो क्या करें भाई प्रिवेंशन के लिए? So, tobacco controls measures have been shown substantial benefit to the heart health. So, sorry, भाई पेट्रोल पे ही टैक्स क्यों दें? लगाएं टैक्स इस पर, सारे टैक्स पेट्रोल पे ही लगाए जा रहे हैं. ठीक है. एंटी टोबैको मीडिया कंपेन्स होनी चाहिए, ग्राफिक हेल्थ वार्निंग्स हमें यूज़ करनी चाहिए, सोशल मीडिया यूज़ करना चाहिए जैसे हम बात कर रहे थे. अच्छा, फर्दर टोबैको कंट्रोल इंटरवेंशन में क्या कर सकते हैं? लेजिस्लेशन इज़ मोर इम्पॉर्टेंट. हमें सीरियस होना पड़ेगा, बीइंग अ डॉक्टर्स, बीइंग अ कम्युनिटी, हमें आगे आना पड़ेगा और हमें अपनी जो हुकूमतें हैं उनको इन्फोर्स करना पड़ेगा कि वो लेजिस्लेशंस बनाएं. वेरी इंपॉर्टेंट. जिन मुल्कों में है वहाँ पे लेजिस्लेशन आप देखें, आप सिंगापुर चले जाएं, आपको च्युइंगम खाने पे जेल में डाल देंगे. तो लेजिस्लेशन इज़ इम्पॉर्टेंट. एक्सेस रिस्क ऑफ कोरोनरी हार्ट डिजीज़। अच्छा, एक इम्पॉर्टेंट पॉइंट जो है वो ये देखिए आपके, जब हम छोड़ते हैं स्मोकिंग तो जो रिस्क होता है वो हाफ हो जाता है विद इन अ ईयर। थोड़ा टाइम लगता है, 10-15 साल लगते हैं, बिल्कुल नॉन स्मोकर के बराबर आ जाते हैं। कोई और अदर रिस्क फैक्टर जिसको आप छोड़ दें, जो कि छोड़ने वाला हो, वो ऐसा बेनिफिट नहीं देता एक्सेप्ट टोबैको। तो इतना बड़ा बेनिफिट आपको मिलता है अगर आप टोबैको छोड़ते हैं। सो बहुत सारी मल्टीपल जो डाटा है और एनालिसिस है वो सब यही जाहिर करते हैं। शॉर्ट ऑफ टाइम की वजह से मैं आगे जाऊंगा। तो इंडिविजुअल लेवल पर क्या कर सकते हैं, रिस्पेक्ट स्मोक फ्री पॉलिसीज़, हमें ये रिस्पेक्ट करना चाहिए। एक तो हमारे पास ना इस माशरे में रिस्पेक्ट की बड़ी कमी है, जहाँ पे लिखा हुआ भी होगा ना कि यहाँ थूको नहीं, यकीन कीजिए नहीं भी थूकना होगा तो वहीं थूकेंगे। पता नहीं ये क्या इशू है, आई डोंट नो। तो पॉलिसीज़ जो है अगर हमारे हॉस्पिटल में है, एयरपोर्ट पर है, कहीं है, रिस्पेक्ट कीजिए प्लीज़, आपकी हेल्थ के लिए। और अगर अपनी हेल्थ को नहीं करते कम से कम दूसरों को तो ना तबाह करें, ठीक है। सो दूसरा फार्मास्यूटिकल्स पे पार्ट प्ले कर सकती हैं इसके अंदर। इसके अलावा नॉन स्मोकर्स शुड डिमांड स्मोक फ्री लेजिस्लेशन, वो बाहर आएँ। जैसे कि ख़वातीन हैं, आप अपने लिए और अपने बच्चों के लिए खड़े हुई है, हमें छोड़ दीजिए। हम मर्द हजरात तो वैसे ही जल्दी मरना चाहते हैं, तो हमें छोड़ दीजिए, आप अपने लिए और बच्चों के लिए खड़े हुई हैं। यार हम तो हर बचपन से हर तरह से बस मरते ही हैं, बस मौका मिलना चाहिए, ठीक है कभी। अच्छा, पॉपुलेशन लेवल पर क्या एक्शन होने चाहिए? देखिए, मल्टी सेक्टर अप्रोच होनी चाहिए, कॉम्प्रिहेंसिव अप्रोच है। मॉडलिंग टोबैको फ्री लिविंग होनी चाहिए। अवेयरनेस इज़ मोस्ट इम्पॉर्टेंट। हम हेल्थ केयर प्रोवाइडर्स को काम करना चाहिए कि हम अवेयरनेस क्रिएट करें। और अब हमारे पास और ख़ास तौर पे जो कि सेकेंड हैंड स्मोकिंग है उसके लिए, तो ये पैगाम जो है वो देना चाहिए। मेरी ऑडियंस जो वो सारे मेरे बच्चे जो सुबह से बैठे हुए थे, अनफॉर्चुनेटली दे हैव गॉन, उनके लिए बनाया था, बट एनीवे फिर कभी सही इंशाल्लाह। सो थैंक यू।
Thank you so much, Dr. Ashar Bilal, for your talk. Now I would like to call the last talk of the day to Dr. Sabah Ijaz to please come up on the stage and give a talk.
Thank you. So the topic is last, although कि ये last importance का topic नहीं है, and I thought कि primary prevention पे होगी ये talk, but I was told कि नहीं हुई है, and so I'll try to condense it within 10 minutes. As we all know about dyslipidemia, it's basically elevation in cholesterol, triglyceride and lipid LDL levels and low HDL levels. And basically आपको पता है कि लाइपोप्रोटीन्स जो होती हैं उनके साथ हमारे कोलेस्ट्रॉल सारा ट्रैवल करता है, बिकॉज इट कैन नॉट बी ट्रांसपोर्टेड इन द ब्लड बिकॉज इट्स हाइड्रोफोबिक, राइट? So basically the target of all the therapies are lipoproteins. They are hydrophilic spherical structures. इनके अंदर एक कोर होती है जिसमें कोलेस्ट्रॉल होता है, डेंसिटी की बेस पे हम we divide them into low density and high density. So this is the spectrum. Higher density are actually anti-atherogenic. फिर वो जितने बड़े होते जाते हैं, they are small LDL, LDL, LP little a, फिर उसके बाद VLDL on chylomicrons. सो हमारा जो थेरेपी का टारगेट है, वी ऑल नो कि LDL होता है एंड मेजर एपोप्रोटीन इज ApoB100. इफ़ यू लुक डाउन, LP little a is also mentioned. So I would just like to, because we all know about LDL and don't know much about LP little a, this is a newer focus of research. We all know कि LDL का तो हम टारगेट करते ही हैं, but LP little a is another new target because it's estrogenic and pro-inflammatory. एंड बेसिकली हमारे पास अभी बहुत जगहों पे इसके टेस्ट भी अवेलेबल नहीं है, सो इट्स नॉट बीइंग चेक्ड. और हमारी पॉपुलेशन में इट्स बीन सीन दैट LP little a is actually higher than the western population, and this should also be considered while working up for cholesterol levels. So we have primary dyslipidemias जो कि रेयर होते हैं, then we have secondary dyslipidemia जिसमें diet, drugs, disease और metabolic diseases आ जाती हैं. When we start managing lipids, first we order a lipid panel, right? Lipid panel में usually we get LDL, HDL, total cholesterol and triglycerides, and sometimes we also get VLDL. इट कैन बी फास्टिंग एंड नॉन फास्टिंग. तो नई रिकमेंडेशन ये है कि यू कैन गो विद द नॉन फास्टिंग इन मोस्ट ऑफ द केसेस, एक्सेप्ट आपको फैमिली हिस्ट्री ऑफ प्रीमेच्योर CAD है, देन यू शुड गो फॉर फास्टिंग, और आपको इनिशियल स्क्रीनिंग करनी है. एंड सेकेंडली, इफ़ हाई फैटी मील लिया विद इन 8 आवर्स, अदरवाइज रिकमेंडेड है कि क्लिनिक के लिए यू कैन गो फॉर नॉन फास्टिंग सैम्पल्स. सो वंस यू गेट द ट्रीटमेंट, उसमें से आपको फोकस किस पे करना है. सो मेन फोकस इज LDL, राइट? It's the main goal, and basically you need greater reduction or to the risk of the patient. Previously there were many therapies based on HDL, but now it's not recommended because benefits उनके निकले नहीं. And the last is the triglyceride, where very extremely high levels need treatment. And with this, because lipid panel में LP(a) नहीं आता, it is separately ordered and it is not available in most of the labs. It should also be checked at least once. इसकी अच्छी बात ये है कि ये जेनेटिकली डिटरमिन्ड होता है, तो ये चेंज नहीं होता डाइट के साथ, और आपको वंस इन लाइफ ज़रूर चेक कर लेना चाहिए हर पेशेंट का, टू सी के हाई है या नहीं. जो करंटली रिकमेंडेड लेवल्स हैं वो 50 हैं. अगर 50 से ज़्यादा लेवल्स होते हैं तो दे आर कंसिडर्ड हाई, बट दैट इज़ सेपरेटली ऑर्डर्ड. दिस इज़ नॉट पार्ट ऑफ द लिपिड पैनल. So next step in management is risk estimation. I thought I would skip this, but I was told कि primary prevention पे discussion नहीं हुई है. So basically this is very important. When you order the lipids, patient की history लें, and then you go for their risk calculation, which is a 10-year and lifetime risk. It's basically in US done based on pool cohort equation, where they calculate the risk of non-fatal and fatal MI, fatal non-fatal stroke. एंड बेसिकली इसमें क्या प्रॉब्लम है कि जो पूल्ड कोहॉर्ट इक्वेशन का डेटा था, साउथ एशियंस वर नॉट रिप्रेजेंटेटेड, राइट? एंड देन इन यूरोपियन regions they use another score which is called score 2. So you can use either of the two, but because we usually follow the American guidelines, we follow this ASCVD. बट ये याद रखें कि इसमें साउथ एशियंस नहीं थे इस डेटा में. इसीलिए अमेरिकन गाइड्स में दे हैव एडेड सर्टेन अदर फैक्टर्स विच शुड बी कंसिडर्ड व्हाइल कैलकुलेटिंग दिस रिस्क. दीज इंक्लूड CRP levels, calcium score, ancestry which includes South Asians, chronic kidney disease or inflammation, premature menopause, preeclampsia, metabolic syndrome. These are additional factors which are not part of the ASCVD risk factor. So हम लोग तो हाई रिस्क में वैसे ही आ जाते हैं. This is the app which I just included because it can be added into your mobile phone and it can be easily used in the clinic setup. ये इसके पैरामीटर्स हैं बेसिक्स, जो आपको अगर आपने लिपिड पैनल कराया हुआ है और बाकी हिस्ट्री है, यू कैन सिंपली कैलकुलेट. आपके पास 4 नंबर आते हैं. One is low risk, less than 5% risk of having an event in the next 10 years, 5 to 7.5 borderline, intermediate and high risk. यहाँ आसान है और यहाँ आसान है क्योंकि यहाँ आपको सिर्फ लाइफस्टाइल मॉडिफिकेशन करनी है, यहाँ आपको मेडिसिन देनी ही देनी है. जो बीच का ग्रुप है, दैट्स अ ग्रे जोन, एंड देन यू हैव टू गो फॉर फर्दर टेस्टिंग और कंसिडर फर्दर फैक्टर्स जो कि अभी हमने पिछली स्लाइड पर डिस्कस किए थे. सो कमिंग टू द थेरेपी, जैसे मैंने कहा था कि LDL इज़ द मेन कल्प्रिट हेयर, सो वी फोकस ऑन LDL. जो फर्स्ट लाइन ड्रग्स हैं, दीज आर स्टैटिन्स. Statins basically is just a refresher. These are HMG-CoA reductase inhibitors जो कि acetylcholine A और HMG-CoA से जो आपका कोलेस्ट्रॉल बनता है, इस स्टेप को ब्लॉक करती हैं. And all the major trials in primary and secondary prevention has shown that lower the LDL level, lower the event rate. ये बहुत सारी ट्रायल्स हैं, मेटा एनालिसिस हैं, इट्स प्रूवन विदाउट डाउट. इस पर तो अब यूजली अब डेटा इस पर हो भी नहीं रहा है बिकॉज ये पहले से ही प्रूवन है. सो इट्स द कॉर्नर स्टोन. There is 21% reduction in 5-year incidence of major coronary events, revascular stroke, and 12% reduction in all-cause mortality when you reduce 39 milligrams या 1 millimole of LDL. There are 3 types of doses: high intensity, moderate, and low. I think कि cardiology या जो हमारे students हैं, they all know about it, so we'll skip that. जो डोज है वो आप डिसाइड करते हैं बेस्ड ऑन के लेवल्स कितने ज़्यादा हैं. एक तो वो लोग हैं जिनको पहले ACS इवेंट्स या स्ट्रोक हो चुका है, उनको तो आपको हाई डेंसिटी देनी है, या अगर आपका LDL मोर देन 190 है, उसके बाद आप क्या करते हैं, बाकी लोगों में ये रिस्क कैलकुलेट करते हैं फॉर प्राइमरी प्रिवेंशन. और उसके बाद डायबिटीज़ है तो आपको एटलीस्ट मॉडरेट इंटेंसिटी देनी है, और अगर हायर रिस्क फैक्टर्स हैं तो यू कैन गो फॉर हाई इंटेंसिटी. इन रेस्ट ऑफ दीज जिनमें डायबिटीज़ नहीं है, उनमें फिर यू गो फॉर फर्दर टेस्टिंग, जिसके अंदर आप कैल्शियम स्कोर, CRP और ये सब करवा सकते हैं. देन रिस्क गाइडेड थेरेपी पे जाते हैं. देन व्हेन यू स्टार्ट स्टैटिन, देन यू हैव टू लुक फॉर कंप्लायंस कि पेशेंट ले भी रहे हैं कि नहीं, बिकॉज कंप्लायंस के बगैर लेवल्स लो नहीं होंगे LDL के. और every 4 to 12 weeks आपको जो है initiation के बाद you'll have to order another panel to see if the patient is compliant and response is according to the dose. तो जितनी dose high होगी उतना LDL down होगा. And then you keep on monitoring every 3 to 12 months. There are certain side effects of statins जिसमें आपके myoglobin हो सकता है, rhabdomyolysis हो सकता है, liver dysfunction हो सकता है, but usually these are very rare. You have to order these tests once when you start statin. You don't have to keep ordering these tests every time. And it is seen कि जब बहुत दफ़ा इस तरह होता है कि बहुत low LDL हो जाता है तो people think that we should reduce the dose, titrate it down or stop. But it has been seen that lower doses actually reduce the risk of cardiovascular events. Even less than 50 के doses पे भी कोई safety issues नहीं होते. It's actually beneficial. तो आपको कम नहीं करनी होती डोज इवन अगर लेवल्स लो भी हो जाएं. अब रिकमेंडेशन ये है कि जो जिन लोगों में रिकरेंट इवेंट्स हो रहे होते हैं विद इन 2 years, यू हैव टू गो अप टू लेस देन 40 milligram levels. It's a 2B recommendation, but you can go as low as less than 40. And at high risk आपको less than 70 का गोल रखना होता है with statin और with combination. यूरोपियंस ने एक्चुअली ये नंबर 70 से कम करके 55 किया हुआ है, तो दे आर इवन मोर stringent about it. But despite all this evidence, well established benefit, there is very low under titration and less prescription of statins. ये वेस्टर्न डेटा है जिसमें देखा गया है कि ख़वातीन में एक्चुअली कम कंप्लायंस होती है, लोअर डोज होती है. एंड एक ट्रायल हुई है जिसमें हाई एडहेरेंस वर्सेस लो एडहेरेंस स्टैटिन पे देयर इज़ 25% इंक्रीज इन मोर्टेलिटी आफ्टर MI. सो बाकी नॉर्मल ट्रीटमेंट अपनी जगह, बट स्टैटिन्स पे स्ट्रेस करने के लिए हर फॉलोअप पे आपको अपने पेशेंट्स के साथ बैठ के डिस्कस करना चाहिए दैट दे शुड रिमेन कंप्लायंट बिकॉज दिस इज़ द मोस्ट अफोर्डेबल ट्रीटमेंट. हम आगे वाली दवाओं की बात करेंगे, दे आर वेरी कॉस्टली. Next drug in line is ezetimibe, which is easily available in Pakistan. Basically ये NCPC1L1 receptors के through act करती है और कोलेस्ट्रॉल जो आपके chylomicron remnants हैं actually इसको कम करती है. Basically acts on the intestinal level, right? And usually it is given as an adjunct, add-on therapy to statin. It's not usually given alone. So अगर इसको हम alone use करते हैं तो इसके कोई mortality benefit नहीं है, but it can reduce 20 to 25% LDL levels and some reduction in CVD events. Next drug जो है, जो कि अब बहुत इन हो गई है, established भी हो गई, but because of the cost issues अभी पाकिस्तान में इतनी easily available नहीं है, लोग import करते हैं. Basically PCSK9 inhibitors कहलाते हैं. And what they do is कि normally क्या होता है कि जब हमारा LDL degenerate होता है, the receptors जो हैं उनको वापस आना होता है. But there is a molecule called PCSK9 which degrades those receptors. जब यहाँ रिसेप्टर्स कम होते हैं तो हेपेटिक लेवल पे LDL पार्टिकल्स का इनटेक भी कम होता है. सो व्हाट PCSK9 inhibitors do, they basically block this degradation and upregulate the receptors. That results in increased LDL uptake to the liver and reduces the levels in the blood of the LDL. So this is the mechanism. Basically ये degradation of receptors को कम करते हैं and then they increase the uptake ताकि blood level कम हो जाए. But it's a very costly drug, right? Although इसके benefits बहुत ज़्यादा हैं, it can reduce up to 56 milligram per deciliter of LDL levels over a period of within 6 months. It has a very significant results based on CVD mortality, stroke and MI. And this is another trial, वो 4-year trial थी, and Odyssey trial. These are the main 2 trials जिसके results में consistently endpoints in MI, stroke, revasc and cardiovascular death, these are all reduced. So अब recommendations जो ये 2 drugs new हैं, इन पे based क्या है? If patient is already on high intensity statins and LDL is more than 70, you can add ezetimibe or PCSK9 or other monoclonal antibodies. तो ये वो लोग हैं जिनमें रिकरेंट इवेंट्स हो रहे हैं हाई रिस्क इवेंट्स में, बट लो रिस्क लोगों में ये रिकमेंडेड नहीं है. और इसके अलावा सेकेंडली प्राइमरी डिस्लिपिडीमियाज जो हैं, फेमिलियल डिस्लिपिडीमियाज, उसमें रिकमेंडेड है. दिस इज़ द न्यू ड्रग, आई जस्ट वांटेड टू इंक्लूड बिकॉज इसके बारे में लोगों को इतना पता नहीं है. इंक्लिजरान इज़ बेसिकली स्मॉल इंटरफेयरिंग मैसेंजर RNA. बेसिकली करता ये भी PCSK9 के थ्रू काम है. इट एक्चुअली रिड्यूसेस द PCSK9 क्लीवेज ताकि PCSK9 इनहिबिट ना हो और उसके लेवल्स बढ़ जाए तो आगे से मैकेनिज्म इसका सेम है एज PCSK9, बट ये इससे पहले जेनेटिक लेवल पे काम करता है. इट इज़ ऑल्सो इंजेक्टेबल. इसकी ट्रायल्स एक्चुअली 2015 से शुरू हुई थी ओरायन ट्रायल्स के नाम से. देयर हैज़ बीन मेनी ट्रायल्स, ओरायन 11 तक आ चुकी हैं अभी. नाउ दिस प्रीवियसली इट वाज अप्रूव्ड इन यूरोप एंड 2 years ago it was approved by FDA in US as well. और इसका यूजुअली जो डोजिंग रेजिमेंट है उसमें यू गिव 1 dose at day 1 and then 3 months, then you give a dose every 6 months. सो इसकी अच्छी बात ये है कि इसकी डोजिंग बहुत स्पेस्ड आउट है, ऑल्दो दिस इज़ कॉस्टली, बट जो इसकी कॉस्ट अगर आप कंपैरिजन करें तो जो 6 month पे कॉस्ट बनती है वो आपकी स्टैटिन से मोर लेस कंपैरेबल बन जाती है, बट स्टिल इट इज़ नॉट अवेलेबल. ओवरऑल अभी तक जो इसकी ट्रायल्स हुई उनमें उसको ऑन टॉप ऑफ स्टैटिन यूज़ किया गया. इट वॉज नेवर यूज्ड अलोन. So it can reduce your LDL level more than 50% at at around 18 months, and it maintains these levels. So say that there is only twice a year dosing, right? Then this is another new agent, bempedoic acid. It's a novel agent. Basically ये भी कोलेस्ट्रॉल पाथवे में before HMG-CoA reductase ऐड करता है. ये उन लोगों के लिए हुआ statin intolerant और oral दवाओं पे जाना चाहते हैं. You can use it with combination and ezetimibe. So it reduces further 13-14% of LDL in addition to ezetimibe. जो लोग statins नहीं ले सकते उनके लिए. But इसके कोई mortality benefits अब तक नहीं. But this has been recommended in patients who are statin intolerant. So next target, as I told, was triglycerides, जिसमें first intervention is lifestyle modification and exercise and diet. Then you have to consider other causes which can cause triglycerides, such as obesity, insulin resistance, diabetes, liver disease, and drugs. And the first drug is actually statin, because statin 15 to 20% reduction can cause reduction in triglycerides. So first you have to start with statin, and if despite statin there is no reduction, इसमें जो कट ऑफ अभी रिकमेंडेड है गाइडलाइन में वो 175 का है. सो इफ ट्राइग्लिसराइड इज मोर देन 175 आफ्टर यू कंट्रोल योर डायबिटीज एंड हैव गिवन स्टैटिन, यू कैन गो फॉर फिब्रेट्स. सो फिब्रेट्स एक्चुअली आर पेरोक्सिसोम प्रोलिफरेटर एक्टिवेटर इनहिबिटर एगोनिस्ट. इनका फंक्शन क्या होता है? दे इंक्रीज द डेंसिटी, रिड्यूस द डेंसिटी एंड इंक्रीज द पार्टिकल साइज, इंक्रीज HDL सिंथेसिस एंड रिड्यूस ट्राइग्लिसराइड्स. दो फिब्रेट्स अवेलेबल है, जेमफिब्रोसिल एंड फेनोफिब्रेट, and that they can be given on top of the statin. Maximum ये 30% reduction करते हैं आपके triglycerides level में. That's why आप उनको statins के साथ देते हैं. इसके अलावा और drugs जो हैं, niacin, omega-3 fatty acids, ये भी use हो सकती हैं for statins. Usually recommended है कि very high dose हो, very high levels हो, then you should start treatment because there is risk of pancreatitis. Otherwise you should first start with statin and then later on consider adding fibrates. Omega-3 fatty acid is another triglyceride lowering drug जो कि एंटी इन्फ्लामेटरी है और बहुत सारे लेवल्स पे काम करती है. और इसकी जो 2 ट्रायल्स हैं वो रिड्यूसर और स्ट्रेंथ है, एंड दे यूजुअली रिड्यूस ट्राइग्लिसराइड levels from the baseline, and they have been shown to have overall effect in primary and secondary prevention, but secondary prevention में ज़्यादा रोल है, primary में overall इतना रोल नहीं. So recommendation ये है, अगर more than 500 is the level of the triglycerides initially and the risk is higher, you can initiate therapy with statins and then you can add fibrates अगर वो lower नहीं होते. But अगर 500 and 1000 के बीच में है तो you can directly start fibrates. So in conclusion, LDL cholesterol is the target, lower and longer the better. LP little a is evolving measurable marker for risk assessment, greatest absolute number of events avoided in patients at greatest risk. And lower level is the better. So don't go for कि 70 से नीचे आ गया तो dose कम करनी है. Ezetimibe and PCSK9 inhibitors and inclisiran are recommended in very high risk patients where LDL targets could not be achieved with statin use. And next on is the high triglyceride. If it is not controlled despite statin, you can consider adding fibrates. Thank you. Yes, yes, I just told that.
4 years' time, we realize that more people will die. So I don't think this can be, and you have already mentioned the guideline is 2A, and it still it says more than 500. So above 175, please do not use that. You are not treating biochemistry.
So,
Outcome data is not supported.
so at more than 175, you can add other things like omega-3 fatty acids, but not fibrates. Yeah. But triglyceride lowering is a target.
You said in your one of the slides, if you go back, you did say you should add one before. Yeah. Okay, next. Yeah. Here you said not this one next. Yeah. Here you said 16 above 175. You have not written it, but I suggest that please do not prescribe it. I've gone through this study and there will increase mortality. And
Yes.
above 500, you use it to prevent pancreatitis, not to protect heart problems. For heart, you can use that, what is it, super saturated petrol, क्या नाम है उसका?
PUFA. PUFA.
Omega-3 नहीं,
PUFA.
नहीं, there is a specific drug जिसके बाद में बड़ी प्रॉब्लम चल रहा है. Eco,
These are omega-3, DHA and ECO. So this came from here, which I mentioned, high triglyceride. But इसमें मैंने fibrate नहीं बोला है, but you can reduce it. Reduce it में इकोसा यूज हुआ था, वो यहाँ नहीं आता, बिल्कुल. That's omega-3. That is omega-3. That's what I'm saying कि ट्राइग्लिसराइड के बढ़े हुए तो आप omega-3 ऐड कर सकते हैं. I'll show you. So this is Ecosa tetraenoic acid and Docosa hexaenoic acid. These are omega-3, both of them. Thank you.
Thank you so much, Dr. Sabha. I conclude. Sir, I would like to call, please, Doctor, for the concluding remarks.
At the end, I think I have to thank you all who are still around here, resilient, and I can see ladies are more resilient than gents. Most of them are left. The ladies are still around and hanging around, so they are the tougher one. Thank you ever so much to all the organizers, my organizing team, Professor Rashid Saab, our care team and media team from the medical college, and Go Red team, I think, and thank you very much the media team of the hospital, and Colonel Bakar Saab, you have been resilient too, and I think it's heartening to have somebody with this title with us. And we've really enjoyed it, and thank you ever so much. And let me reassure you, this is not the last one. So we'll see you again in 2024, hopefully at better time of the year, as Professor Rashid Saab says, in March, hopefully, and we'll give out the date. And tea is ready. Tea and cookies. At least I'll have one cookie. Thank you so much. Thank you so much. Yes, certainly.